Okay, so why don't we go ahead and get started? So good morning, good afternoon, good evening, wherever you are. I am Dr. Akwi Bang, interventional gastroenterologist at Massachusetts General Hospital and the director of the Global Gastroenterology Program at MGH. As always, I am honored to be here, excited to have our speakers with us today. Absolutely excited to have them here. And I am just truly blessed and wanted to say a big, big thank you to all our speakers because it takes a lot understanding what their clinical obligations are. And it's a Saturday, it's a weekend, it's time to spend with family or time just really maybe even spend by yourself. But either way, you chose to spend this time with us today. And the reason we're here today is to talk about colorectal cancer. Colorectal cancer is a leading cause of cancer-related mortality, but colorectal cancer is preventable, it's beatable, it's treatable. And it's just super important for us to try and spread the knowledge about colorectal cancer. And the focus today is colorectal cancer in Africa, but what we have is a diverse group of speakers who will be talking about different things, some aspects of colorectal cancer that are universal, right? Everyone needs to have a bowel prep for a colonoscopy, irrespective of what continent you're in. A bowel prep is extremely important. Understanding risk factors, understanding what you can do to prevent colorectal cancer. And so those are some of the things we're going to be talking about today. The way the program has been set up is we are going to have three moderators. We have Dr. Jennifer Kizza-Brown, who's an internal medicine resident at Massachusetts General Hospital. She's also on the Global Health Pathway as part of her residency program. And she recently just came back from Zambia and will be returning towards the end of the month again. Our next moderator is Dr. Angelo Autiak, recently graduated from med school at Suez University in Egypt, and will be returning to South Sudan to continue and start his medical practice. He is also a Massachusetts General Hospital Global Gastroenterology volunteer and a POHER alum. So happy to have them both. And they both are the co-editors of our quarterly newsletter. And our third moderator is Dr. Segun Komolafe, who is a surgeon in Scotland. He is a moderator and a speaker today. He will be, and he'll present and say how he got the honor of doing both the moderating and speaking. But we've had the opportunity of working together for many, many years. I think our first time meeting was on a bus ride in Nigeria from Lagos to Ife. But he is also one of the surgeons who will be traveling with us to Zambia for our colorectal cancer in Africa workshop. So very, very excited to have these stellar moderators today. So we have four sessions. We'll have our first two speakers, what might end up being our first speaker, then we'll have a Q&A. So please feel free to drop your questions in the chat box or in the Q&A box, and the moderators will, we'll get those questions and ask our speakers. And then we do have breaks in between, so about 10 minutes breaks in between some of the sessions, an opportunity for you to get up and stretch. But please, take this opportunity to learn, to ask questions, and key point update is that this program is now CME eligible, and I am going to go ahead and share some slides um, for you to get credit for attending today. So let me start with the first slide. Hopefully you can you see my screen? Perfect. All right. So this is the second slide. And so you'd see there's a code. It's to the right of the screen. So make a note of that code or use that QR scanning bar in the bottom left for you to get credit. So there are two codes because the session has been broken up into two sections. So these are two different codes. So this is the first one for the CME program. And then this is the second code. So please make a note of the codes that you can use so you get credit for attending today's session. And once again, Just a reminder for those who are in Zambia, or those who want to travel in Zambia, we do have our workshop in colorectal cancer coming up. And this year, we've actually decided to focus on surgery and pathology. The theme being tissue is the issue. And so we have our surgeons who will be working out of Andola Teaching Hospital. And then we have our pathologists who'll be working out of University Teaching Hospital. So scan the codes once again to register. These are in-person sessions. So if you're interested, you're based in Zambia, you're outside Zambia and would like to join us in Zambia, you're absolutely more than welcome to join us. And so now going to our program, I will hand things over to our moderators. Our moderators will introduce the speakers. They'll read the bios of all the speakers before each session, and then we'll go from there. So once again, I would like to take this opportunity to say thank you to each and every individual who agreed to speak today. I'd like to take this opportunity to welcome you to this program, and I look forward to an interactive session. And to all our attendees, please feel free, use a chat box, use a Q&A box for any of your questions. And on that note, I will hand things over to our moderators who can introduce themselves and introduce the speakers. So one last key point, we are going to be strict with time, and we're trying to figure out like what the best way is. So we just decided we'll just yell at you at about 3 minutes. We'll turn the mics on and say you have 3 minutes to go, because we thought you might not be able to see the chat. So either you time yourself, or if you hear our polite voice just saying 3 minutes, just to give you a heads up, so we can maintain time and just be respectful of everyone's time. On that note, I will hand things over to our moderators to introduce the session. So once again, welcome to everyone, and look forward to interacting with you throughout the day. Thank you.
Excellent. Very excited to start us off for our first session. I feel I need no additional introduction of myself, given that Dr. Akwi Azumbeng gave an excellent introduction of me. I can go ahead and start by introducing our first speaker, the wonderful Dr. Harlan Rich, who will be talking about bowel preparation for colonoscopy in renal and cardiac patients. Dr. Harlan Rich is a gastroenterologist with Brown University Health Gastroenterology and an associate professor of medical science and medicine at the Warren Alpert Medical School of Brown University. He received a medical degree from Vagelos College of Physicians and Surgeons at Columbia University in New York. Dr. Rich completed an internal medicine internship and residency with Boston University at Boston City Hospital and a gastroenterology fellowship with the Warren Alpert Medical School. He is an award-winning practitioner and has presented at numerous conferences and collaborated on peer-reviewed research published in academic journals. Dr. Rich is a member of the American Gastroenterological Association, American College of Physicians, and the Massachusetts Medical Society. And so with that, I'd love to turn it over to Dr. Rich to present.
Well, thank you so much, and good morning, good afternoon, and good evening. Can you hear me okay? Okay, great. I am getting over a head cold, so hopefully I last through this. Let me share presentation. Minimize that, expand that. Let's see. Does that look good? Screen-wise? Wonderful. Okay. So thank you again, Akwi, for inviting me to participate in this incredibly important discussion this morning. Clearly, we're seeing rising rates of colorectal cancer in younger patients throughout the world, and building a knowledge and understanding and infrastructure and workflows to help try to get people at least tested when they're symptomatic and possibly screened at some point in the future is going to be important across the world. So I've done this talk before, and we'll go through some of the slides I've given before, and then we'll focus a little bit on renal and cardiac considerations. I have no financial disclosures. So again, we'll talk a little bit about the history of colonoscopy because we're going to talk about prep. We need to understand history of why we're doing this and the understanding of why we're screening for colon cancer. And then we'll talk about the importance and goals of bowel prep, a brief historical overview, the different types of preps and how they work, and complications with special considerations in renal and cardiac patients, and then a summary. So I will point out that a multi-society task force published this past year a very comprehensive document on bowel preparation. And I would suggest that those of you who haven't seen it, go look for it. It is referenced here. It's published in three of the American GI journals. And again, very, very comprehensive overview of bowel preparation, the data supporting it, and recommendations that are data-based. So I do reference that a bit throughout this talk. Just to go back to understanding, we have to doing preps. We have to understand being able to do colonoscopy. People started doing rigid sigmoidoscopy in the early 1800s, but it was really promoted at the end of the 1800s. It wasn't until 1963 that fiber optic sigmoidoscopes were introduced, and through the 60s, these were progressed in terms of being more flexible, more user-friendly. It wasn't until 1965 that a colonoscopy was performed, but the way they did this was passing a tube from mouth to anus and then a pulley system that was attached to a gastroscope that was then pulled back into the cecum. So I don't think I would ever want to go through that. The earliest flexible colonoscopes were first actually used in the late 60s, and longer scopes were introduced in the end of the 60s and early 70s, and the first video colonoscope was introduced in 1983. In terms of understanding colon cancer biology and why we're screening and why colonoscopy is useful in terms of, as Akwi said, potentially preventing colon cancer, there's been a development over the past century of an understanding of the biology of colon cancer. Most of this was originally done by Dukes at St. Mark's in London, where they demonstrated that colorectal cancers were associated with residual adenomatous tissue. And then in the 30s, they developed a staging system to show that better survival accompanied diagnosis at an earlier stage. The polyp cancer sequence was diagnosed actually by a radiologist at St. Mark's in 1974. And in 1984, Bert Vogelstein did amazing work showing that colon cancer really is a disease of genetic alterations that occur in sequence that lead to carcinogenesis. So colorectal cancer screening first came about in the 1940s when they started to do rigid sigmoidoscopies at the University of Minnesota. In the 1960s, they did a large-scale study at the Strang Clinic in New York and showed a 90% 5-year survival in those patients who were detected to have cancer. In the early 70s, they started to evaluate the role of guaiac fecal occult blood testing and reported beneficial results in 1993. In the entire decade of 1980 to 1990, the National Polyp Study was conducted, and they were able to start reporting out in 1993 a reduction in incidence of patients, colorectal cancer incidence in patients undergoing polypectomy. And then in 2012, a reduction in colorectal cancer mortality in patients undergoing colonoscopic polypectomy. So it's really been decades that this data has been developed, and an awareness and understanding of the ability to detect cancer early and to reduce mortality, and also by removing polyps to reduce colorectal rates. So if we're going to do colonoscopy, we need to have a good bowel preparation. If we have a good bowel preparation, we'll be able to visualize the entire colonic mucosa. Colon cancer cleansing or colon cleansing will allow to markedly increase the detection rate of advanced neoplasia. So there have been a variety of analyses. One study in the US, the ability to detect polyps less than a centimeter in size was significantly associated with a good preparation. And another multinational European study, the detection of polyps of any size was found to depend solely upon the quality of bowel cleansing. Now, we know that there are probably other factors in terms of the rate of withdrawal, the skill of the clinician, but clearly bowel prep plays a significant role. Bowel prep is also one of the major obstacles to patient compliance with screening. Most patients who refuse colonoscopy identify bowel prep as the most objectionable aspect because of the unpleasant taste, the side effects, dietary restrictions, and the interference with normal life. And the chat seems to be going crazy, so I'm just going to look at this for 1 second. Okay, these are just people saying hello. Um, Sorry. Okay, so what happens if we have a poor bowel prep? One audit in the United Kingdom showed that 1 in 5 incomplete colonoscopies or failures were caused by a poor bowel prep. And in France, 4% of procedures were incomplete, but a third of those were due to poor colon cleaning. If you have a poor bowel prep, it impacts the cost of colonoscopy, so it may increase the overall costs by 12 to 22%. It decreases physician efficiency. Patients may be required to pay additional co-pays for each examination, and they may be determined to be unnecessary, leaving the patient with a significant financial burden. Colonoscopy is said to be no longer cost effective if greater than 13% have to be repeated as a result of poor preps. There are medical legal risks related to improper performance of colonoscopy in the case of missed cancers, and the quality of the preparation may also impact the rate of complications. So, good preparation has numerous important factors in terms of doing a good quality colonoscopy safely. There are several independent predictors of inadequate colon preparation, and they include a later starting time, a failure to provide good preparation instructions or to follow those instructions, patients who are inpatients, patients who are constipated as the procedural indication, if they're using tricyclic antidepressants, which are anticholinergics and will slow colonic movement. Males tend to have a poor preparations, and a history of cirrhosis, stroke, or dementia are all associated with it. Use of psychotropics, opioids, obesity, diabetes, and Parkinson's play a role. And socioeconomic risks include male patients, single or widowed patients, patients with low health literacy, patients with language barriers, low household status and socioeconomic status, lower educational level, and minority status. I had slides at the end of this talk previously talking about navigation and a variety of factors that one needs to employ to try to manage these risks. I'm not going to speak about it today because of time, but I think it's very important that one is developing a colonoscopy program that one needs to understand who the patients are, to assess these potential risk factors, and to provide services and support, including written materials, pictures, and things that are easy to understand, and possibly navigation services to try to combat some of these problems that will potentially adversely affect the ability to do a good colonoscopy. So the ideal preparation for colonoscopy should empty the colon of fecal material, do so rapidly, not introduce macroscopic or histological alterations, be satisfactory to patients to take in terms of taste and volume. They need to be palatable and tolerable. They need to be safe, and they need to be affordable. And so there are a variety of preparation options. There are osmotic laxatives, including sodium phosphate, magnesium citrate, and mannitol. There are a variety of polyethylene glycol and polyethylene glycol with electrolyte solutions as a 4-liter preparation, or as 2 liters combined with a laxative or additional osmotic agent. In both of these cases, they can either be given as a single dose or split dose, and most of the recommendations now favor a split dose. And then there are stimulant laxatives, including senna, sodium picosulfate, and bisacodyl, that have all been used in conjunction or sometimes independently. Sodium phosphate has been around probably one of the longest preps, and it's probably one of the least expensive. So I'm going to spend a little time talking about it because it's also one that has probably the highest risks. These are low volume hyperosmotic solutions. So there was a product called Fleet's Phosphosoda that was a 45 milliliter dose that contained 5 grams of sodium and 17.8 grams of phosphate. So the osmolarity was 16,000 milliosmoles per liter. The tablet form required up to 40 tablets. And basically, these chemicals will osmotically draw water into the lumen. While this is happening, though, they can induce significant water and electrolyte shifts. They have to be diluted. They have to be accompanied by a significant amount of oral fluid intake, and there are a number of side effects, including nausea, vomiting, and abdominal pain and bloating. More importantly, and we'll talk about this again later, there are a number of well-described adverse events with these sodium phosphate preparations, including hypernatremia, hyperphosphatemia, hypokalemia, hypocalcemia, hypovolemia, acute phosphate nephropathy or nephrocalcinosis, and aphthous ulcerations of the colon. And so we'll mention it here and we'll talk about it again that these preps should be avoided in the elderly, people with congestive heart failure, liver or renal insufficiency, inflammatory bowel disease, poor gut motility, or other patients who may develop electrolyte or fluid imbalance. And they've actually been removed from a number of markets because of the safety profile. Oral sodium sulfate has a similar mechanism but does seem to have a slightly better safety profile. The workhorse of most of our preps are polyethylene glycol-based preps. These are synthetic, non-branched hydrophilic polymers of ethylene glycol. First synthesized in 1859, they were demonstrated to be non-absorbable in 1947, and they were actually useful in demonstrating the co-transport of sodium and glucose, which was then helpful in development of oral rehydration solution in Gatorade. Polyethylene glycol 3350 demonstrates a strong osmotic pressure across the small intestinal mucosa, which then can bring fluid into the lumen. And now around 1980, when people were trying to develop osmotically balanced sodium sulfate oral lavages, it was actually substituted for mannitol, which had been used previously. The problem with mannitol is that mannitol allowed for fermentation, and it yielded potentially explosive gases. And so there were a number of reports of people having bowel gas explosions with electrocautery. And so mannitol was diminished at that point when these reports came out. Um, the net loss of electrolytes in the rectal effluent was counteracted by adding potassium chloride and bicarbonate, so that the net absorption of water and electrolytes is near zero. So these are the polyethylene glycol electrolyte solutions. And the brand names that we see here in the US are Golightly or Colite, New Lightly or Trilite, and there are a number of other products throughout the world. I'll just mention the clotted gas explosions as it's interesting. A number of gases in the colon, but we know that hydrogen and methane can be produced and are combustible. And if you have non-absorbable sugars such as lactulose, mannitol, or sorbitol, or completely absorbed sugars like lactose or fructose, these can be produced by the colonic flora, and they may be present in combustible levels. So to have combustion, you need to have these gases. You need to have a combustive gas like oxygen and a heat source like electric cautery. These have not really been seen after the oral PEG electrolyte solution. So using CO2 may reduce the risk by removing the oxygen in the air. And there's a Italian study that says that if you have good exchange, good cleansing and air exchange, it might reduce the risk as well. So mannitol, again, very inexpensive. It can be effective, but has these significant risks. So the standard 4 liter or liter PEG or polyethylene glycol electrolyte-based formulation is fast, safe, and effective. Compliance, though, is poor because the volume is very large. Some of these formulations have a salty taste or a sulfur odor, and about 5 to 15% of patients don't complete the preparation. If you split the dose, it's equally or at least more effective. Common side effects include nausea, vomiting, abdominal fullness, and bloating. They don't typically cause substantial fluid and electrolyte shift. So as we go through the renal and cardiac concerns, these become our much safer preparations to use. They're also preferable for patients with previous poor preparation. And as I said, it's much safer than osmotic laxatives and sodium phosphate laxatives for patients with electrolyte or fluid imbalance, renal or liver insufficiency, congestive heart failure, or liver failure. The stimulant laxatives include bisacodyl, magnesium citrate. Magnesium citrate is a hyperosmotic purgative, which also releases CCK, which stimulates water and electrolyte secretion. Again, magnesium, people become hypermagnesiemic if they have renal dysfunction, so it needs to be avoided in those situations. Sodium picosulfate and magnesium citrate, which we'll abbreviate as SPMC throughout. It adds a stimulant laxative plus the size hyperosmotic purgative. Brand name would be Picolax, for example, in the UK. Again, very effective, but contraindicated in patients with chronic kidney disease, can cause dehydration, electrolyte disturbances, including hypermagnesemia. There are other combinations, including sodium picosulfate, magnesium oxide, and anhydrous citric acid, and or potassium chloride, Klingpik and Sutab. There's another prep called Suprep, which is a similar combination of sodium sulfate, magnesium sulfate, and potassium sulfate. And then people have used 2 liters of polyethylene glycol with Senna. Senna is an anthraquinone derivative, which has a direct effect on intestinal mucosa and increases the rate of colonic motility, enhancing transit, and inhibits water and electrolyte secretion. And people have even used high-dose Senna alone, but it tends to be associated with more abdominal pain. So what most people are shifting to is low volume PEG with another agent. What's been described and been very effective has been PEG plus bisacodyl, PEG plus magnesium citrate, or PEG plus ascorbic acid. And as I'll show you, these all have different efficacies, but these tend to be better tolerated and as effective as these larger preparations. So when we think about adverse events during bowel preparation, A number of significant adverse events have been reported. This is one study of over 9,000 patients where some type of medical intervention was required. And again, people have developed bowel obstruction, bleeding, rectal prolapse, allergic reactions, tetany, problems with their blood sugar control, strokes, blood pressure alterations, pulmonary embolism, ischemia, arrhythmias, hemorrhages and epistaxis, bone fractures, which sounds a little odd, but if you have loss of consciousness and fainting, you might fall and break something. Impaired consciousness with head injury, dizziness and balance disorders, and dyspepsia, vomiting, and colicky stomach ache. So we'll talk about hypovolemia first. If one is using something like the oral sodium preparation, you can lose upwards of 2 liters of hypotonic fluid, which can lead to dehydration, volume depletion, and hypernatremia. This may also precipitate acute kidney injury or acute tubular necrosis. And there are a number of comorbidities which may precipitate hypovolemia, including pre-existing diarrhea, vomiting, dysphagia, hyperglycemia, or diuretic use. And so one needs to be aware of these things if one is going to administer a bowel prep. Typically, if you're going to give intravenous fluid replacement, you want to use an isotonic electrolyte mixed fluid, such as a lactated Ringer's. And patients typically should continue fluid intake up to 2 hours before the colonoscopy. When we think about bowel preparations and dietary intake and stuff, we don't want people having anything solid for at least 6 hours and no fluids for at least 2 hours. But many of the recommendations suggest fluid intake until about 2 hours before the colonoscopy. With the SPMC, or the oral sodium phosphate, isotonic electrolyte oral rehydration solutions should be taken to prevent hyponatremia rather than plain water. Obviously, these are electrolyte balanced, and plain water may just exacerbate hyponatremia. So the oral sodium preps, again, have a number of electrolyte disorders which are well described. Hyperphosphatemia related to the oral phosphate load, hypocalcemia related to the hyperphosphatemia, and people have developed tetanic contractions if their calcium levels drop low enough. Hypokalemia related to GI and renal potassium losses, hypernatremia related to the oral sodium load, and hyponatremia related to excess water intake around the prep. Severe symptomatic hyponatremia has been described. It's actually more common with the PEG colonoscopy preparations because these oral sodium preps are giving a sodium load. There's an increased risk with older age, use of thiazide diuretics and SSRIs, and those with renal and heart failure. So patients who have risk factors should be monitored and treated promptly in the event of adverse events to prevent permanent neurologic sequelae. The worst case scenario is people have described osmotic demyelinating syndrome or central pontine myelinolysis in these cases. Acute phosphate nephropathy is associated with the oral sodium phosphate preparations, and there are a number of risk factors. And again, these are leading to contraindications for the use of these agents, being over 55, having pre-existing hypovolemia or baseline kidney disease, bowel obstruction, active colitis, and patients using drugs that affect renal function, such as diuretics, angiotensin-converting enzyme inhibitors, or ACE, angiotensin receptor blockers, or ARBs, and nonsteroidal anti-inflammatory agents. Absolute contraindications to the oral sodium preparations are pregnancy, being very young, having later stage chronic renal disease, inability to maintain an adequate fluid intake, pre-existing electrolyte disturbances, ascites, CHF, prolonged QT interval, recent ischemic heart disease. Other contraindications include pre-existing hyperphosphatemia, clinically significant cirrhosis or ascites, bowel obstruction, megacolon perforation, ileus, and relative contraindications include active inflammatory bowel disease, parathyroidectomy, and delayed bowel transit. So I think what I'm trying to tell you here is that there are numerous risks associated with these drugs, and you have to be very careful in terms of who you select to receive them. Just to show you the difference between the polyethylene glycol-based preps and the oral sodium phosphate-based preps, the sodium phosphate have rates up to 37% of having electrolyte disorders, whereas the high-volume PEG preps have much lower incidences of hypokalemia, hyponatremia, hyperphosphatemia, and hypocalcemia. But again, these are real electrolyte disturbances in both settings. There are 2 patterns of kidney injury that have been described after bowel preparation with oral sodium phosphate for colonoscopy. The first is an earlier symptomatic, which is usually due to acute electrolyte shifts Patients may develop hyperphosphatemia and hypocalcemia and present with lethargy, confusion, seizures, and even tetany. The basic way to treat these is with intravenous fluids, oral phosphate binders if they're hyperphosphatemic, intravenous calcium gluconate if they're hypocalcemic, and/or hemodialysis. And the recovery is not guaranteed. Patients can develop chronic kidney disease after this, or even death has been reported. More concerning is this later insidious development of renal failure or renal injury, and these patients can present asymptomatically. They will develop over time nephrocalcinosis, which is really related to the intratubular calcium phosphate deposition. Hydroxyapatite is the other name for it. And these patients will develop a chronic kidney disease. So that has been described with these oral sodium phosphate preps as well.
Just a 2-minute warning, Dr. Rich.
2 minutes, okay. So the awareness of kidney function should inform the choice of bowel preps. With chronic kidney disease, we should avoid oral sodium phosphate. Mild kidney disease, PEG or sodium picosulfate, magnesium citrate may be acceptable. Patients with advanced chronic kidney disease should be prescribed the PEG electrolyte. SPMC have a risk of hypermagnesemia in patients with kidney disease, and PEG may expand intravascular volume, so we need to adjust the dialysis schedule, usually dialyzing the night before or the morning of the procedure and being prepared to dialyze afterward. These patients can develop AV fistula thrombosis, and we need to avoid intravascular volume depletion in peritoneal dialysis patients to avoid deteriorating the renal function further. ACE inhibitors, ARB, diuretics, and NSAIDs should ideally be discontinued on the morning of administration and for a few days afterward to reduce the risk. PEG is advisable in diuretic patients, and diuretics should be considered to be discontinued, but again, you have to look at their fluid status carefully. And again, maintaining proper hydration is important. Heart failure can be accompanied by risk of oral acute sodium phosphate nephropathy, and so patients with heart failure should avoid these drugs. Again, PEG is the best oral bowel prep for these patients, but they can lead to increased intravascular volume in patients with diuretics. So the PEG electrolyte solutions should be avoided with heart failure. Patients physiological and able to compensate for an acute change in intravascular volume are the ones likely to have an increase in plasma volume. And again, they talk about patients continuing their cardiac medications during the bowel prep, but what gets a little iffy is whether the ACE inhibitors and the RB should be continued. We don't want to run into patients developing failure as a result of adjusting their medications or hypertension. So it's a very difficult line to cross. Bowel prep has been associated with atrial fibrillation, particularly in patients over age 50. Other arrhythmias include atrial tachycardia and flutter. There are a number of comorbidities that have been described, including hypertension, hyperlipidemia, diabetes, and ischemic heart disease. And many of these patients have underlying structural heart disease like dilated atria, left ventricular hypertrophy, and heart failure. I won't go into the various changes in resting potential, but there may be factors in the prep that will lead to these things. And there are a number of post-procedure cardiac complications that one needs to be aware of. Angina, myocardial infarction, stroke. So appropriate monitoring before, during, and after the procedure may reduce the risk of these complications. Bradycardia, atrial premature contractions, and VPCs have been documented, and rare cases of VTAC and cardiac arrest have been reported. Again, we do see that there are patients undergoing colonoscopy who have development of ischemia, and these may be risk factors. So take-home points. An optimum colonoscopy requires an optimum bowel prep. Split-dose oral preps optimize bowel cleaning. Significant renal and cardiac complications may occur, often associated with pre-existing conditions, and this means that pre-procedure planning and risk assessment is of the utmost importance. We should be avoiding the oral sodium phosphate preps in renal and cardiac patients. We need to be aware of the degree of underlying renal dysfunction and further tailor the prep as appropriate. Adjust drugs which increase the risk of adverse outcomes. Balance electrolyte preps and hydration may reduce metabolic complications. We need to be aware of the underlying structural or functional heart disease and tailor the preps and monitor for evidence of hypovolemia or fluid overload, and also be aware of post-prep and post-procedure complications. As I said, the Multi-Society Task Force has a number of recommendations. They actually don't talk so much about renal failure or cardiac disease in this very comprehensive paper, but I do commend it for information about preps overall. And with that, I will stop.
Excellent. Thank you very much, Dr. Rich. And I will introduce our next speaker, and then we'll save time for Q&A. I know there are lots of excellent questions waiting for you already. And so I have the pleasure of introducing our second speaker, Dr. Aparna Parikh. She is an associate professor of medicine at Harvard Medical School and a gastrointestinal oncologist at the MGH Cancer Center. She leads the colorectal medical oncology research and young adults colorectal cancer programs and is internationally renowned for her expertise on gastrointestinal cancers and work in liquid biopsy and ctDNA. She is the co-founder and CEO/chief scientist of Reversing Early Recurrence and serves as director of the MGH Global Cancer Care Program and co-director of the GI Cancer Program at the MGB Cancer Institute. Dr. Parikh is a respected clinician, researcher, and advocate for equitable cancer care work.
Great. Thanks so much for having me. Good afternoon to everyone. Really nice to see some familiar names and faces. Let me just pull up my slides here. Sorry about that. All right, let's. Do I have sharing privileges? It's saying need
You
access. I'm
should.
okay.
Let me just make you a co-host if that makes a difference. So I just made you a co-host and if that changes, but it should allow multiple shares. Let me know if that works for you.
Okay. There we go. That works. Can you see my screen now?
Yes, perfect.
Perfect.
Just,
All right.
presenter mode and then you're all set. Perfect.
Okay,
Thank
great.
you.
All right, so thanks for having me again. And my talk today is really around this kind of challenge and emerging epidemic of early onset colorectal cancer, and how we might start to think about these patients a little bit differently. So here, so I think to just level set, and these are U.S. based numbers, but suffice it to say, we're really starting to see this trend happening globally, especially in more kind of westernization, more countries that are becoming more and more westernized, and particularly with dietary habits and lifestyle changes. So when you look at the most recent 2026 numbers, I think consistently for colorectal cancer and both in men and women, it has been in the top three malignancies for both men and women for quite some time. I think what is really unsettling, though, is that as of just 2026 number, colorectal cancer is the leading cause of death, cancer-related death in men and women under 50. Last year it was in men, and now has suppressed breast cancer in terms of being a leading cause of cancer mortality in women as well. So I think top three incidents overall, top three mortality overall, but again, number one now, cancer-related killer in men and women. So I think really, really alarming in terms of the trends that we've seen over the last couple of decades. And when you look at colorectal cancer incidence by age, again, the median age of diagnosis is still 66 in the United States. But when you look at, again, the age group in which we're seeing this tremendous percentage of new cases, it's about 15% in that age group of 45 to 55. One of the other interesting, I think, epidemiological features of colorectal cancer in young patients is that it tends to have more of a rectal proclivity in terms of that rise in incidence. So when you look at all colorectal cancer, it's around 30 to 32% of colorectal cancers are about rectal cancers. And this has been pretty stable. But when you look at early onset colorectal cancer in particular, it's about 40 to 50% of early onset colorectal cancer. So the rectal cancers are really kind of driving that surge. And again, here is just the kind of annual change that you're seeing over the last couple of decades when you look at incidence rates of colon cancer by age compared with, again, here on the left, the incidence in 2020 to the incidence now. And what you can see is the steepest slope in that age group of 20 to 35. Also 35 to 49. But I think this blue curve, blue and yellow curves is, I think, what is really keeping many of us up at night in terms of why this is happening. There's been, over the last several years, there's actually been, I think, some data describing what is happening in Africa as well for colorectal cancer. This was a pooled analysis of many studies published in one of the Lancet e-journals. And if you look at, again, about 40 some studies, when you look at the pooled proportion of cases, it's about 38% of colorectal cancer patients diagnosed in the African subcontinent tend to be in the younger group. And so as I showed you in the previous slide, in the US, you're still hovering in that median age range in the 60s, but the mean age, they didn't report a median here. The mean age in colorectal cancer in Africa from this series was 53.5. So perhaps, demographically, even a lower shift that is happening in African patients. When you look at colorectal cancer, the stage of diagnosis, and again, this is a US data, I think what we see in many lower and middle income countries is a flip entirely of this curve. And here the stage distribution, because of screening, and the screening age in the United States is now 45. We have a relatively distributed stage distribution where we are catching actually many patients in the earlier stage disease. And again, this is all comers. This is not necessarily looking at younger patients. And about 20% of patients having stage 4 disease at diagnosis here. And when you look at data from LMICs, it's almost opposite, right? It's around 20% of patients are probably getting diagnosed with early stage disease, and 70 to 80% of patients are getting diagnosed with later stage disease. It won't be surprising to this audience here, but why is this important? And I think, like you see with many other cancers, 5-year survival drops off substantially, across the stages. I think even with chemotherapy use. So this is a figure that I think is just giving you some insight into the complexity of, what is driving this. So even just this morning was asked by a media outlet, like, what is the one single factor that is driving young onset colorectal cancer? And I think the problem is there's not one single risk factor. I think we're really recognizing and trying to understand a little bit more what is the interplay of the host and risk factors that are driving this. And so when I like to think about it, I think, there's some modifiable risk factors that are well known: obesity, processed foods, heavy red meat diet, Western dietary patterns. I think physical activity. I think the reason fiber and activity, I think, is good is, again, it promotes colonic motility. And I think moving things through the bowel, you get that less chronic inflammation, especially of, perhaps what is actually in the stool, alcohol consumption, tobacco use. And then there's the non-modifiable but established risk factors such as family history, IBD, age, obviously risk increases, but again, noting that rising incidence. And then we see, here we see higher rates in African Americans and Native Americans, and others. And then what is emerging, and I think this is where we're really trying to hone in on this young problem, is what is happening with the gut microbiome, and is it early antibiotic exposure in lifetime, or even in utero exposure, that might be causing some dysbiosis and mediating inflammatory changes in the microbiota. Again, I mentioned the Western diet patterns with the ultra-processed foods, corn syrups, I think likely hypothesized to impact metabolic health. And then I think emerging data perhaps on environmental exposures like microplastics and PFAS chemicals and how these may be kind of pro-inflammatory. So, it's really this interplay of factors that is driving this. And I think in contexts where there's no established universal screening, I think if we can really start to understand what is a risk profile, are there ways to better tailor who should get screened? And that's actually a study that we have going on in India right now in a couple of different large states that we're seeing one state that has very high colorectal cancer incidence, another state that's low, and trying to do aggressive lifestyle and dietary questionnaires and symptom assessments to see if we could figure out a risk profile that you might want to offer more tailored screening towards. And then, of course, I think key symptoms you all know, but I think the challenge with these key symptoms in younger patients is change in bowel habits, weight loss, rectal bleeding. Many of our patients that come in, they're active, they're running, they're stressed, they're at peak of their child rearing ages. So I've had, many athletes that just think it's because they've been they're, running a lot, and that's why they're getting blood in their stool. Women that are anemic, have had children, and their anemia is attributed to menses and, other things too. So I think really paying attention to symptoms in younger patients and not just dismissing it. There's data, it's about a year for younger patients before they actually come to presentation to oncology with their diagnosis of describing symptoms before they're actually diagnosed. So there can be a substantial delay because these symptoms are often attributed to other things. And again, this whole idea of multifactorial risk, I think there's this idea of the expososome, and again, early lifestyle environmental exposures on the microbiome in in particularly. So, what are some of these early life exposures that are being explored? What is how does breastfeeding in utero, mode of delivery? What is happening to the mother at the time of pregnancy, antibiotic use again early in life, maternal infections, and then all of these other exposing events and elements in our lifestyle, and do these early kind of chronic insults over a course of a lifetime alter the inflammatory milieu and microbiome in the gut, ultimately leading to those chronic inflammatory states, just like obesity and diabetes, that can drive early onset colorectal cancer. So in terms of molecular differences, this is some data that just shows are there molecular differences in colorectal cancer. This is a large kind of data set of both MSS and MSI high colorectal cancers. And what you can see for the MSS, not a lot of kind of big differences across the MSS patients. I think for the MSI high patients, not surprisingly, you can see the higher BRAF associated with more sporadic MSI high, more MLH1 associated with Lynch. So again, there are some distinguishing features, but that being said, I think it's important to note that in young onset colorectal cancer, the far majority of cases are actually sporadic and not germline attributable. And when you look at the MSI high differences and specifically the, again, overall MSI high rate, again, not surprisingly, a little bit higher in young onset colorectal cancer, again, germline for the patients that have Lynch, and very rare BRAF mutations, whereas that's very common as a sporadic driver in older patients. In the MSI high setting, in younger patients, we tend to see right-sided tumors, if they're Lynch, but again, as I mentioned, heavy on the sporadic cases being left-sided and rectal. And then the gender predominance in the younger patients for MSI high is roughly equal in older onset colorectal cancer, especially in the elderly, skews towards more female. So how has colorectal cancer treatment sort of changed? And I think why are some of these changes that are happening perhaps even more relevant to younger patients? And with that, we'll start with just rectal cancer as a use case. And this is not a talk on management of rectal cancer, but I think there's a couple of kind of unique things that have happened in the field over the last 5 to 10 years that I think particularly for younger patients might be relevant. So this idea of non-operative management really, I think, really has shifted the field of rectal cancer. And so why does non-operative management perhaps matter more in a young patient? And again, this idea of moving towards personalization for every patient. So not every rectal cancer is the same. I think there's various ways to stratify locally advanced rectal cancers, and location of rectal cancers dictates the local recurrence risk, and obviously the MSI, MSS status. And then not all the goals of therapy are same. So when we used to give tri-modality therapy for every patient, chemotherapy, surgery, radiotherapy, we knew we had impacts on quality of life and bowel function, fertility, sexual health, and obviously sphincter preservation. And when you look at a younger patient, right, they have decades of survivorship ahead of them. So the advantage of non-operative management, they have function preserved for 40 plus years, versus maybe less time as you're older. Your fertility window is key in your youngers. You can avoid pelvic radiation. You don't need ovarian transposition, for example. Non-operative management also from a career family perspective, more rapid recovery rather than a longer term recovery with surgical procedures. And then obviously the psychosocial impact. And again, not to say that psychosocial impact is not important on our average risk or average age colorectal cancer patients, but there tends to be a higher kind of stigma in young adults, and depression rates in younger adults is about three times higher.
Just
So
a
that
2-minute warning, Dr. Perk.
Oh, okay. So yeah, I'll just kind of skip through a couple of these slides just quickly, but suffice it to say, I think this movement towards organ preservation has really become important in rectal cancer, particularly. So both for MSS disease, where you can give induction chemoradiotherapy and then chemotherapy. And what you can see here is no impact on disease-free survival by doing neoadjuvant therapy rather than how we used to do it with chemoradiation surgery and then adjuvant chemotherapy. Immunotherapy also really important in this setting. I think tremendous data from MSK with dostarlimab giving just a few doses with 100% complete responses. And I've been really interested in dosing strategies for immunotherapy, and particularly in low and middle income countries. And I'm happy to talk about some studies that we have ongoing in that space as well. I think finally, the last thing is just the survivorship piece. I think what's next, surveillance, germline testing for all, tremendous data now around exercise, 7% disease-free survival benefit with exercise, and especially in younger patients, and you can get them moving after a diagnosis, I think clearly lends itself to improved outcomes. And that's all I have. Thank you so much.
Thank you so much for 2 excellent presentations. We'll leave about 10 minutes now for some questions. And so I have been getting lots of excellent questions from the chat. I can start with a conglomerative theme of questions for you, Dr. Rich, and really surrounding the idea of this change in time that's needed for bowel prep. So one of the questions was that in our setting, some patients report significant fatigue after 2 days of bowel preparation. What strategies can we use to improve patient tolerance? And along that same framework, another participant had asked, has the bowel prep over a period of 2 to 3 days now become obsolete? With some patients, I have seen it enables better bowel preparation and reduction of complications associated with the acute 1-day preparation. So if you'd like to address those 2 questions.
Sure. I mean, I think we're trying to avoid 2 and 3 day preparations. Now, again, the caveat being that one might alter diet for a few days beforehand. So there's fairly good data suggesting that a low residue diet may play an important role in a good cleansing regimen. And so I think most people are not trying to prep the patient for 2 or 3 days, but maybe do some dietary alterations. And we do provide lists of what low residue diet foods are. Again, there are parts of the world where fiber makes up a tremendous amount of the diet, and so sometimes that's not easy to achieve. But trying to limit the preparation to that, 12 to 24-hour window before. The only places where we're really seeing these longer, more extensive preps are in patients who've had a previous colonoscopy with a poor prep, and perhaps patients who have underlying significant risk factors. So patients with severe constipation, I find patients with Parkinson's very, very difficult to prep. And those are patients where we may do a more extensive, real formal 2 day preparation with 2 days of cathartics and things. In terms of the fatigue and lethargy, I think using oral electrolyte solution rehydration is probably the best way to approach that. But yeah, and trying to do an actual preparation over 2 or 3 days with chemicals is, I think, not indicated for most patients.
Thanks very much. And Dr. Parikh, a question that has come in for you. One of the participants says that in my setting, where antibiotics are frequently used without prescription, could this influence the rising incidence of early onset colorectal cancer? What evidence currently supports the association between antibiotic exposure and colorectal cancer risk?
Yeah, great question. And I think there is definitely data that I think overuse. I think in sort of our generation where kind of antibiotics are kind of thrown at everything, that the antibiotics might be actually just changing the constituency of the microbiome. And I think we're starting to understand, which particular gut microbiota may be protective and which may be linked towards colorectal cancer. And so the idea of the antibiotics is really that there's this dysbiosis and a kind of change in that balance of what might be protective and what might be harmful, kind of microbiota and that chronic antibiotic use. And I think we don't exactly know what is chronic. So how much antibiotics, what is that critical amount that might be needed to, or is changing the microbiome. But I think we do know that, as you alluded to, I think in this generation of patients that are getting early onset colorectal cancer, we did see a lot more kind of antibiotic use in this generation, even as young kids. So, I can't tell you exactly how much, but I think in general, I think antibiotic stewardship is probably a good thing. I think across the board, and so maybe other reasons beyond just antimicrobial resistance, that antibiotic stewardship is going to be helpful long term.
Excellent. And back to you, Dr. Rich. There were some questions around types of prep used. So two specific questions were, is there any role in the use of castor oil in bowel preparation for CKD patients? And another question as to the use of lactulose for renal or heart failure patients.
So in terms of the castor oil, it has been studied over decades. I mean, it's an ancient agent. It's a stimulant laxative, basically. It's converted in the bowel to a renoleic acid or something like that, which is a stimulant laxative. I think the biggest problem with castor oil is that it's poorly tolerated. Patients tend to develop a lot of abdominal pain, cramping, nausea, vomiting. And as a stimulant laxative, it is going to potentially contribute to the same types of electrolyte disturbances. So I don't know that it's necessarily any safer. It certainly doesn't have, FDA testing behind it from on the U.S. perspective, where one would say this is an FDA approved regimen. It poorly tolerated. It's very inexpensive, which makes it very nice to be able to use. And I think if one were to try to use it again, one would probably want the patient hydrating with a balanced electrolyte solution, so an oral rehydration type solution, to try to at least reduce the risk of dehydration and electrolyte disturbances. The second part was about lactulose. Again, lactulose is osmotically acting agent. Again, it can suck fluid in. It can lead to fluid shifts. It's not to say it can't be used, but again, one needs to be aware of the possibility of causing hyponatremia, hypokalemia, and so on. And again, lactulose is one of the agents that potentially can be metabolized by microbiota to cause explosive gases. So if one is using lactulose, one needs to make sure there's adequate air exchange, perhaps use CO2 when one is insufflating and so on.
Very helpful. And a question for you, Dr. Parikh. There is a request to kindly elaborate more on the surveillance for colorectal cancer regarding circulating tumor DNA. Has that been standardized in the guidelines, and what's your take on it? In the event of circulating tumor cells, but no rise in CEA and no evidence of disease on imaging, what would you do?
So this is a topic that's kind of very near and dear to my heart and spend a lot of time thinking about. So I think to answer your question, long story short, the answer is currently no. So it is not yet in the guidelines for surveillance. I think undoubtedly ctDNA detectability in the blood is the most powerful prognostic feature. It really trumps any TNM staging, and I think there's a movement in the field to really think about the clinical pathological staging and including ctDNA to prognosticate. But in terms of using it to inform therapeutic decision making outside of a clinical trial, no. So if you're positive, all you really do is you might just scan a little bit earlier, and we don't know that scanning more actually, and actually some data that has already shown out of Europe that more frequent scans don't actually change outcomes either. So prognostic, but not yet standardized in the guidelines here. That being said, I'm optimistic in the sense that I think there will be therapies that if you are persistently positive after adjuvant chemotherapy, there may be therapies that can still be offered to allow cures. And I think my hope for particularly, I think LMIC type of context is as the tests get better, can we use ctDNA to risk stratify who does not need treatment? So for de-escalation purposes, but as of today, no.
Extremely helpful. And I can give one more question to both of you before we pivot to our next session. After our next session, there will be a break. So Dr. Rich, another question that came in was regarding the combustibility that you mentioned. There was a request to clarify further if that means that the bowel can explode during a colonoscopy, and in what circumstances that could happen. Is it related to poor bowel prep, etc.?
So again, the combustion is related to certain gases, methane in particular, and hydrogen that might be produced. These are going to be produced particularly when you're using sugars that are poorly digestible and are broken down by the gut microbiota. And again, it's not going to be a spontaneous explosion. It's typically associated with electric cautery. My mentor once was using a rigid sigmoidoscope and burned off his eyebrows when he was using electric cautery. So again, avoiding these non-absorbable sugars is probably one of the best ways to do that. Being aware of the possibility of an explosion with electric cautery, using CO2 might reduce the risk. Again, using cold snare as opposed to hot snare may be one way to reduce the risk. And again, it's rare, but it's well described, so I think it's of interest.
Fantastic. And a last question for you, Dr. Parikh. Is there any risk stratification tool for colorectal cancer screening in average risk individuals less than 45? From your experience, how do you decide who to recommend screening in the absence of family history? And I think to add to this excellent question, for example, we often have patients with LDLs that are super elevated and are 27, and yet we say statin still makes sense. I think in a similar framework, are there any times that you might say, here's where we extrapolate from what, USPTF tells us today, and here's why?
Unfortunately now, and I think that's the $1 million question right now is who, if that's what we all want to figure out is who under 45 should we be screening in the absence of any risk factors. And I think unfortunately now it's just symptom driven. And again, I always explain to patients here, when it's symptom driven, it's no longer screening, it's a diagnostic colonoscopy. So if you're having symptoms, you're not sending them to get a fit test, right? You're getting your diagnostic colo. So great question. And I hope in the next decade, we'll maybe even sooner, we'll be able to figure that out.
But I agree. I think being awareness of symptoms and acting on them much earlier than we typically do. You pointed out this year-long lag and so on. So if somebody's coming to me who's 30 years old with rectal bleeding, I'm doing a colonoscopy. I'm not just running off to.
Yeah, exactly. Yeah, exactly.
Oh, well, I wish we had time for more questions because there are many trickling in. So I imagine folks may be reaching out to you guys for more advice and wisdom. But to protect the time of our next speakers, I'll pivot to our next section. So I'll introduce our two speakers, give them both an opportunity to present, and then we'll save time for question and answer, followed by a break. So I have the wonderful pleasure of introducing our next two speakers. So our first is Dr. Ganyant Oyeleke. She is a consultant physician, gastroenterologist, and hepatologist at Gastroderm Clinic, Lekki, Lagos, Nigeria. She graduated from the University of Ilorin Medical School in 1995 and received the Internal Medicine Fellowship of the National Postgraduate Medical College of Nigeria in 2009. She served as a consultant at General Hospital Broad Street from 2010 through 2015 and at a Lagos University Teaching Hospital from 2015 through March 2025. She was director of the World Gastroenterology Organization Lagos Training Center. Dr. Oyeleke has published and presented widely on liver and gastrointestinal disorders. She is an examiner for the National Postgraduate Medical College of Nigeria, vice chair of the WGO Training Center Committee, and member of the WGO Endoscopy Committee. She's a director of the Viral Hepatitis Lagos Echo Clinic and currently serves as president of the African Association of Future Gastroenterologists. She'll be presenting on risk factors for colorectal cancer, population age, or gender differences. And afterwards, we'll have the pleasure of hearing from both presenter and moderator, Dr. Segun Komolafe. He is a general and colorectal surgeon at University Hospital Wishaw near Glasgow and former NHS Lanarkshire clinical lead for colorectal cancer. He studied medicine at the University of Glasgow, graduating in 1999, and completed an intercalated BSc in parasitology. He trained in general surgery in the west of Scotland, specializing in colorectal surgery, and undertook a laparoscopic fellowship at Barretos Cancer Hospital in Sao Paulo, Brazil. He was appointed consultant in Wishaw in 2012 and completed robotic surgery training in 2021. His practice includes laparoscopic and robotic surgery for benign and malignant colorectal disease, emergency general surgery, and therapeutic endoscopy. He is an active member of the NHS Scotland Global Citizenship Program and contributes to global surgical training in Brazil, Malawi, and Nigeria. He is also a former college tutor of the Royal College of Physicians and Surgeons of Glasgow and serves as honorary clinical senior lecturer at the University of Glasgow. He'll be presenting on multidisciplinary teams, definitions, setup, and challenges. And so with that, I'll first turn it over to Dr. Oyeleke.
I'm trying to share my slides. Just 1 minute. Yes. Okay. Can you see my slide? Sorry. Okay, thanks. So good afternoon and good morning, everyone. And thanks, Jennifer, for the kind introduction. So I'm taking the risk factors for colorectal cancer, population, age, and gender differences. And I must say the earlier speaker had made my presentation a bit easier because I think she also dwelled a bit on the risk factors. So we know colorectal cancer, so this is just a brief introduction, one of the leading causes of cancer, and she clearly stated that now it's the topmost cause of death, particularly in men and women under 50. So this is the global outlook of colorectal cancer, and you can see the Western world, the incidences, the age and dies in incidence per 100,000 is much higher. And this is Africa, where we belong less than 4.9 per 100,000. Some have said, well, it could be higher. It's probably because we have a lot of underreporting. The burden in Africa, as stated, new cases about over 70, deaths about 46 per 100,000. The highest incidence from studies have been reported in North Africa, followed by East Africa. But we know that other African countries are reporting high incidences as well. CRC is the top 4 most diagnosed cancer in 56% of African countries, and the mortality and incidences are higher in males. It's projected that new cases may reach about over 168,000 in 2050, and deaths will be over 110,000. So we go to the risk factors, and I grouped them as non-modifiable and the ones you can modify: the age, the gender, the race, genetic or hereditary conditions, and family history, particularly in first-degree relatives. The geographical variation occurs across African regions, and colorectal cancer incidences vary significantly from one country to another. And the highest, like I said earlier, is been reported in the northern parts. The lowest incidences in Central Africa, and the differences are likely linked to dietary and lifestyle changes, increasing urbanization, healthcare access, availability of screening for colorectal cancer, particularly availability of colonoscopy equipment. Some countries have been reporting higher incidences as well. In Nigeria, where I practice, Egypt, South Africa, Morocco, and even Ethiopia. So this is just to show the age standardized incidence in different African countries. And as stated, you can see from Algeria to Sierra Leone with very low levels. But we're concerned whether these are real low levels or we have gross underreporting in these areas. Studies have talked about the changing epidemiology and the fact that there is an increasing incidence of colorectal cancer in Africa compared to what we were taught back then when we were in medical school some years back. And the key drivers to this could be change in diets. The westernized diet is now on everyone's table now. There's increased consumption of highly processed food. There's increased physical inactivity and obesity. And also people are living older. The population is aging more than it used to be. And the fact that we're able to make the diagnosis in some areas, unlike before where diagnostic facilities were not available. So this is just a study by Ayii et al. On the burden and the trend of colorectal cancer. And they found that about 58,000 new cases are diagnosed yearly. In terms of age as the risk factor, it's the strongest risk factor for colorectal cancer, and we see them in older adults, and they're typically about 50 years or older. And we know that the highest incidence and mortality occur in a slightly older age group of 60 to 69 year group. But we're seeing younger people with CRC as well, which we'll still discuss later on. So these are the age incidences, the age to the gender relationship between different groups. So you can see the incidence higher as the age continues up to the 60 to 65 age, so 60 to 69 age group, then there's a rapid fall. But what is also concerning is the incidence of CRC in the younger age group. The early onset colorectal cancer, which the previous speaker also clearly mentioned, is the fact that we're seeing an increasing number of younger age group, less than 40, with colorectal cancer. Approximately, a study has shown approximately 21% of cases before the age of 40, and about 38% even before the age of 50. And what could explain this could it be genetic predisposition? She also elaborated environmental exposures of microplastics and all, or delayed diagnosis. You know, most people with rectal bleed would rather think it's just hemorrhoids, or they'll find an excuse for it. But these are causing delayed diagnosis. Then, of course, we have limited screening programs, and the screening programs are actually not designed for the younger age group. So these may be other features responsible. A study compared was a descriptive epidemiology of age at colorectal cancer diagnosis in Africa. And what they found was that, of course, what we talked about, younger age group, and the fact that patients may need to go for opportunity screening, because waiting for the standard period that we screen may be a bit too late for some of them, particularly the ones that have the familiar tendency to developing CRC, or if they have symptoms, like we said earlier. In terms of the gender differences, the male to female ratio has been said to vary from 1.3 to 1 to 1.6 to 1 in some studies. And similarly, continent-wide data indicate that both the incidence and mortality rates are higher in males. And the reasons postulated for this could be because men tend to have greater exposure to CRC risk factors like smoking, alcohol consumption, high red meat intake, or even occupational exposure. The female hormone estrogen has also been found to kind of have a protective effect against colorectal carcinogen. So this is a study by Virginie et al. Then we move to the non-modifiable risk. Studies also have shown that the familial or genetic hereditary predisposition, as we see in Lynch syndrome, non-familial adenomatous polyposis, or even juvenile polyposis, tend to progress. There's a common and well-known risk factors. So these are some of this polyposis syndrome, even seen in very young age group. I know recently in the Lagos University Teaching Hospital, a pediatric gastro reported cases of juvenile polyposis, which was strange because we thought we didn't have so much of this kind of situation in our environment. So we need to do more procedures, and we may start to see more of these conditions. Inflammatory bowel disease is also a condition that we're seeing a lot more now. So these are conditions that could be like precursor and increase the risk to colorectal cancer. The modifiable risk factors, obesity, she already discussed that, the previous speaker, sedentary lifestyle, smoking, and you can see the ultra-processed and westernized diets, and of course, barbecuing and grilling in open fire or flame, so we have to be very careful. This is a common practice in many African countries as well. So we have the risk as well, and we need to be careful with this. A scoping review of about 25 studies from 2011 to 2021 shows that dietary behaviors, particularly frequent consumption of red meats, ultra-processed meat, or sugar-sweetened beverages, and high-fat meals are consistently correlated with elevated CRC risk. And this was further enhanced, particularly when you now grill in or pan fry in open fire. And so these tend to increase the carcinogen level and could result in colorectal cancer. Different other studies from different parts of Africa corroborated this as well. Studies from Nigeria, from the Southern Africa, and from Zambia as well. Another study also discussing the incidence and risk factors for colorectal cancer in Africa. Appeared to be significantly associated and increasing the risk of CRC in Africa. A large-scale prospective study of over 500 women in the UK found alcohol and processed meat intake as enhancers, and in the same study found calcium supplements or calcium in dairy products to have some protective effects and reduces the risk in about 70% in that study. So the interaction of population, age, and gender, this combined effect can be the main driver, increasing the incidence among patients, men showing higher incidence and mortality than women, and earlier age and onset compared with the Western population, which is quite worrisome for us. And additionally, rapid urbanization and dietary transitions are contributing to rising CRC incidence in several African countries. And it's been projected that these incidences will be even higher in by 2050 if we do not do something to the current trend. And the implication of this is really huge. And the increased burden of the colorectal cancer in Africa would require that we improve screening program. We need to increase public awareness. We need to ensure that we're able to diagnose colorectal cancer earlier and treat earlier as well. We have to strengthen our cancer registry. That is still challenging because some countries do not even have the incident rates. We have to promote healthy lifestyle, avoid sedentary, eat well, diet and exercise. Early detection strategies such as colonoscopy or FIT tests could significantly reduce CRC mortality across the African population. And in conclusion, CRC in Africa shows distinct epidemiological characteristics influenced by the diversity of the age, the gender, ethnicity, geographical location, and the mortality and incidences are increasing. Age remains the strongest risk factor, but we're seeing them in the younger age group, and we need to really address this and do something, increasing awareness. Men have a higher CRC incidence than women, and a substantial population of patients with CRC, like I said, will present earlier compared to the Western population. and we have to address these risk factors. This is critical in improving cancer prevention, screening, and control strategies in Africa. Thank you very much. I hope this is clear enough. And the floor is open now, I think. Oh, no, I think there's another presenter before the question and answer. Thank you very much for listening.
Thank you so much, Dr. Oyeleke, for that excellent presentation. And exactly, we'll now transition to Dr. Komolafe, and then after his presentation, we'll have a Q&A for both of you. Keep putting those questions in the chat, and please take it away, Dr. Komolafe.
Thank you. I'm going to try to share my screen if I can. Share. Let me know what you're seeing. Are you seeing the PowerPoint?
Not the PowerPoint yet. That's the PDF of the presentation slides right now, or the PowerPoint, or the PDF of the presenters.
Okay, let me try again. Share. There you go. That better?
Perfect.
Okay, let me just minimize the chat. Minimize that. And so just in terms of full disclosure, I'm not Mukhtar. I am deputizing for my colleague, Dr. Ahmad, who is tied up at work. No disclosures apart from I'm not Mukhtar. And what we'll try and do today in the next 20 or so minutes is just talk through the role of an MDT. What does a good MDT look like? How can we streamline MDT? Some discussion around standards of care in MDT working, a quick overview of staging. Because of time constraint, we won't have time to go through case scenarios. And then we can review very quickly some barriers to efficient MDT functioning and strategies to try to deal with them, and then talk a little bit at the end about how we monitor our MDT performance. Very quick summary. This is a slide that I always find interesting to think through. I'm drinking a hot water and honey mix right now. I drink a lot of honey. And so it's interesting to think that a bee produces roughly a 1/12 of a teaspoon of honey in its entire life. And so many, many, many bees, hundreds, thousands of bees go into my daily honey, lemon, and ginger drink that I have every day. But it makes the point that good outcomes requires teamwork. Many of us in the African context will understand this picture instantly. It's a soldier, we call them soldier ants in Nigeria, working together to bridge a gap where there is a need to get and sometimes carry heavy things across big gaps by working together again as a team, and everyone sacrifices their individuality for the greater good. I'm always slightly, I often think it's a misnomer to describe some MDTs as benign MDTs, because if you have inflammatory bowel disease or pelvic floor dysfunction or complex anal canal problems, then they don't feel benign to the patient. But we know, or many of us will participate in many of these different kinds of MDTs. MDT, of course, to clarify, is multidisciplinary team. So there are a variety of MDTs, and of course, we also participate in cancer MDTs. In the UK, around about probably 15 or so years ago, it became mandatory for any patient with a malignant process to be managed in the context of an MDT within the NHS, the National Health Service, but also even in the private sector. So in the private hospital where I work, if you're going to request a list of patient for a procedure and it's for a cancer diagnosis, you must state as part of your booking request in the private sector the MDT process that's led you to agreeing to put that patient on. All the words which you maybe can see in the background here are different things that different people focus on in the context of an MDT. So, we as surgeons throw anatomical jargon around like gonadals, the ureter, close to vesicles. The oncologist will talk about fall 3, fall fox, fall 3 inox, none of which I understand. Radiologists talk about T2 weighted imaging, diffusion, etc., etc., etc. But the point is that everybody brings different things to the MDT. We try and define and have shared language, we have agreed terminology, and then we work together in a way that everybody can be on the same page. And there is no individual um, agenda, but we're working together to complement each other. This can be a typical kind of MDT setup, certainly in the UK, in your average hospital. And we understand that in the, say, the Nigerian or African context, all of these facilities or expertise may not and will not be readily available. However, it is important to have a mindset that says that patients require or may require input from all these different kinds of specialties to have the best of care. Um, and that's ranging from the colorectal surgeon, liver surgeon, research nurse, stomach care, palliative nurse specialist, gastroenterologist, clinical oncology, medical oncology separately in the UK. And then CNS, nurse specialist, pathologist, tissue is always the issue, and then radiology, which is crucial to work out your staging. Um, in the UK, when I've given this talk before, I've even given that same diagram, but placed at the center of the picture, the hub, which is the patient. And then next to the patient is the cancer nurse specialist, because the cancer nurse specialist is often the person that the patients and their family will have the most contact with. They will be the person that patients will talk to me, for example, and then they will phone the nurses up and say, can I just double check this thing that I heard, this thing that I've seen? They might phone up to say, I've had this letter come through the post. What does it actually mean? So CNSs are crucial. This is a typical kind of UK MDT in a hospital, oncologist, clinical oncologist, radiologist. Now, everyone won't always be there. And one of the things that's important to clarify for different MDTs is what is your actual quorum? When does your MDT become quorate? If I log on to my MDT, which on a Friday morning, and there are 3 colorectal surgeons and 1 radiologist and 3 nurses, then that probably is not a quorate MDT, because we haven't got pathology, we haven't got oncology, we haven't got clinical oncology. So it's important to try and clarify what will make your MDT quorate. And if you're in an environment where you don't have all the specialties and specializations, what sorts of things can you put in place to try and make sure that all the different specialties or specialty input or knowledge can be put into your MDT to help you to make the best decision for your patient? Almost MDTs now, particularly since the pandemic, meet virtually. The advantages, the challenges are internet availability. It's not always readily available, even here in the UK. Sometimes we struggle to get the problems with the internet, bandwidth, and then coordinating meeting with people. When we used to have a rule in my MDT that everyone has to have the camera on, but we've lost that now, because in reality, people's cameras can be distracting if people are obviously not paying attention. But the benefits are that it does allow people to participate who are offside. You can record the meeting, you can chat as we are doing today without disrupting things too much. And we haven't put this here, but another really important thing with the recording virtual MDTs is that you can now have an AI summary of the MDT meeting. What is the role of the MDT? We want to try and establish treatment protocols for colorectal cancer. We want to define rules for members. We want to agree how we work and governance. We want to discuss every diagnosis of colorectal cancer and come up with a trick and recommend a treatment plan. And it's important to state that an MDT always acts in an advisory capacity. Ultimately, the patient, along with the clinician, should be able to assess all the information and make a decision about managing the patient that the patient is happy with and makes sense. And the MDT should help advisory. I've just got a flag that my internet connection is unstable. So if there is a problem, please let me know. And streamline MDT, this is actually very a hot topic in my MDT right now because we are being overwhelmed with referrals and we are debating what's the best way to try to streamline the process. But you need to have a referral process of some sort, something that is structured, captures all the information you need without too much information, but then also gives the clear question for why you're discussing or rediscussing patients. You have to be flexible to allow to discuss the more complex patients, and the more straightforward cases should really only be discussed for noting. So someone's got a right colon cancer, the CT shows no distant metastasis, the patient is fit, they need right hemicolectomy. That's just one you should note for argument's sake. Clicking forward. And then the checklist for discussion. One of our MDT issues can be someone is presented for discussion, but their quote's not ready yet. So if someone hasn't got the right histology, then you need to go back for more histology. Someone hasn't got the right, hasn't been staged with a CT scan yet. For rectal cancer, for anal cancer, has an MRI been done? For rectal cancer, for example, do they need to have an endorectal ultrasound scan to supplement your assessment of the depth of the tumor? For colon cancer, do you need to have a PET scan? If anybody has a question about a liver metastases in any of our in colorectal cancers, they always get a liver MRI and a PET scan. So if there's a liver mets, don't bring them for discussion without the MRI and the PET scan. For anal cancer in particular, is it a squamous cell carcinoma or an adenocarcinoma? Because how you manage those will be crucial. Again, this is making the same points again. Documentation, MDT standards, so standard of care for patients who are straightforward. And this is also things that we can do. And again, every MDT will find their own particular way of doing this. But essentially, for anal cancer, for example, what you found, examination of the anus, examination of the groins for groin nodes, any tissue that you have, any MRI, PET, CT scan, and then you classify the patient as in its local disease, local regional disease, metastatic disease. And then what you do will determine how you manage the patient. But the argument for these kinds of algorithms is that if you simplify things and have algorithms, and by and large, you will have a system for processing your patients, which is consistent and reproducible rather than having an ad hoc process for every patient you manage. As we've mentioned, we need to leave time for complex discussions. So early rectal cancer, there are here literally 7 different options for how to manage an early rectal cancer. Recurrent rectal cancer, people with advanced disease as multifocal, and people with large polyps, large benign precancerous polyps, or large polyps that may have a focus of invasion. We can't prove or disprove that. How do you manage those? So we actually, as well as our cancer MDT, where I work in Lanarkshire, we have a separate complex polyp MDT for these patients. I don't need to go over staging of cancer, and I won't go over it for time. The only thing to say is that the new American AJCC classification of the TNM9 has been released recently. So some of the lymph node status has been kind of modified. So it's worth just go online and find that out for yourself, TNM9, and the slight changes to lymph node status that have come out recently. Again, I won't labor that. I won't labor that for the sake of time. And again, why do we have MDTs? Because actually, when I talk to my patients and tell them why they need to go to an MDT, this is what I tell them. I say, when I'm treating your bowel cancer, although I'm the surgeon, and there are literally 5 different ways of treating bowel cancer, and also the non-treatment option, which some patients choose. And all I know about, and I say this tongue in cheek to my patients, ultimately, as the surgeon, I am just a glorified plumber. The gut is a tube, and I'm a plumber, and there's bits of the tube that I can remove, and that's my expertise. However, there's chemotherapy, radiotherapy, immunotherapy, ablative therapy in some types of lesions, and not in bowel cancer, but in breast cancer, for example, ovarian cancer, there's hormone therapy. So because my expertise is limited, I need a team to make a team decision. I won't go through cases for the sake of time. I'm just going to skip these forward. If you want to discuss MDT cases, then I would encourage you to come to our meeting in Zambia if you can the next week, or get involved in some of that, because that's when we have a chance to discuss these patients. Skipping forwards. Barriers to MDT practice. Resource, time. Many places we've gone to within the African context and said, you guys don't have an MDT, why don't you try and set up an MDT? And there just isn't time. And I understand that. And the reason we have MDTs in the UK is because the government mandated and then released money 15, 20 years ago that anybody managing cancer and all patients with cancer have to be managed with an MDT. So about 15, 20 years ago, there was a rejigging of how many clinicians in the UK worked to make time for MDTs. And now we're trying to do, for example, I call it complex polyp MDT. We struggle to find time for that. And many of us do it as an extra because we deem that it's important, but time is a resource that everyone wrestles with. Specialists, and I get it, and I understand, again, in our African context, this can be difficult. And I guess the benefit, if you like, of having internet and discussions online is it's possible to have access to specialties internationally or out of the region or within the country who can advise how to manage patients. But again, it's about a mindset, because in the African context, where many patients are paying out of pocket, if they don't have the best and the correct treatment the first time, have to have a second or a third operation, for argument's sake, it's that patient who is paying. And we know that in the African context, from WHO data, that having to have major healthcare interventions is financially ruinous for a significant proportion of Africans. So it's important to try and have a process that means that people who are paying with money they don't really have the best care at the start. Again, these are interprofessional rivalries. This hopefully shouldn't be a thing, but we know that we are human beings and this can be a problem. Very definitely, we have seen this. I've come across this sometimes in my own work life, where there are rivalries between, professors. You've got the oncology professor and you've got the surgical professor who don't like each other. And so because of that, I don't know if you can still hear me. I've put my headphones in because some ambient background noise. Because of interprofessional rivalries between the professor of surgery and the professor of oncology, all of a sudden you can't have an MDT because the two departments don't speak. So these are the kinds of things that you just have to get past for the sake of the patient. This is an example of the problem we have with the skills and the specialties resource. This is Kano in Nigeria. We had our African colorectal cancer meeting 2 years ago now, with 2 oncologists for a population of 20,000. The UK has a population of about 60 million now, sorry. Kano has a population of 20 million. And you can see the huge discrepancy between the population of Dorset, where Mukhtar Ahmed lives and works, with 7 oncologists for a population of 700,000, and 2 oncologists for a population of 20 million. So this is real. But the advantage of things like the internet is exchange programs, virtual MDTs, MDT guidelines. These are things that we can try and do with intentionality to try and overcome barriers to MDT working. International collaborations, these are some of the ones that we know about. For example, Cameroon to Leeds, Malawi to Edinburgh, many of these which support working across international borders. Finally, performance monitoring. It's important that we audit reports, and all surgeons should know their mortalities, their leak rates, their permanent stoma rates, etc., etc., etc. In the UK, there is a mandatory requirement to audit these things, and I know I manage patients with inflammatory bowel disease and also cancer, and we have lots of audit and reporting around cancer, but nothing really around IBD, and it's always quite staggering, because when you have audit process and you look for outcomes, that then drives an improvement in care inevitably, because standards are set which you have to meet. And I would encourage all of us in our institutions individually or in collaboratives with our local, in our towns or states or regions, to have a think about, if we don't already, audit, reporting, and then peer review. And then finally, patient feedback. Patient feedback is so important. We're not always good at this as clinicians, but it's important to always have eyes on what the patient thinks, how they're receiving what we're giving them, and what they think of the service they're getting. These are the things that you need to record for your MDT. It's important to have somebody in MDT who writes things down. Ideally, that should be a dedicated admin type person who can note things down with input and support from clinicians. But you want to be in the habit of capturing your data so that you can then look at that as you review what you're doing in your outcomes. We try to, and actually where I work, have a quarterly meeting for education where we'll just spend a whole day looking at our outcomes for the past quarter, any specific mortality and morbidity, any new guidelines, any new evidence, any new emerging evidence, etc., etc., etc. So to summarize all of that, we should try and have a clear criteria for MDT discussion, clear documentation of outcomes, clarity about what we want MDT to be about and what makes our MDT correlate. We should have standards of care for common conditions. We should really have a culture of reporting what we find and determine what the key performance indicators are, leak rates, etc. And then we should aim to try and collaborate locally, regionally, or internationally to fill gaps in expertise. Thank you for your time. This is a picture of the south coast of England near where Murta works. Thanks for your time. That's all I have to say. We're now open, I believe, for questions.
That's right. Excellent presentations. Dr. Oyeleke and Dr. Komolafe will now take the many questions that are coming in for your response. Dr. Oyeleke, I can start with you. A question that was posed is if there are any differences between early onset and late, quote unquote, onset colorectal cancer in tumor behavior, long-term outcomes, or in any specific way.
Thank you very much for the question. Excellent question. So the challenge with early onset is because most times it's not picked up early. And at that time, patients will present very late when it's really advanced and it's almost inoperable. So that's the thing. And so it's in terms of the progression, it may not really be different, but because the presentation is late, then that makes it really worse in terms of the outcome. I hope this answers the question.
Excellent answer. And I'm sure if there are clarifying questions, they'll come in the chat for us. Dr. Komolafe, I can pose the next question to you. There was an inquiry as to whether the MDT has to choose a single reference guideline, such as NCCN or ESMO, to use. And along those lines, how do you manage fundamental differences in what might be considered the optimal treatment process from the MDT?
Thank you for that question, Dr. Aderiwigbe. In terms of do you have to choose an optical? You don't have to choose a single reference guide. So it depends on your particular context. So we in the UK where I work will often reference signed guidelines, or we can reference 3 different guidelines, okay, in the UK for argument's sake. And this is the point. We have our signed guidelines, which is just an intercollegiate guidelines. We have an ACP-GBI guideline, which is colorectal guidelines, that's surgical. We have BSG guidelines, that's kind of more gastroenterology. We also have oncology guidelines. So you don't have to reference any individual guideline. And what's useful is to have an idea of emerging evidence and what the consensus of the various guidelines is. So, for example, in rectal cancer, a lot of European and some American guidelines is very much around kind of non-operative management of rectal cancer and pushing to avoid surgery. But I know that where I work in my local context, a lot of the emphasis tends to be on surgery for rectal cancer. And so we often have this tension of local guidelines versus international practice. And I think what's better for you as a clinician is to have an understanding of the various guidelines and be able to kind of synthesize all of those to try and always do what's best for the patient. Always accepting that an MDT is almost always an advisory process anyway. And what you should always be presenting to the patient who's at the center of decision making is this is the options, this is what our MDT recommends. What do we agree to do together? What do you want? And sometimes some patients always remember will often choose no intervention sometimes. Atypically. So it's always about the um giving the option to the patients, but being aware of different guidelines, definitely. And I don't, your question, how do we manage fundamental differences in optimal treatment process from the MDT? I'm not really sure what to mean about the theory. The theory of an MDT process is that if you don't have, alphas who tell everybody what to do, then theoretically, if everyone is looking at the same scientific evidence and you're looking at the patient's performance status, then you should hopefully be arriving like a funnel at the same sorts of conclusions. The reality in the real world, and I know this when I was a registrar, there was a professor of surgery who told everyone what to do for every patient. And it wasn't really an MDT, it was the prof telling everyone what to do for the patient. And I think that it's in those kinds of scenarios that you tend to have big variations in outcomes from MDT. When you have alphas who tell everyone what you should and should do. So I would be saying that if that's your MDT context, then that can be tricky to manage, and that can be difficult in the context where you have to respect your elders, etc., etc.
Sounds like being open, adaptable, and collaborative is key. So that makes a lot of sense. And I can pivot back to Dr. Oyeleke for another question. You did touch upon this during your presentation in mentioning hormonal exposures, differences in behavioral practices, but one of the participants was curious to just extrapolate further on any explanation as to why colorectal cancer is found more often in men than in women.
Okay, so I think I touched on this briefly, the fact that men often have greater exposure to environmental factors like smoking, alcohol consumption, the red meat consumption, and exposure to occupational like microplastics and all, much more than the women. And the fact that the hormonal protection that the woman gets from estrogen also helps to reduce, guards against the carcinogens kind of sort of in colorectal cancer. So I think that's majorly the reason why they tend to have more male to more incidences in men than women.
Thanks very much. And back to your Dr. Komolafe, I'll combine these two questions. They're somewhat of logistic pieces. One was a curiosity question as to why there is no oncology pharmacist as a part of your MDT, and if you've thought about that addition. And another is just logistically how long a case should usually be discussed during an MDT.
Yeah, so in terms of our MDT is open to anyone and everyone. The issue with an pharmacy oncologist is just time. They're often too busy to come and sit in a 3-hour MDT every week because they're busy. And if you think of the fact that if we're going to discuss 25 patients in MDT and only 2 are relevant to the oncology pharmacist, then it's not always the best use of their time. But we definitely recognize that it's good for, even, we don't have palliative input in my MDT, for example, whereas they often bring a different perspective on a patient and what to do for patients. So for many of the specialties, it's often just time, and that's why it's important for your own MDT to determine what makes your MDT quotient. You need to have pathology, radiology, oncology, clin-onc, med-onc, ideally both, or a nurse, etc., admin person. So every MDT will have what it needs. There is a superfluity of other things you would like to have. We'd like to have a liver surgeon every week, but we can't have one, for example. So all these things are things you have to determine according to your MDTs and your institution. What was the second part of the question? Sorry, I missed the second part of the question.
Oh, no, that's okay.
How
It's
was it?
just how long the
Oh, yes. Yeah.
yep.
So the standard of care is a good one. Surgeons, as I'm demonstrating, like to talk a lot. So if you can try to limit if someone's obvious, like as a stage one, stage two rectal bowel colon cancer needs surgery, it should not be one that takes a lot of discussion. Someone's 8 to 9 year old with liver mets, lung mets, shouldn't need a lot of discussion, just registration. The ones, and that will allow you to discuss the patient, the young fertile female with lower third rectal cancer who is also 3 months pregnant. Those kinds of patients that are complicated, you need to have more time for them. Um, and so there is no fixed time, I would say, but try to work out very quickly what's the cohort of patients you don't need to discuss at length, and have an algorithm that's safe that they can be processed through and record that.
Excellent. Dr. Oyeleke, back to you for a question. You have raised excellent points about so many of these modifiable risk factors and general risk factors that we're becoming very aware of for colorectal cancer. And I'm just curious to hear your thoughts on practices towards disseminating that information throughout the continent of Africa, maybe any initiatives that you already are a part of or are doing that you'd like to share with the group.
Sorry, can you take the last part again?
Oh, sure. Yes. Just any initiatives that are already in practice to try to disseminate information about these risk factors, to try to raise awareness, maybe any practices that you're already doing, or any advice or thoughts you might have for best ways to do this.
Right. Thank you very much. So, what is obvious is the fact that the awareness on colorectal cancer is very, very low. I did a study recently on a small community in Lagos, just to ask them round on. It was my thesis for my master's like 2 years ago. And the number of patients who, not patients really, the population, they are completely not aware of what's colorectal cancer. And I think we need to do more on this. Already we're doing something, but I think we need to do it on a large scale. We have pockets of people giving awareness talks and NGOs coming around to talk. And some even doing colonoscopy screening or the stool test. But I think we need to expand more on this awareness. We have to raise awareness. Hopefully, this is also part of the raising awareness, which is, the webinar really. But aside with just in the medical family, we have to extend it to the general population. That's one. So the awareness for the population, even awareness for the doctors, because in Nigeria, there's something usually once they have blood in stool, people just feel it's because my stool was hard yesterday or hard last week and all that. And we've seen quite a number of people having years of bloody stool and not doing much about it until it becomes too late. The other thing is also letting people know that they need to present early, and not take on other alternative medicine, because, so people will typically use some other maybe herbal medication, thinking, oh, it helps to protect. So we need to do a lot more talk. We need to educate our people more. We need to educate the doctors more so that they can refer them earlier. So we're doing a bit of this in different associations, in different organizations. In Nigeria, we have a society for hepatology and gastroenterology in Nigeria. So we do awareness talks. And I know in Africa, we have the AAFG, we have POHER, we have different countries with different organizations giving talks and raising awareness about colorectal cancer. So I think we need to leverage more on all this and do much more. And also build capacity. The levels of the endoscopy is not where we want it to be. So we need to improve that in terms of the equipment and even the personnel. We don't have many gastroenterologists or colorectal surgeons or even pathologists. So we need to build capacity to make the diagnosis, to confirm the diagnosis, and to do the surgical maneuver that it's necessary. So these are the things. Already we have some ongoing, but we're not there yet. So we're hoping that we're able to build up on what we have already, and hopefully that would help to reduce the incidences. Thank you.
Yeah, very, very eloquently said. Definitely lots of work to be done, but we're lucky to have the efforts that you're already making. And Dr. Komolafe, I saw that you already addressed a bit of this in the chat, but
Yeah.
kind of a combined question that came in. You had mentioned in your presentation that you have a discussion checklist that you often require that we think through before a patient is presented to the MDT.
Yeah.
And as you're very aware, some hospitals don't have the resources to do all the steps that are in that checklist. And so just curious to hear how you navigate cases where, the complexity is that the checklist can't be done and we have to find a way to support this patient.
Yeah.
And I can add that to the question that was already posed in the chat that you've responded to and give you a space to respond to the whole group verbally.
Yeah, so the first question about what kind of patients do you discuss is a live one where I work right now because our MDT is being overwhelmed right now. We're struggling to get through all our patients. And we've tried triaging. So all the list of names for the MDT, someone goes through them the day before, 2 days before, and then we'll just say, a third of the patients are not being discussed because that scan's not ready, that path isn't ready, the patient actually hasn't got proven cancer yet, to go back and get more tissue. And that's one and that's one approach, but that then can become militant where you start being borderline unhelpful. I don't really have a neat answer to that because I suspect that every institution will have its own unique situation. And I don't like to give a glib answer like just saying it depends on leadership, etc. But that's almost what you need to do is have a little bit of understanding of your own particular clinical context, have an understanding of your own specialty and what's available and how much time you have, and then try to off that work out what's reasonable. So we are struggling in my MDT right now to try to balance the increasing burden of work with the fact that no one has more time. In fact, everyone's busier, but we're trying to do more work and process more patients in our MDT in the same time, 2 hours on a Friday morning, 8:30 till 10:30. So we're trying different approaches, and I think that's the issue. But the issue around that is going to be leadership and understanding of what needs to happen, or what you need to change or tweak to try and be helpful. But the important thing about the African context, this wasn't my presentation, so I didn't get to kind of put this in. But one of my big things about the African context is that the WHO published, and this is available on the website, there's really clear evidence that for something like 30%, 25 to 30% of Africans in sub-Saharan Africa who have to have a healthcare intervention, that single healthcare intervention is financially ruinous for them because they have to borrow, they have to save, they have to get surgery and they miss work for 2, 3 months and they don't have social services to kind of pay them. So for 1 out of 3 Africans, for argument's sake, having to have a right hemicolectomy for cancer or an anterior resection for cancer is financially ruinous. Now, you do an operation in the patient, and it actually turns out that because they haven't been staged properly, they've had an anterior resection for rectal cancer, the margins are not clear. So, and actually, they never got a CT scan before their operation, so they've got a liver met. So they've now had surgery. They're now not be able to work for 2 or 3 months. They've now got a liver met that potentially has been missed because they never got an MRI, and then they have local recurrence in 12 months later and need more surgery with money they don't have. And so the African context is particularly unique in that because healthcare is so expensive and people are paying for themselves, we almost have a greater pressure to get the right decision for the patient the first time. And there is this thing called GIRF, to get it right first time. And particularly in a context where you have private clinicians or private surgeons or who are seeing people without an MDT setup, and if I decide to operate on you, that means I get paid. So there's an immediate conflict of interest. And I know many, the vast majority of people are good people and are not unscrupulous, but very definitely in our in our African resource limited context, MDT process or an MDT mindset is even more important because the patients that we are treating have so much more to lose because the healthcare process is being paid for by them, and 30% can't afford what they're paying for. And so we almost have a greater obligation in that context to try to find ways to make sure that what we're doing for the average African patient is hopefully the best thing for them the first time. And I think the issue with MDT working and having multi-specialty input into your patient care is that that will mean that you probably will make a better decision. And I think it's that kind of mindset that's really important for us in an African context.
Thank you for expanding and applying very, very appropriately to our panel topics. I will pose one more question that was raised to Dr. Oyeleke and then end with the question that was raised to both of you. Dr. Oyeleke, these two questions are somewhat connected. So the first is there a correlation between the genetic make of Africans and the new adopted westernized diet? The second is, beyond the influence of westernized diet that are increasingly adopted in many African countries, is there evidence that some traditional African dietary patterns themselves may also act as a modifiable risk factor for colorectal cancer or other gastrointestinal diseases? Additionally, what practical steps can individuals and communities take to address dietary risks while still preserving cultural food practices? I know those were very long questions, so happy to reiterate them in steps as you answer them.
All right, thank you very much. Excellent question. So, yes, I think some of our food, the way we prepare them, could also be potentially the high risk group, particularly high consumption of like charred food and charred meats or smoked food. I know in Nigeria we take a lot of smoked fish, suya, which is like roasted barbecued meats and all that. So, but the smoking and barbecuing or deep frying can also be something that could increase the risk. And also, yeah, I know that most of our food tend to be plant-based, but we know that some areas in some parts of Africa, they like their red meat as well. So, yeah, and the meat is processed in a certain way, maybe not the westernized way, but even the way that is being processed as well could increase the risk. Some would keep meat salted for a while and hang it, so there are different ways in different parts of the world, of Africa, that even that on its own. Then also, I know that even reusing cooking oil, which is, because people can't afford to throw oils that they've used to fry food away because of the economic situation in some aspects, so, and deep frying food, we love our small chops in Nigeria, for example, which is, you have to deep fry puff puff and all this. So yes, if these practices are done consistently for repeatedly, it could also result into an increased risk. And what are the practical steps to reduce this risk would be to increase our fiber. So we have our legumes, all those beans and all that. So we need to increase the consumption of vegetable, millet, sorghum. We have all those that are fiber-rich, yam, cassava. Then the living greens, we have different types. We need to increase that and limit consumption of all the bad ones that I mentioned, the overcharred, the smoked ones, the excessively processed meats. And also, instead of doing that, then we can steam our food, we can boil or we can stew them, and also I think, changing the way we cook our food would also help. And in terms of, also educating each other, because some people they just didn't know, so if I don't know that eating suya every day could cause me trouble and I like it, and now I know, then I can change my way. So that can help to, change the behavior and make things easier. typical Niger street food is fried this or grilled this and all that. So we have to make sure that we cook it in a healthier way that would also support our lifestyle and all that. The second question is on whether there's a correlation between our gene and our new adopted Western. So I think there's been a lot of talk about that, but I haven't been able to lay my hands on proper studies to, but I know there's been some suggestion that, maybe genetic variation in Africa would tend to, we're wired for the high fiber. Then when we now move to Westernize, it's like a drastic change or shift in our food, and that can cause some kind of imbalance and all that. But like I said, I don't have proper studies on that, but I've read about having the a life or diet transition kind of, or dietary transition that can predispose Africans to the rapid change in the diet. So the other thing is also the role of the gut microbiome, which I think the previous speaker before me also discussed. That has also been elaborated, and that promoting healthy beneficial bacteria and all that can protect the colon. So maybe if we put all this together, that would. So the rapid change, yes, in the transition, maybe the fact that the gene, the diet or the gene is wired for the high fiber, which I mean, like I said, it's still a lot of talk on it, and I haven't seen many papers to actually confirm this. So, but it is a possibility, but there is no. It's not like, I'm not sure there's any identifiable African genetic risk at the moment, honestly. So I don't know if anybody has something else to add on. All right. Thank you very much. I hope this is okay.
Yep, excellently answered. Definitely an emerging field for research. And yeah, I can end on our last question that was raised. If both of you would like to comment, please do. But it's in reference to a publication from our very own Dr. Asenbang et al. With a recent paper on Africa pancreatobiliary cancer registry creation. There was a request for both of you to comment on the role of consultants and MDTs in generating and contributing to cancer registries, particularly with regards to longitudinal centralized collection of relevant data.
So I can speak to that very quickly from a UK point of view, which is that we have dedicated team of people who collect all the data. And what they do every 3 months is they circulate the data they have for the past quarter to all the outcomes, to all the clinicians relevant, and say, this is the data we have on your patient. Can you just double check that everything is accurate? The reality, and hopefully this is not condescending, is that many clinicians are really too busy to be putting Excel spreadsheets and dates together, and you almost need to accept you need to have people who are good at collecting data. But what's important is that whatever data is being collected, there is some clinical oversight over that, because input equals output, and if the data in your database isn't really good, or registry isn't accurate, the outcomes you will derive will be inaccurate. So I would say that there just needs to be a mindset of getting people who can collect the data. The clinicians and or the government mandate the data you need to collect, and then there has to be regular clinical oversight of the data, which hopefully collect prospectively as you go along. Dr. Oyeleke can tell us her thoughts.
Thank you. Thank you, Segun. Okay, so I think it will be a different approach for us, because in most hospitals, we don't have a proper data department. I think some hospitals in Africa have that, but so most times it's actually also the doctors doing that themselves. And as you know, we're short-staffed, there's a lot of workload and all. So it's actually just to, encourage the consultants, if you are the ones doing that, to make sure you have the diagnosis is accurate, you put the proper documentation, or you hand it over when you have people that are doing that. Make sure that you have supports the follow-up information. Everything is the treatment outcome. If there's documents the recurrence or survival, if you're able to do that. In some situations, if you have, like, I know we're involved in a research group that had a lot of funding. They were able to get the backup of all the data people that will help us to properly document, but not all the hospitals have all this. So it's left to the consultants or the doctors to put all this up themselves. So I don't know. It's a different approach. Yes.
I think another thing that might help in the African context is that whilst you may not have an admin team to collect data, if there is a culture of using readily available pro formas for all your cancer care, then it makes aggregation of data easier. So, for example, there is a readily available online ESGAR, European Society of Geradiologists, for reporting MRIs of the rectum. The Royal College of Pathologists has pro formas for reporting specimen in rectal cancers or colon cancer. Surgical bodies in the UK often put out templates. In fact, there are established templates in the UK of operation notes you should be using. And so if we, in the absence of audit and audit staff, if individuals and institutions, and this is something local HODs can do or students can introduce to the seniors, is to say, why don't we start using this particular formula or pro forma for operation notes, for endoscopy reports, for if you use this pro forma, it means that whenever you come to try and look at your data, you will almost certainly have most of the requisite data available that has been recorded at the time in real time, and it will make a retrospective review easier. And I think that may be a necessary compromise in the absence of established audit teams or admin staff. That kind of way of working, of having pro formas for op notes, path reports, gas, and all these things will mean that you capture all the relevant data.
That's a very good idea. It will also help to standardize, the reporting and all that, and avoid missiness of, which is another thing. By the time, if it's not you doing it, then somebody else comes and it doesn't fill up everything. Yeah, so good idea.
The point of MDT work and then the point of the best cancer care is if you leave cancer care up to individuals, it will always vary, because people are different, and and even a good person can be really busy having a bad day. But if you have systems that are in place, then it means you have a basic floor that nothing shall fall below. So a lot of what we're talking about in African context, in any context, is how can you improve the level of the system of working so that as you raise the system up, the minimum level of care is being lifted up according to your system, and it doesn't depend on having an excellent professor, excellent gastroenterologist, excellent pathologist. You have a system where everything, they're just standards.
Okay.
Excellent discussion. Excellent discussion. Fantastic presentations. Such an excellent discussion that we will have to skip over our break, but worthwhile of the time. I will pass over to Dr. Angelo Autiak to present our next group of presenters for the panel.
Yeah, we can see you now, Angelo. Are you speaking?
Yeah, can you hear me?
Yes, we can hear you.
Okay, thank you. Thank you so much. And now we'll go over to the next session. And again, I'm Angelo Autiak. I'm a recent graduate medical doctor based in Egypt, and I'll be moderating the next session. The lineup for the next session is we're supposed to be having about 4 speakers. but now we have three speakers with us on the call, Dr. David Epstein, Dr. Omar, and Professor Abubakar Bello. So I'll go ahead and introduce Dr. David. Dr. David Epstein is a gastroenterologist in full-time private practice in Cape Town, South Africa, and part-time senior lecturer in the Department of Medicine at the University of Stellenbosch. He is the senior partner in Cape Town Gastroenterology Center, a multidisciplinary gastroenterology practice with an interest in holistic IBD care for children, adolescents, and adults. Dr. Epstein is the founder and director of IBD Africa. This is a nonprofit organization aimed at improving the care of IBD patients living in sub-Saharan Africa through research, education, and advocacy. Dr. Epstein's research interests include IBD, Africa IBD epidemiology, genetics in Africa, and IBD quality of care in low and middle-income countries. He's a member of ICO, the GLIDE, which is the Global IBD Registry Consortium, AIRE, which is the Africa IBD Research Enterprise Consortium, and the IBD Emerging Nations Consortium. So over to you, Dr. Epstein. Hello, Dr. Epstein, can you hear us?
Angelo, if he's not able to, because his mic and camera both off, maybe we move on just for the sake of time to our next speaker who's here. And then once he joins, we can carry on. I just want to make sure we're respectful of everyone's time given our constraints. Thank you. Maybe introduce our next speaker.
Thank you. We'll move on to our next speaker. And our next speaker is Dr. Omar Abdihamid. And Dr. Omar is a consultant clinical oncologist, cancer researcher, and passionate advocate for equitable cancer care in Africa. He leads the Garissa Cancer Center, which is the first and the only oncology facility in northern Kenya, which brings life-saving treatment closer to thousands who once had to travel vast distances for care. His research and advocacy focuses on decentralized oncology services, culturally informed care, palliative integration, and digital health innovation in resource-limited settings. Dr. Amit has spearheaded projects quantifying the impact of regional cancer centers, advancing patient navigation systems, and exploring how African cultural and faith contexts influence treatment access and outcomes. As a 2024 Common Sense Oncology Fellow and Cancer Research Fellow at Queen's University in Canada. And he also serves as a 2023 African Cancer Leadership Institute Fellow and ASCO IDEA Award recipient. He was recently appointed as the founding editorial board member of the Autiak Journal for Cancer Research, which was launched in October 2025, and where he's committing to amplifying African scholarship and mentoring the next generation of researchers. Welcome, Dr. Amit.
Thank you, Dr. Angelo. Please confirm if you can hear me okay?
Yes, yes.
My slides are visible? Good.
Yeah.
Thank you. I'll keep it very short. Thank you, Dr. Akwi, for giving me the space and for the invitation. Happy to be here. My name is Omar. I'm an oncologist, as you mentioned. I'll just step back and say that I will probably be singing to the choir here, because there have been amazing talks about the topic that had already been presented ahead of time. Much of what I'm going to present might be a bit of a repetition, but nonetheless, I'll keep it very short. I only have 18 slides, so this should be quick. So why colorectal cancer really matters in Africa? Historically, you do know that this was considered a very low incidence tumor in the continent. People thought Africans really eat nice, healthy food, organic, which we do. But I think urbanization has caught up with us. Similarly, also, there's a rapidly rising case findings and the improvement in our cancer registries in the continent, leading to, high detection bias. So we are seeing a lot of cancer, colorectal cancer, being diagnosed. Okay, and also most of this is probably diagnosis at late stage, and leading to somehow really poor outcomes, and then really leading to getting the attention of this disease. So I will start by saying this, that colorectal cancer in Africa fits to the paradigm of the statement of African colorectal cancer paradox, as what I've just mentioned. Historically, it was known to be really low incidence. Now we're seeing high incidence because of the reasons I've mentioned. And more specifically, we're actually seeing a lot of young early onset colorectal cancers, which really needs to be investigated. And again, because of really most of our cancer infrastructure in the continent, despite being really different in different countries within the continent, we still do see high disproportionate incidence versus mortality sort of presentation. So I'm sure this was mentioned before. If you see colorectal cancer in Africa globally, we were actually quite low, and you see Europe is leading the pack, followed by North America and Africa to be known to be a bit, having lower incidence. But if you see the graph, the graph on the right side, you see in Africa does have higher mortality for its low incidence, compared to, and higher mortality, but for high incidence for continents like Europe. So this is really not good. We really need to shift that curve to be lower mortality and, and higher incidence, probably switching where Europe is right now on that curve to come to, and where Africa is. So the trends that in Africa, the colorectal cancer trends is really unique by region. There's a very unique epidemiological pattern. North Africa has a lot of colorectal cancer, probably because of genetics, bit of diet, bit of cultural in terms of food culture, and even ethnicity. As you know, North Africa has a very distinct ethnography compared to Sub-Saharan Africa. And as you know, even Sub-Saharan Africa does not have one similar ethnography. East Africa is a bit different genetically to West Africa, South Africa, and also Central Africa. But of note here is that colorectal cancer is seen to be high in Northern Africa. So part of the reasons why we're seeing a very, emerging trend of high incidence of colorectal cancer, I may have touched this earlier on, is that we're really improving our colorectal cancer and, index of suspicion and data collection, which is what gets reported. So there's trend of increased colorectal cancer registry, and as you see from 1995 to where we are now, the age standardized incidence per 100,000 of colorectal cancer is really increasing, and that is because of data capture, which again Africa really is improving, and is in line with the reason why we are going to see a lot of cancers, not only colorectal, in the continent because of improved infrastructure in the next 30 to 40 years. So I think this is a bit of repetition. I've mentioned this before, but what is more important is the age of distribution. Uniquely in Africa, I've touched why it's unique to talk about. Why it's important to really have this discussion today is that we're seeing a lot of young early onset colorectal cancers. An age group here being 40 to 49 to be the highest. That is actually not a young age. Not an old age, quite young. And still you're seeing a good proportion, around 5%, actually less than 30 years of age. So this is actually very important and unique and needs a lot of attention. Again, similar thing, Africa, you see the incidence in Africa and US comparison, this data on early onset colorectal cancer from Segun et al. That was published in 2023 in the Journal of Cancer, Journal of Clinical Oncology, Journal of Cancer, in 2023, showing that the proportion of colorectal cancer cases that are early onset being higher in Africa. As you see on the left here, Africa showing around, close to 38%, but the US having, around 20 or 15% early onset. Similarly, if you see in the age group of 50 years and higher, still you do see USA being higher. So this is the pattern. In the Western world, we do see colorectal cancer a bit towards the age of 45 years and above, and even 50. But in Africa, we are seeing a lot of actually, an early onset, as you see in this graph, which is less than 50 years of age. So again, some of the etiological factors associated with this is global. It doesn't have to be unique to Africa, is that you see in this square, you do see that the relative risk versus the type of offending agents that are known as risk factors for colorectal cancer, high fiber, the so-called high and low fiber, like processed food, like low fiber diet, and the intake of high or highly processed food is actually the highest culprit. If you see up there, the blue dot of low fiber diet, and if you look at the a relative risk of magnitude of 1.3, and more likely of getting colorectal cancer with that kind of diet, compared again to obesity at standing at a relative risk of 1.2. Smoking supposedly actually does cause colorectal cancer, but you do see the relative risk is quite low compared to, again, alcohol, which is a bit higher, and then red meat being somewhere in the middle. So a bit of pathogenesis. This is not a master class for colorectal in terms of the pathogenesis, but this is just the snapshot of, and how colorectal cancer pathway develops. And again, starting with those, risk factors that I've talked about: highly processed food, low fiber intake, bit of genetics, smoking, alcohol, obesity, all that, leading to a bit of microbiome dysbiosis, harmful microbes accumulating in the colon, inflammation state really in a cascade aggravated, which leads to colonic tissue damage and polyp formation, right? Through the adenomas and polyps. And then if that is not really clipped, because there's little or few people who go for cancer screening of the colon, then that really develops into tumor. And then, with early detection and diet really, really plays a big role to catch any, of this continuum of disease pathogenesis. And then, unfortunately, because of the Africa low risk setting, we do see a bit of, someone really not getting proper screening and not getting catched a bit early in the continuum of care, leading to late diagnosis, again, because of poor screening and low awareness and even stigma. So there have been some work that were done actually from Africa, and which was published, dietary transition and colorectal cancer, correlation. Traditional diet, which is basically the high fiber, low fat diet, and westernized diet. If you look at any given time, the relative consumption pattern is actually was higher at some point, meaning the traditional diet used to be a very common thing, but as you see, the orange bar graphs are taking over. As the time goes, there's a lot of sugar consumption, a lot of sugar, processed food, red meat is on the rise, and you see vegetables actually a bit, getting a bit lower. Urbanization is another culprit that is attributed to why we're seeing colorectal cancer, and more so early and young onset colorectal cancer. If you see this relative trend, the blue curve is, as you see, urbanization goes and increased from the year of 1980s to 2020s. You see also the red curve also taken over, which is basically taken, an increased intake of highly processed food, which is basically a high and low and high fat, low fiber diet, kind of contemporary food culture that is taken over, especially in the Western world. So screening, I think this is very important. You can't talk about colorectal cancer without talking about how important screening is. We're still lagging behind as a continent in the uptake of colorectal cancer screening, based on because of the unique factors in the continent: stigma, low awareness about colorectal cancer, and availability of screening and endoscopies and all that compared to high-income countries. But what is even more alarming is that, stage at diagnosis, because of, again, these global cancer care screening disparities, you do see in Africa that the stage of diagnosis is actually very low for stage 1. Remember, we really want to flip these histograms. We need to have higher stage 1s than we are seeing higher stage 4s in Africa. And again, that is because of the disproportionate access to colon cancer screening. So the future, looking far into the future, as I've mentioned, and this will not really become smaller. It will only, the trajectory and the modeling of the studies show that from 2020 to 2050, the colorectal global cancer burden will continue increasing, because I don't think the weather is going to, the environment is not going to be better. The food will be not even better. Population also will be aging, and because of those age being a huge factor for cancer diagnosis, everything, all that added together, we only expect increase rather than decrease. But again, in parallel to that, you do see in the back closer home as well, the projected colorectal cancer will also be increasing. As you see here, 2022, again, North Africa leading the pack, in terms of the colorectal burden in Africa. From 2020, still North Africa was highest and Central Africa was the lowest. And in 2050, you still see those numbers going close to, 40,000 cases from 2020 to coming to 2050 projections going again higher. Okay, so this is a very common phenomenon in, just a second, let's try to put my, epidemiological transition in Africa is really one of the phenomena that really needs to be highlighted. Remember, Africa previously was a lot of effort and resources and funding was on communicable diseases like HIV, tuberculosis, and malaria, and all that. And right now we're moving a shift to non-communicable diseases because the population in Africa is growing, it's aging. There's a lot of westernization of food and living cultures. So there is a definite epidemiological transition or a shift, and leading to all colorectal cancer also increasing. You see the population in blue will be expected to increase as the years go by. Similarly, the colorectal cancer cases in green also will be increasing. And then finally, this is my last slide. Just key takeaway message for trends in colorectal cancer is that it's here to stay. The numbers will keep increasing across the Africa regions, notably Northern Africa leading the pack, but also in any other region will also be increasing. This also means that we might be seeing early colorectal onset, cancer onset, meaning age less than 50. And then unfortunately, because we are not improving our infrastructure in the same pace the disease is taking over, so it will be very, very, reasonable to see a lot of late diagnosis unless we improve our cancer care infrastructure across the country. Screening really plays a lot in colorectal cancer, and if anyone has a high risk factor, a high BMI, continuous smoking, has an alcohol use history, family history, please go for screening, and also, educate your communities about this disease, because it's one of the diseases that has a lot of risk-benefit ratio in terms of screening. And investment in cancer registries is urgently needed because that defines our numbers. Remember, we will only report what we have documented, and based on what we are seeing right now, our numbers will even be higher because of the infrastructure of cancer registries. Thank you so much.
Excellent presentation. Thank you so much, Dr. Omar. We'll move on to our next speaker. Our next speaker is Professor Abubakar Bello. So, Professor Abubakar Bello is a leading radiation oncologist and academic whose work has advanced cancer care in Nigeria and across Africa. He previously served as the president of the African Organization for Research and Training in Cancer, Ayii, promoting cancer research, training advocacy across the continent. He chairs the National Comprehensive Cancer Network, Harmonized Guidelines panel for prostate, colon, rectal, and anal cancers for sub-Saharan Africa and contributes to other guideline panels. Professor Bello is also a member of the African Cancer Coalition. He is an IAEA Fellow at the National Cancer Institute in Cairo. He is internationally recognized for the leadership in oncology education, research, and cancer care policy. He is currently the Chief Consultant, Clinical and Radiation Oncologist at the National Hospital Abuja and the President of the Association of Radiation and Clinical Oncologists in Nigeria. You are welcome, Professor Bello.
Can you hear me? Hi. Can you hear me? Hello.
Yes, we can hear you, Prof.
Yes, we can hear you, please.
But your
But
screen.
can you see my slide as well?
No, we are only viewing the Zoom screen.
Oh, okay. So if you permit me, I would like to share again. Share.
Yes, your slides are now sharing, so we should be able to see soon.
My
Hello, can you hear us? Hello, Professor,
Wow.
can you hear us?
Yes, I can hear you now. Can you
Yeah,
see my screen? Okay, I think I'm having some difficulty with my. I'm having some difficulty. Can you see my screen now?
Oh, we can see the screen, but the Zoom screen, not the PowerPoint slides.
Prof. Bello, if you want to email
No.
it to me, then I can share for you. If you want to email me your slides.
I will do that immediately, yeah.
Okay, wonderful.
Seems
Should we
okay.
go to the next speaker so that we don't rush you
Yes,
to do
please.
that? Okay, all right. And so it looks like, Dr. Epstein, are you ready?
I don't know why this is not happening.
Dr. David Epstein?
Hi.
Hi, how are you?
Good. I got my timing wrong.
That's
I missed my
okay.
session.
No problem.
Sorry about that.
That's okay. It happens, and we flipped time zones. So, are you able to share? If we can have you go on next.
Sure.
Okay, perfect. All right. And Prof. Bello, if you just email me, and then we'll get you sorted.
Right.
Okay, just want to share settings. Where is it? Just want to share my screen. Just give me a minute. Where is it?
And to everyone who's listening as we're waiting for our speakers to share their slides, just remember this is a CME program, so you do get credit. Just make sure you complete using the link we shared earlier. All right, back to you, Dr. Epstein.
Right. Are you able to see my slides?
Yes, we are. You
Yes.
just change it to a slideshow. It's perfect.
Is it on slideshow?
Not
Not yet.
Okay, sorry.
in my
Right, how's that?
slides. I've sent them.
I'm just going to turn on my video.
Oh, yes. It's perfect now.
Yeah. All right. Okay, you can all see that.
Please go on.
All right, thanks. Right, thanks, Jennifer, and thanks, Akwi, to speak at this meeting. It's I've been dipping in and out of the meeting, but it's been a fantastic meeting. So I'm going to be talking on colorectal cancer in inflammatory bowel disease. Okay, those are my disclosures. So, as I've mentioned the last time I gave this talk, when I look at the relevance of inflammatory bowel disease in colorectal cancer, I think we really way down the line because there are so many more pressing needs, diseases that have a much higher incidence and prevalence that are major public health issues. And I've tried to sort of stratify it in this slide to show that, in terms of priorities, I think IBD-related colorectal cancer is very low down the line in terms of a priority in colorectal cancer screening. But nevertheless, I think IBD is on the increase, and it's something that we do need to be aware of. So just to give you some examples, and I think some of this has come up in the previous talks, that we have major disparities in terms of colon cancer screening in South Africa. We've got a dual healthcare system, a private healthcare system that offers very good services and has great access. And if I just look at my practice over a 7-year period, patients who were asymptomatic, so they came for routine screening colonoscopy, 284 patients. I didn't find a single colon cancer, but there was an adenoma detection rate of between 23 and 26%. But when I compare this to my colleagues at the government hospital, Groote Hospitals, a tertiary referral center, they don't offer routine screening colonoscopy unless you have IBD or Lynch syndrome. And if you just look at their APR for rectal cancer, they just see 100% advanced cancers. So most of the lesions, all the lesions are either T3, T4, and all of them advanced cancers. So there's no early detection in their setting compared to a setting where we obviously are a completely different world. So we're going to talk about IBD. So we talk about two illnesses, ulcerative colitis and Crohn's disease, which both can be quite destructive in terms of their effect on the colon. And we know that these diseases are characterized by a number of extraintestinal manifestations. So it's a very much a disease that affects both the gut and various other parts of the body. So Sub-Saharan Africa is a fertile ground for the development of IBD, in that we're seeing a huge transition from rural to urban living. We've got large mega cities on the continent. There are increasing trends in obesity. There's GDP increase. There's a massive increase in fast food chains. And this is just a slide from South Africa. Up until 2018, I suspect the figures have doubled since this was published. But there are some things in Africa that are protective against IBD. We have very low vaccination rates. Breastfeeding is still widely practiced, and antibiotic usage compared to Europe is very low. And we know that those are all protective in terms of IBD. So I looked at a study from the 1980s, how many cases of IBD were detected in sub-Saharan Africa. This was a 24-country study, 75 hospitals with over 12,000 cases of bloody diarrhea. And within that, only 22 cases of IBD were identified. And if one looks more recent data, you can just see that there's been a massive increase in the number of cases that have been reported across the continent. And if one looks at PubMed, the number of reports of IBD in sub-Saharan Africa increased substantially over the last 20 years. So if we look at Cape Town at our IBD Africa registry, we've got data on over 4,000 patients. And if we look at the early data from the 70s and 80s, it showed a very much developed world pattern of IBD, predominantly white patients, a signal amongst Jewish patients, and Crohn's more equal to UC. But more recently, if we look at the demographics of our patients, it's all ethnicities. We're seeing UC far more than Crohn's disease, which is what is experienced in other low and middle income countries. So we've got this sort of mix of developed and developing world IBD patterns. But are we estimating IBD in sub-Saharan Africa? And I think we are. So the first thing is awareness. There's poor IBD awareness, and a colleague of mine was doing an endoscopy workshop somewhere in Central Africa, and the first case that he had to scope was his host said, we've got a very interesting case of familial polyposis, and when he did the colonoscopy, he found out it was actually a patient, obviously with IBD undiagnosed, who had numerous pseudopolyps. So there's seriously a lacking of awareness. And then there's some issues that may delay diagnosis or presentation, and that's the cultural perception of weight and health. And we know from the HIV literature, there's a lot of stigma around weight loss and HIV, but even non-HIV weight loss may still trigger stigma and delay presentation for diagnosis. We know that infectious diseases mask IBD, and there's a whole list of IBD mimics on the African continent. But just to give you a feel for how this can play out, this was a study from a rural healthcare setting in Malawi, where almost 20% of patients with depression were incorrectly treated for malaria. Then also diagnosing IBD requires resources and expertise. If one thinks of just a mucosal biopsy and what happens after that, the infrastructure, the resources, the skills required to produce an accurate histological diagnosis, it's quite significant. I don't think we always appreciate that. And this was just an interesting study from Djibouti, where they were looking at IBD in 657 suspected cases, but less than 30% of those cases had a biopsy taken, and they only identified 3 IBD cases. But, just the lack of being able to take a biopsy obviously was a major hindrance in terms of identifying patients. And then we also, when we look at the literature to see how many IBD cases are reported from sub-Saharan Africa, very little is published, but I think IBD series from Africa lack novelty. Most are never published in the major GI journals and are usually published in one of the numerous biomedical journals on the continent. But only 27% of these journals will be found in international scholarly databases. So there may be a lot of published literature on IBD in the continent that just goes under the radar. If we look at early diagnosis, this is again data from our IBD registry that almost 20% of patients will experience symptoms for more than 2 years, both Crohn's and UC, before a diagnosis of IBD is made. And I've just got some figures that are identified. I'm not sure if they're 100% correct, but the capacity to manage inflammatory bowel disease is hugely under-resourced. So one of the challenges with early diagnosis with IBD, competing healthcare needs, all the infectious diseases, and just basic things like clean water is IBD a priority if you cannot separate sewage from drinking water? I think in terms of public health, priority is given to non-communicable diseases deemed modifiable by lifestyle. So diabetes and hypertension, obesity all get a lot of attention on the continent because these are deemed modifiable by lifestyle, whereas autoimmune diseases generally do not receive the same attention. And a lesson we've learned in South Africa is to advocate around immune-mediated inflammatory diseases, when all the disease societies, the rheumatoid and the axSpA and the psoriasis and IBD, I think together we represent a far more significant voice compared to each disease trying to advocate for resources on its own. Again, I looked at some data on gastrointestinal malignancies in IBD. So this was some data from 2019 where we looked at 2,500 patients with IBD. We identified 121 malignancies, but only a small percentage, 14%, which
think Dr. David has network issues. Hello, Dr. David, can you hear us? Hello? Hello, Dr. David, can you hear us?
He's on mute right now, so maybe he can't hear us. Trying to get back online, I think.
Oh, yeah, I can see he's mute.
I think he's trying to get his talk back.
Yeah.
You're on mute, David. You're speaking.
You're muted, David.
I think you can't unmute.
Maybe Angelo, you'll be able to unmute him. If you are a host, you can unmute him.
Yeah, I'm trying to unmute him now. I'm asking him to unmute. Dr. Epstein, if you can hear us, maybe give us a thumbs up. Okay. And are you trying to unmute? Give us a thumbs up. That's okay. If you want to, you can type in the chat if you, because you're muted right now. And as we're waiting, just a reminder for everyone that the program is CME eligible. The details have been posted in the chat by Dr. Kizza-Brown. So if you'd like to, and it's free. So if you'd like to get credit, for all those who need the points for medical licensing, please use that. Okay, Dr. Epstein is back.
Sorry about that.
That's okay.
Oh, it's okay.
I'm just going to share again.
Sounds
Where is this going to? All right. Okay, I'm just going to open it up. Sorry, just give me a moment. Okay, let's go back. All right. Okay. Sorry about that. So this was the patient I was talking about who had long-standing UC, not really treated, and at endoscopy she had a diseased colon and a stricture, and this was an invasive carcinoma, and it was an advanced cancer, and she passed away a year later despite chemotherapy. And this is another patient that I recall who also had, complicated ileocolonic Crohn's with complex perianal disease. She was treated in the conventional manner, that her sepsis was drained, she had a Seton suture, she was put onto combination therapy, and we had to keep her on quite high doses of a combination of infliximab and azathioprine to maintain trough levels. This was in the early days before we had access to other drugs. And in 2019, we decided to stop her azathioprine because her skin was really not, she was suffering a lot of skin-related issues, and her trough levels with infliximab had stabilized. And a couple of months after stopping azathioprine, she developed what appeared to be recurrent perianal disease. But after surgery and biopsies, this turned out to be a squamous carcinoma of the anus. And she had to undergo a diverting stoma and chemotherapy and radiation. But fortunately, she's done very well 7 years down the line on Stelara. So just two cases that I recall. I'm going to skip that. So a lot of what I'm going to talk about has been based on the new British Society of Gastroenterology guidelines, which was published in 2026. And many of the guidelines, whether it's AGA or ECHO, show similar sort of guidance in terms of managing the colon cancer risk in IBD. So just as an opening comment, I think IBD surveillance has shifted from a universal intensive colonoscopy strategy to more risk stratified, focusing on high quality endoscopy, emphasizing chromoendoscopy, and really the importance of inflammation control to reduce colorectal cancer. So we have seen a paradigm shift over the years with, I think, a more focused strategy. So the colorectal cancer risk in IBD is 1.4 to 1.7 times that of the non-IBD population. And this is significantly lower than previous estimates, but it's still high enough to warrant dedicated surveillance. And it's important to remember that the risk is not evenly distributed in the IBD population. So the mortality of colorectal cancer in IBD is higher than the general population if one adjusts for tumor stage. It's known internationally that implementation and adherence to surveillance guidelines is generally poor. And another interesting point I found was that post-colonoscopy colorectal cancer rates are much higher in IBD patients than in sporadic colon cancer. And this reflects just the difficulty in detecting, early lesions and maybe a difference in the cancer biology in IBD. So generally, it's recommended that patients with colitis involving the left side or extensive colonic involvement or Crohn's colitis involving more than one colonic segment are eligible for surveillance, and that patients who have isolated proctitis, have small bowel Crohn's, or maybe are not suitable generally for a surveillance program, do not require surveillance. So most guidelines start surveillance 8 years after the onset of symptoms. So it's important to make the distinction between diagnosis and onset of symptoms, because a lot of patients, certainly in our setting, may have had symptoms for up to 2 years before diagnosis. And then obviously patients who have primary sclerosing cholangitis are very high risk of colon cancer, and they would start their surveillance at diagnosis. And the risk of colon cancer before 8 years is low, and so that's why the rate is the duration of disease is 8 years before surveillance. So if one looks at the BSG guidelines, this just gives you guidance on how to approach surveillance colonoscopy in IBD patients. And I'm not going to go through it in too much detail. The guideline is pretty straightforward, but really it's based on risk. And it has a risk calculator to work out the risk of colon cancer. But the important things are, number one, that you choose the right patient, that they fit the criteria for surveillance, that you do this when the patient is ideally in remission, because that's far easier to detect lesions that may be sinister, that uses a good colonoscopy preparation and preferably dye spray. And then important to consider patients who have a family history of colon cancer. And then there's some special situations, which I'm not going to talk about because they would make this a much longer talk. But one has to consider anal cancer in patients with perianal disease. One's got to consider colon strictures and how to deal with them. These guidelines don't apply to patients who are diagnosed at a young age and their biology may be different. Patients who have family cancer syndromes and IBD will be different. And then patients who have an ileoanal pouch may need to be considered in certain situations for surveillance. So I used the colorectal neoplasia risk tool that the BSG has provided, and it's actually very helpful and it's very quick to use. So it's based on multivariate analysis, and I just took the example of a 59-year-old male who's had relatively mild left-sided ulcerative colitis for the past 25 years. Who's had one inflammatory polyp in the past, who doesn't have PSC, and who has very mild activity. And it gave a risk of 0.7%, so that would immediately go into the low-risk group, and your surveillance would follow that strategy. So it's very useful to decide what surveillance strategy to use based on your last colonoscopy. In terms of colonoscopy performing surveillance, I think high quality colonoscopy is important. And starting with the basics, a good bowel prep, before one starts with any of the fancy modalities, if you don't have a decent bowel prep, then you're not, it's no matter what sort of instrument you're using, you're not going to have much success. The preferred technique is to use a high definition colonoscope. According to the BSG guidelines, there's really been no benefit with some of the modalities like narrowband imaging or FICE or iScan compared to just normal white light high definition endoscopy. Chromoendoscopy seems to have some advantages, but the level of evidence is low. And just in terms of this, I just as a cost-saving measure, I use a food colorant, a blue food colorant to use when I do chromoendoscopy, and it's a fraction of the price of indigo carmine or other methylene blue. And it, I think, gives an excellent result. So, if costs are an issue, that's something that I would recommend. Targeted biopsies has become the preferred strategy rather than the random 4-quadrant biopsies every 10 centimeters that was recommended previously. And then random biopsies are reserved for special situations, so maybe patients who have PSC or who have previous dysplasia. So how to deal with dysplasia, or how to, what to do. And again, the BSG has the algorithm, which I'm not going to go through because it's in the public domain and everyone can read it. But really, it looks at whether one has a lesion that's unrelated to IBD, which is on the left, or one has visible dysplasia related to IBD, which is in the blue, and then there's non-visible dysplasia, and indeterminate for dysplasia. And it takes you through these various algorithms. I think a practice point that I find quite difficult is to decide, is the lesion that one identifies within an area of colitis, because that does make a big difference to how you're going to deal with that lesion. And sometimes a patient might be in very good remission, and you may not have an accurate history of how extensive their colitis was. And so now you've picked up a lesion, and whether it's arising from an area of colitis is very important to know. And so what I do in that situation would be to take biopsies around the lesion to see if there's any evidence of underlying colitis, because that will affect how you proceed through the algorithm. I think the special circumstances are anal cancer and perianal disease. I think one just has to be aware of this, examine the anal canal both digitally and endoscopically. Childhood onset IBD, we don't have very clear guidelines, but a lot of these patients will be appearing for surveillance after they've transitioned from childhood to adult care. Obviously, one has to approach patients with hereditary syndromes differently. Strictures are an issue because they can be associated with neoplasia, so they are an important feature at endoscopy to deal with and assess adequately. And then for patients who've undergone ileoanal pouch anastomosis with UC, if they've had a colectomy for dysplasia, if there's been a residual rectal cuff that's been left behind, if there's chronic pouch inflammation or PSC, they may be suitable for surveillance for cancer. So just some emerging trends. Several themes have appeared in the most recent guidelines. I think individualized risk prediction tools estimating 5-year neoplasia, I think, is important. I think the real focus is on controlling inflammation. Chronic, poorly controlled IBD is a modifiable risk factor that we can address. I think we are looking at better sort of dedicated IBD surveillance endoscopists if one has that luxury, chromoendoscopy, and an audit of dysplasia detection rates. So if one has those, to just improve the service. I think potential chemo prevention is controversial. Whether one uses 5-ASA chemo prevention, it's not been shown to be universally effective, and it's very difficult to separate the effects, the therapeutic effects, from the effects on preventing cancer. But certainly, I think the practice at present is not to add this to patients who have achieved a good remission on advanced therapies. I don't think one would want to add 5-ASAs as a chemo prevention. And if I just show you those slides, those pictures on the right, 5-ASAs are not readily available in Africa anyway. And for many of my colleagues who practice on the continent, it's really an aspirational drug if you can get patients onto 5-ASA therapy, which is very unfortunate. So just to summarize, I think IBD is recognized as a risk factor for colorectal cancer in Africa, but should the focus really be on early diagnosis and good remission as a priority, rather than, spending a lot of resources on surveillance for the patients that we do have. I think a much better strategy would be early diagnosis and achieving good remission. We know that the incidence of colorectal cancer in IBD has decreased, probably due to better therapies, but it is still high enough, more than 1.5 times the rate compared to non-IBD patients, to warrant customized surveillance. But if the rate drops to below 1.5, then one would say, is it really worth performing surveillance in IBD patients? I think surveillance, according to guidelines, using individualized risk stratification tools, I think have become very helpful and easy to use, instead of trying to work through very complex algorithms. I think get the basics right, have good KPIs, good bowel prep, high definition endoscopy and chromoendoscopy. And all dysplasia cases, I think, should be discussed in the context of an MDT. They are difficult decisions to make. One often needs review of the histology to be sure one's made an accurate diagnosis, and generally a discussion with your gastroenterologist, pathologist, and colorectal surgeon to try and plan a suitable strategy for patients who have dysplasia. So that's a brief overview. Happy to answer any questions, but I think that's all I have to say for today. Thank you.
Thank you so much, Dr. Epstein. Wonderful presentation. We'll proceed to the next speaker, and please keep your questions coming in the Q&A and in the chat as well. So we'll go over to Professor Abubakar Bello. Dr. Kizza-Brown, if you can share a slide, please.
Yeah, Prof. Bello, I've made you a co-host. Did you want to try and share? If not, Dr. Kizza-Brown will share your slides.
Fine.
So you're now a co-host. Let me know if that works for you.
Yeah.
Okay.
And I see if I'm able to share now.
Okay. It's slowly, you're sharing the Zoom.
Said you can see my screen now?
No, but we see the Zoom slides.
I don't get it. You see my slides?
No, we don't. We don't see your slides.
It's amazing. Okay.
Do you want us to share for you?
Yes, please.
Okay. All right.
Since
Not a problem. Okay. Sounds good.
Stop sharing.
Okay.
Yeah.
Great. Sounds good. Dr. Kizza-Brown, you want to take over and share his slides, please?
Yeah.
And Prof, just let us know when to go to the next. Dr. Kizza-Brown, if you can just make that into slideshow. Yep.
Yeah.
I think it's at the bottom. Yeah, there you're so close. And then just switch the display so we're not seeing the double.
Wow. That's hopefully I'll be able to.
Yes. Perfect. All right, over to you, Prof. Bello. Just tell us when to move to the next one.
Yeah, okay.
Thank you.
So thank you so much for inviting me to talk of something that is so close to my heart, which is the NCCN harmonized guidelines and the implementation processes for colorectal cancer. Again, I'm Bello Abubakar, Chief Consultant at the National Hospital for Radiation and Clinical Oncology. I'm also a research professor at the University of Health Sciences, Azare in Nigeria. Next slide. So this is the objective of my talk, and yeah, the previous speakers have made it very easy for me by talking about the burden of colorectal cancers in Africa. So I'll quickly go quickly through the first 6-7 slides. So next slide, please. So we do know about the global burden of colorectal cancer being the third most common cancer worldwide, and also the second leading cause of cancer deaths, with about 1.9 million new cases yearly. Next slide, please. So this is basically what we see in Africa. The incident, it's increasing exponentially. You can see that the graph has gone up. I mean, almost double from 2010 to 2025. It has gone really, really up, and that may be because of the awareness and probably because of screening. Next slide, please. And then when we look at the incidence against the mortality, you will see that we have high prevalence of mortality, and this is not unrelated to the late presentations, and poor recognition of even the cancers themselves. Okay, next slide. Yeah, so this has been discussed extensively. I will not go into details, but suffice to say that the incidence is number 4 in about 5.6% in African setting, while the mortality is about 5.7. So it's hovering almost the same number of incidents as well as the number of mortality. Next slide, please. Yeah, next slide. So we do know that the incidence, like has been mentioned earlier, it's really rising, and we still believe that it is underreported because of the poor, screening process and screening programs. They have not been institutionalized in most of African countries, and we know that a chunk of our patients are also in the rural area. So it is always, really difficult for us to give a clear-cut epidemiology of colorectal cancers. But we have seen very young patient presenting. I have a patient currently that is just 19 years old, presenting with an advanced colon cancer because she spent so much time with other doctors because it was the last differential that they have, Of course, because of that, we have high mortalities, due to late presentation. Yes, please. Next, please. Next. Okay, so you know that the NCCN has so many resource stratification, and they have the basics, the core, the enhanced, and then the NCCN standard. These are the guidelines that you will see in the NCCN, while the ESMO has a standard European guideline, and of course, NICE guideline that is in the UK also has its own guidelines. So there are many guidelines, and stratifications, but we decided that the African story is sub-Saharan Africa especially is one and the same thing: late presentation, poor resources, very few clinicians, and so on. So we said it is better to have one guideline for sub-Saharan Africa. So what we have currently is the NCCN harmonized guideline for sub-Saharan Africa. Next slide, please. So why harmonized guideline? I mean, we do know that most of our evidence are just few. Africa has about 3% of the global clinical trials from where you actually get evidence. So because of that, we needed a guideline that really is evidence-based and then can actually be adopted to the sub-Saharan Africa narrative. And then it will also provide, a realistic treatment pathway, because having a guideline is always better than not having any guideline at all. Next slide. So we do know that the NCCN guideline is actually evidence-based, and also it is resource adopted. And in some instances, of course, you have also stage-specific treatments for the diseases, and that has helped us a great deal, in adopting or in harmonizing the guidelines. Next, please. So, developing a clinical practice guideline, in cancer also presents its own unique problems and challenges due to the heterogeneity of disease presentations, the complexity of therapeutic decisions, and the availability of therapeutic options, especially in LMICs such as sub-Saharan African countries. But we also recognize that guidelines should incorporate standard outcome measures, quality of life measures, patient preference, and cost effectiveness analysis. And this, the NCCN guideline has given us all that is required. Next, please. So, what do we need the guidelines for? First, to improve patients' outcome, including disease-specific survival, also assist providers to keep up with rapidly evolving evidence. We know that we don't have the evidence yet, but it will also give us way of developing our own evidence. So with the guidelines, which is 10 years now, we will be able to say that yes, we have made a giant stride in providing some evidence in the guidelines. And also it provides us an independent measure of quality of care. And with that, we are able to say that, yes, Mr. A or this institution is actually doing the same thing as my institution, and it is also doing the same thing in another institution. And that helps us also in facilitating shared decision-making in multidisciplinary care. And it also helps us in facilitating referrals, knowing that if I send a patient to Kano or to Maiduguri or anywhere else in Nigeria, I know that the patient is going to receive the same type of care because we are using the same standard guidelines. Next, please. Next. So basically, clinical practice guidelines also, we know the definition, is a systematically developed statement to assist practitioners and patients in decision about appropriate health care for specific clinical circumstances. So if a clinician can use a guideline in arriving at a medical decision, then that guideline has been framed correctly. So guidelines should not be vague or lack specific direction and should provide substantive guidance. Next slide. Guidelines should also promote conformity and eliminate inappropriate intervention, and that is where the harmonization comes in. We know that we cannot carry whole and sinker the whole guideline, the core guideline that is being used in the United States. And that is why we are able to pick up those guidelines that are really beneficial for our patients. And those ones that we are not able to do are grayed out. So the cost of care can be more accurately also gauged, and cost of care may even be reduced. We are able to pick up the right treatment and the right interventions, and also involve policymakers, in developing those guidelines. And that has helped us in, getting to pharma and getting a really reduced cost of some of our drugs that we are using currently. and that has also improved the care. Yeah. Next. So we know that studies have shown that patients treated according to evidence-based standard of care have better outcomes than patients that are not. And also there is emergence of malpractice litigation also in Africa, which has created interest in documenting evidence for treatment decisions. So until now, a clinician or a consultant will just decide on the way he wants to treat patient, but when there is litigation, he doesn't have any evidence to show. But with the MDT, with the advent of the NCCN harmonized guidelines, at least we know where we can fall back to. These are the evidence, these are the things that we have treated and so on. And it has also helped us in discussing with health insurance coverage, around the regions, knowing that this is the specific drug, this is the specific intervention that we want to have for the patient. So that is why guidelines is really, really important. Next, please. Next slide. So so this is a historical context of how the guideline was actually formed. We formed the African Cancer Coalition in 2016, where we had some meetings, and then it was decided that we are going to harmonize most of the guidelines that are on the NCCN domain. And a lot of clinicians were all invited. Next slide, please. So far, we have over 200 cancer experts from about 34 cancer treatment centers in 13 countries that have participated. We have over 24 policymakers from 8 African countries that have also participated, and also over 30 experts from the NCCN guideline committee that have also participated in guiding us in the harmonization process. You can see the number of countries that have actually participated in blue. And interestingly, the interest in the guideline has gone so far that even those countries that have not participated in the harmonization are actually getting in touch and are adopting it as their national guideline. Example is Liberia, that has never participated in any of these, but they have adopted it as their national guideline. Next slide, please. Next. So, no. Can you go back? Yes. So we know that we need to have a multidisciplinary team. We need to have multidisciplinary care. And because of that, we made sure that in each of the guidelines, especially also in the colorectal guidelines, we have surgical oncologists, medical oncologists, radiation oncologists, pathologists, palliative care and pain specialists, as well as nuclear medicine specialists and radiologists. And this is the same thing for each group, for each disease entity. We make sure that all the multidisciplinary team participants are involved in developing the guideline. Next slide, please. So next slide. I've mentioned this. So this is the strategy for implementation. So how do we get the guidelines implemented in clinical practice? First and foremost, we've been able to make some of the countries to adopt the guidelines as their national guideline by endorsing the guideline. That is not to say that people cannot use other guidelines. It is so imperative, it is important that we use guidelines that are tailored toward what we have. And these are our clinicians have actually participated in developing those guidelines. So we have also included these guidelines in the MDTs that we do across Africa. And we're also doing webinars, for African clinicians that have not participated in the development of the NCCN harmonized guidelines. This is to give them also, a sense of belonging, and then also to be able to ask questions and then see how they can actually adopt those guidelines. We have also partnered with professional societies to disseminate the information, the Autiak comes to mind. There was session on implementation of guideline at the just concluded in November, the Autiak conference in Tunisia. So that has really given a lot of people to understand that yes, there is a strategic guideline that is primarily for sub-Saharan Africa. And we've also done some major outreach, to different cancer centers across the continent, where experts that have participated also go and discuss with the clinicians that are running day-to-day activity. And we've also started some publications and joining hands to develop some research projects around that guideline uptake and impact. Next slide, please. So this is basically how the guideline looks like. You can see this is the table of content. You can see for colon cancer, we have the African Cancer Coalition representative endorsement, and so on and so forth. And then importantly, you will see clinical presentations, primary treatment. These are algorithms, treatments, for MMR, MSS colon cancer. Until recently, until the advent of this guideline, a lot of people just treat every cancer the same. And this has really given us a lot of concerns. And at the end, if you look at the end, you will see that there are principles of most of the things that we do. Principles of imaging, this give you a detailed discussion of what kind of imaging, what is expected from the radiologist, what is the template for them to be able to report properly what is expected to help the clinician in decision making. The same thing goes for pathology and molecular review. There is templates that you can adopt in part of your protocol for your department, and so on and so forth. So the same thing goes for systemic therapy, radiation, and chemoradiation therapy. The same thing goes for risk assessment, and so on, and including survivorship. This is very critical. Until now, survivorship is one of the things that we don't take very seriously when we are treating cancers. But now, with the advent of this, we are able to carry people alone in terms of survivorship. Next slide, please. So this is the impact on decision making. It has standardized staging. It has also defined a clear pathway for treatment of colon cancers and rectal cancers as well. And with that, it has reduced treatment variabilities in most of the centers that have adopted the guideline. Next slide. So we know that the NCCN harmonized guideline is in algorithms that are easy to use. So you can see that in terms of the diagnostic algorithm, you can see that there is clinical presentation and you have all the workup that you need to do. Suffice to say that we have graded most of the workup that we are unable to do in sub-Saharan Africa at this point. So the ones that are in black are the basic things that should be we should be able to provide for patients to be able to have a very good treatment outcome as far as their cancers are concerned. The blue text are the ones that have been included by the African specialists, by the African clinicians that participated in the harmonization process and are not necessarily part of the parent NCCN guideline. This is because we realize that there are certain things that we actually do that are not necessarily things that are obtained with the high-income countries. So they are all in blue. So the one that you see in blue are the ones that have been imputed by the African experts. Next slide, please. The same thing goes for the treatment algorithm. We know that we have, algorithm for stages, stage 1, stage 3, high-risk patients, and so on and so forth. Next slide. Next slide. Okay. So this is, yeah. Next slide, please. I need to run a bit faster. Okay. So we now understand that chemotherapy, we have Folfox, Carpox, Folfiri as standards that are basically available, in most of African countries, and these are actually incorporated in the guidelines. So we have really now reasons to use these drugs and make them available in most of the African countries. And this has also helped us in looking at the ones that are not available and try to involve our policymakers and also invite pharma to provide those other drugs so that also our patients will also benefit. Next slide, please. So we are able to, incorporate molecular testings now in our colorectal testings. We can now, in so many centers, we are able to do KRAS mutation, NRAS. BRAF is still not readily available, but MSI, MMR is now becoming available in most of the African countries. NTREC is not readily available, but HER2 is also available. So this has helped us in personalizing some cancer patients, personalizing cancer care for some of our patients. And this molecular testing is now developing to the point that some people are now becoming interested in doing some genomic testing as well. Next slide. So with the advent of molecular testing, we are able to get patients on anti-EGFR therapies such as cetuximab and tumumab that are in a way available in some countries while they are not readily available in many countries. But countries are making efforts because of this guideline that we have to provide most of the things that are in the guideline. So we hope in the not so distant future, all the print that we have grade will become black. That means they are readily available in sub-Saharan African countries. Of course, we have anti-VEGF drugs like bevacizumab that is being used regularly for metastatic colorectal cancers. Next slide. Of course, we also have a different pathway. We have totally a different rectal cancer algorithm. Okay, so we have a different guideline for rectal cancer, and we know now that patients are able to follow the algorithm and do the needful. Next slide. So we have incorporated in our MDTs multimodality care in rectal cancer as well, where surgeons, radiation oncologists, and medical oncologists, radiologists, pathologists are also involved in taking decision for the care of the patient. Next slide. So we know that it is so difficult to do mesorectal excision because of expertise in sub-Saharan Africa, but we know that it's a standard based on the guidelines. But we are also mindful of new studies that are being conducted to see if we are not able to do mesorectal incision, what are the things that we can do. So we are following some of the trials like the no-cut trial and so on and so forth. So the guideline has also helped us in understanding some of these things. Next slide. So radiotherapy play a key role in rectal cancer. So we have seen that in the guideline, it has provided for treatment techniques. It has also provided for imaging. And also, it has also provided for re-irradiation where, IMRT is being used and so on. And there are a lot of centers that are coming up in sub-Saharan Africa now that are able to provide the best of radiation therapy, such as BMAT and IMRT. And we also know that some oligometastasis also can actually benefit from the use of radiation therapy and other modalities. Next slide, please. So yes, next slide. I've mentioned this. So we have also, based on the algorithm, that we can now do liver tumor ablations and lung tumor ablations, and this is making a lot of grounds in sub-Saharan Africa. A lot of people are becoming interested, especially for patients that have unresectable tumors and patients that have very small tumors that can be amenable. So that is where the principles comes in. It teaches the clinician exactly what need to be done, so that he doesn't need to go and start looking for textbooks that will not be as condensed as the guidelines. Next slide. So the impacts of the harmonized guidelines, not only for colorectal cancer, is that it has standardized pathways. It has given us leverage to use it for MDTs, and we are having better coordination with the MDTs. And because of that, we are also developing, some evidence, through clinical trials. I am currently a PI of a study where we are using nivolumab for metastatic colorectal cancers in the National Hospital. Next slide. So, of course, there are a lot of gaps with the guidelines. We recognize the fact that not all African countries have the same resources. So also the facilities and expertise. So we have limited access to surgery, and there are also limited chemotherapy as well as immunotherapy. And we know that there is also radiotherapy shortage. Suffice to say, 22 African countries have no single radiotherapy machine. And that is really something that we should be worried about. Next slide. So I have talked about this. Next slide. So these are the implementation challenges, workforce shortage, JAPA. I can see Segun, if I ask Komolafe to come back to Nigeria and spend 2 years, it will be very difficult. And so many of our patients, of our clinicians have left the shores of Africa, and this has given us a serious challenge. But we are trying to see how we can convert the brain drain into a brain gain. The first person in mind is Dr. Osumbo, who has really made it a point to come back and share her knowledge with most of the Africans that are here and also train them going forward. So we thank you for that, and we hope that other Africans will also do the same thing. Diagnostic gaps. Yes, we are working very hard, especially in terms of pathology, and with the clinical trials that we have started, we are able now to do MSI testing at the National Hospital in Abuja because of the clinical trial that we are doing for colorectal cancer. Until recently, that is not happening. So we are also involving the policymakers to see that these are important. Diagnostic tools are very important. Imaging is very important, and how they can subsidize it for our patients. One of the key issues is the financial barrier. The financial toxicity is real. 85% to 90% of Nigerians, and indeed most Africans, pay out of pocket. Until recently, with the establishment of the National Health Insurance Authority in Nigeria, it is now mandatory for every Nigerian to have an insurance. That may help in reducing the financial toxicity going forward. So these challenges are real, but we are facing them head on, and we hope that we are able to fix them in not so distant future. Next slide. So this is the African implementation roadmap of the guideline. It will help us to expand screening, improve pathology, expand radiotherapy capacity, as well as improve chemo access for our patients. Next slide. So we also must continue to use professional societies in training on the use of the guidelines and also disseminating the guidelines and making sure that policymakers also understand the importance of the use of guidelines. And with that, helping in better treatment outcome. Next slide. Yeah. So these are the future directions, genomic expansions, so that we can have tailored, treatment for colorectal cancer and indeed other cancers, and also regional cancer network. Already we have established the Nigerian Society for the Study of Colorectal Disease, which is very functional now, and it's working very hard to see how we can support colorectal cancer treatment and outcome. Next slide. So guidelines, standardized care as a take-home message. We must remember that using guidelines is fundamental. You can use the guidelines to develop your own protocol, and that will give you better outcome. And we have already adopted, the NCCN guidelines for our African realities. And this will support our healthcare system planning, and with that, also help the outcome of our patients. Next slide. Next. So in conclusion, we expect resourced, integrated, harmonized guidelines will provide our oncologists with as many treatment options as possible, given the variabilities in access to resources, guide decision makers on which medicine and equipment should be available at cancer centers where cost effectiveness may vary, and create opportunities for regional collaboration around research, training, and program scale-up, and also encourage multidisciplinary coordinated care. Thank you for listening. I will be very happy to take questions. This is my last slide. Thank you.
Wonderful. Thank you so much, Professor Bello. We'll move on to our last speaker for this session, and then we can take the Q&A at the end of this presentation. So our speaker now will be Professor Amr Shafiq, and he will talk to us about the colorectal cancer screening guideline in Africa, the Egyptian perspective. And Professor Shafiq finished his training in Anshams University and Limo Cancer Center at the University of South Florida. He is currently holding the position of a professor of clinical oncology at the Faculty of Medicine, Anshams University in Egypt, and he is the managing director of Anshams University Cancer Hospital. He is quite active in the field of continuous medical education and holds the position of the president of the Egyptian Foundation of Medical Science, also called the Cairo Journal Club. Professor Amr is also the founder of the Anshams University Clinical Cancer Research Unit and is one of its most active investigators. Welcome, Professor Amr.
Thank you, Dr. Angelo, for this nice introduction. You said most of what I did over a long period of time. So this didn't happen in a short period of time. So I will just share my slides. Okay. This is not typical. Okay. So sharing is not typical. I'm not sure why.
Try again. I've made you a co-host. We have it as multiple.
Yeah, it's giving me options that I don't usually see. It's usually more simpler than that.
That's odd. Yeah, try again now and see if it's still not working.
Okay, I will try. Okay. I will just try. So he's asked me to share a file instead of the screen. So this is a little bit unusual.
Have you tried starting the talk on your laptop and then going to share it again? Because that's what I had to do. It's quite quirky. It seems to be working differently.
Okay, maybe I'll do that. So he's given me like an option between sharing screens, documents, or advanced, and he's asking me if I want to.
If you start PowerPoint on your laptop and then go back into.
Oh yes, I got it. Yes,
they've changed the platform, I think. So
yeah, I guess. So do you see anything now?
Yes, you can now put it on the presentation mode. Yes, perfect.
Oh, good, cool. Okay, so I'm not sure about, is it good day, good evening, or good night? I'm not sure about the timing because we are so widespread on the planet now. So I'm talking to you from Egypt. I'm Amr Shafi. I'm professor of clinical oncology in Ain Shams University, and I do a lot of research. I'm a PI of a lot of studies, and at the same time, and also on the administrative, I am the GM, the CEO actually of the hospital that of the university hospital. So the talk will be about colorectal cancer screening in Africa, and I'm talking about the Egyptian perspective. So this is my disclosure. I will not go slow on that. So colorectal cancer, it is a big problem, a huge incidence, 1.9 million per year, and a mortality rate of around 1 million. So it is the second most common cancer-related death based on its numbers. So burden of cancer is actually increasing. It's growing due to aging population, increase of risk factors that we're not really sure about, but it's probably related to lifestyle and our modernized diet, if I can say that. So colorectal cancer is not a simple disease. The stage where you are diagnosed is totally different. So if you're stage 1, 2, 3, and 4, you will have a totally different 5-year survival rates. It's totally separable. And it's not only separable by stage, it's separable by countries. So the survival will be different if you're in Poland, Sweden, if you're in Egypt, if you're in Saudi Arabia. So it's totally different because of so many factors related to genetics, related to therapy, to availability. And as Dr. Bello have said, we are very different in the resources that we have and what we can provide to our patients and regarding an experience of the doctors and stuff like that. So colorectal cancer screening, there are many criterion, and CRC is very suitable for screenings. It's I can say easily detectable and treatable pre-malignant lesions. We have early detection of CRC will significantly improve the prognosis. In the previous slides, the curves are totally separated, totally different, stage 1, 2, and in comparison to stage 4, which is actually not bad in comparison to other stage 4 of other cancer. So it's definitely better than a cancer pancreas, for example. Anyway, so there are definitely benefits for colorectal cancer screenings, and it definitely will outweigh the potential harms. So what is the impact of screening? And when you talk about the impact of screening, of course, other than survival, cost effectiveness is very important for this because this basically it will turn out to be a policy situation. So CRC screening is cost effective compared to no screening. So there is no debate in that. All screening strategies may reduce colorectal cancer mortality to a similar extent. We have many tools. We can do the genes-based fecal testing. We can do colonoscopy, sigmoidoscopy. We can do FIT test. We have the multi-target FIT. We have many things. And we have the blood tests now. So all of them are more or less effective in colorectal reducing mortality. However, colonoscopy and sigmoidoscopy may also reduce colorectal cancer incidence because they interfere with a precancerous lesion, and so they can actually change the incidence. Well, and FIT, which is the test that we usually commonly do as part of the screening program, also shows a much smaller actually incidence reduction also because it provokes proceeding to colonoscopy and stuff like that. So the impact of FIT screening on stage-specific incidence. So with adaptation, it's actually changed. So initially, it was comparing the early stage to late stage, and we see that the late stage was actually higher, and the early stage detection was actually started to improve, starting from year 2015. We have also the multi-target fit test. So it is actually, it could be a little bit better with advanced adenoma detection compared with a fit, and holds the potential to translate into additional and clinically meaningful long-term colorectal cancer incidence reduction and mortality reduction if adapted in programmatic colorectal cancer screening. So in Egypt, it's all based about an initiative. It's a presidential initiative, and it's supported by the Ministry of Health. Most of my focus, our health system in Egypt is very complex. We have so many tracks, and I chose to talk about the biggest track of them, which is a coverage of the MOH, and this covers most of the Egyptian population. This is the vision and the mission of the initiative, was trying to resiliently and inclusively improve our healthcare system in Egypt and empowering knowledge and access. And the mission statement is to enhance health and well-being of Egyptian population. It's a very political steps. However, the initiative, which is really trying to improve our oncology situation in Egypt, have like 8 pillars: awareness, screening, diagnosis, management and survivorship, data management, and centers of excellence, training, and scientific research. So of course, in this talk, we'll be emphasizing on the second step, which is screening. So citizens from 18 years old can fill out this questionnaire. So we have this questionnaire that provokes the initiation of the screening program. We have like 3,615 primary care units nationwide, and we have like 500 private lab branches. You can and the citizen can tackle this, and by registration by his national ID, he can proceed into this electronic system, which identify and target groups for screening, either to lung, colon, prostate, and cervix. This is nationwide. And if you are colon, it will direct you to a fit test. And this is the questionnaire that usually will be filled. It can be physically or online. And if you have highly suspicious, if you have a high criteria for possibility of colon cancer, you will do a fit test. And if it's positive, you'll undergo a colonoscopy. And if it's abnormal, we'll take a pathological sample. And according to the finding, you'll be referred to an MDT in most of our university hospitals and MOH hospitals. And based on that, you'll follow up guidelines into treatment plan. The initiative results until November 2025. This is updated numbers, which we filled like a questionnaire for over 15 million people or citizens. And we actually, according to this questionnaire, we detected around 350 colon cancer patients. We have like 1,100 benign lesions and around 200 precancerous lesions. Okay, the median age was around 40 to 60 of the patients that we find them. Bleeding per rectum was the most common associated symptoms that we found. And on referring to colonoscopy and pathological testing, if it's benign lesion, we repeat the questionnaire after 1 year again. And if it's malignant, of course, as previously said, we proceed to MDT treatment-based therapy. The results of referral to the assessment clinic, not all patients who turned out to be fit positive actually did the colonoscopy. Around 16% when they were assessed, they were like deferred from colonoscopy and said it's not really needed for different reasons. 1% was medically unfit for colonoscopy. Now 6% was actually refused the procedure, which is common in Egypt. So this is the pathologies that we saw, what we found when we did. This was about 293 samples. Most of them were adenocarcinoma, was around 250. And we have like a spectrum of different histologies that we can find. We find like pre-malignant, which is usually like benign dysplasia with low grade or a high grade dysplasia. We got like 74 patients who turned out to be a benign inflammatory bowel disease between Crohn's and ulcerative colitis. And this is sites where we find the pre-malignant cases for low-grade dysplasia. Of course, the majority was at the sigmoid, followed by different sites, which means that we are not sure where, and we have the all other sites. The least was a transverse colon. And those are the high-grade dysplasia. So they have like some descending, rectal, sigmoid, and other lesions, other sites, sorry. Those are the malignant cases. So we have like 106 cases was found in the rectum. It's a little bit on a high range than we expected. Of course, the rest of the colon is actually higher if you calculate it together, but we have like divided the rest of the colon to others, to the all parts of it. And we find that the sigmoid colon was the most common site to find colon cancer in our screening program. So the stage at diagnosis on detection, all the cases that were like after proceeding to the colonoscopy and then biopsy and then referred to the MDT was like 163 patients, and those in the period of a year. We found like 17% of them at stage 1. We got like 47% of them at stage 2, 30% at stage 3, and only 6% at stage 4. So to give us a number, again, this screening program is a very recent program and very recent and very young doctors are actually holding this initiative and controlling and directing this program. So it was what we consider a successful process since we didn't have any screening program like a few years ago. This is a distribution of age. So 53% age was between 40 to 59 years old. We have like 24% at 60 to 69. And we have 14% less than 70 years. One of the very interesting things that we are observing, and we actually have published multiple publications about it, about the age group. So we have like 9% less, I'm sorry for the mark, it's not right, less than 40 years, which are characterizing a very interesting subgroup that we are really interested in Egypt, which is early patients with colon cancer. And we have like extremely early patients like in their 20s and even some patients in their teenage time. Another thing that we have, as I told you, the screening program in Egypt is extremely, the medical system in Egypt is extremely diverse. So we have a lot of out-of-pocket and we have a lot of private insurance. We have like different situations. So what I've said is the more or less the national, the global perspective for screening. However, recently now we are starting to adapt in the private practice the Garden Shield. So it is a liquid biopsy. We already do a lot of comprehensive genomic profiling in oncology, and I'm an oncologist. But now we are trying to start to use Garden Shield after its FDA approval as a liquid biopsy for detection of CRC with a sensitivity of 83% and specificity of around 90%. Of course, other tests are being adapted. It's very diverse in Egypt. And however, we are really trying to make an impact with what we're doing. What we aim is to cause the butterfly effect of colon cancer screening. We are doing, alhamdulillah, a relatively good job in treating it, but still screening is the best approach if you really want to make an impact. And by this, I thank you, and I'm ready for any questions.
Wonderful. This is an excellent presentation. Thank you so much, Professor Amr. So we have about 10 minutes for Q&A. So we will start with questions in the chat. So we will start with Dr. David. Dr. David, if you are around, if you can hear us, there's a question about the food colorant for chroma endoscopy. So do you mix blue food colorant with water?
Yes.
Yeah, so we just use a food colorant with water until I can't remember the quantities, but the food colorant is quite intense. It's got quite an intense color. So it's just a few drops. I do have this recipe. I can email it, but it's just a few drops just to get that sort of, the color right. But it works brilliantly. I've compared it to other sort of dye sprays, which cost a fortune when I look at them versus a few cents in South Africa, a few cents to buy food colorant. And as you can see from the pictures, gives a very nice chromoendoscopy. Yeah. And we use it comes into.
Can I ask a question?
Yeah.
Angelo, can I ask a question?
Go, please.
I'm pleased to hear from Dr. Shafiq, Dr. Omar, and Dr. David. All of you work in an African context. And there were some publications which I think I read a couple of years ago which seemed to suggest that the genetics of the kind of classic adenoma carcinoma sequence wasn't quite the same in Africans. And that I think that was off the back of a study in maybe Nigeria where they looked to try and they ran a pilot screening program and they were surprised at the low yield of polyp. And the postulation or conclusions with it were the cancers were there, but the sequence, there's a more accelerated kind of pathway and it's not the classical polyp adenoma carcinoma sequence we have in Europe. I don't know if that's something you would recognize from your practice or not.
Well, if I can start, I think we all of us will have to answer this question. But in my practice, I believe that it's how can I say it? I cannot be like a straight shooter in that one because I don't really have an evidence. I cannot really be accurate. I can give you my perception because I practice. I see a lot of patients, so I can really understand where you are coming from because you sometimes see that it's not really working on the classical thing about going from polyps to thing, but there is variation, and I believe there is variation in Egypt because we are like a big referral University hospital, and one of the biggest one. So we see a lot of areas from Egypt. So we observe this kind of thing. So sometimes we don't see like this correlation between the polyps, adenomas, and then conversion into like as a carcinoma situation we have like upfront. But I don't think that I can give you like an exact, a consolidative answer because sadly we are not reporting enough things. We are not like joining the points, the dots. We are not joining the dots enough. We're just observing, and I hope I have a better answer on that.
Who would David or Dr. Omar from South Africa? Is David dipped out again?
I can't really answer that question. I really don't know enough about it. I think the challenge for us, certainly in South Africa, is that, a lot of our Black patients will present with cancer without having been through sort of any screening. So to understand the sort of pathophysiology, whether it's polyp-based or not, is really, I think it's difficult because we just don't have that experience of screening and polyp cancer sort of evolution that may be seen in other parts of the world. So I can't comment. We don't know enough about it, certainly from the South African thing. I think what I can say, though, is that we do have quite a lot of HNPCC in South Africa. We've got isolated communities where there's a founder effect, and we have, a few sort of communities where HNPCC is quite common. And all the cancers in those groups are almost always HNPCC related.
Sorry, Dr. Babak, please.
Yeah. So, the story in Nigeria. So it's almost the same thing. It's difficult to say, and we don't have an institutionalized, colorectal screening program nationwide. And in my practice, I haven't seen any stage 1 or stage 2 in the last 20 years or more that I have worked in oncology, because most of the people they are mostly symptomatic before they start presenting, and by the time they go through imaging and all that, you will see that they have some metastasis here and there. So it's really difficult to say, except we developed a kind of a study really to see how much we can actually screen, and that will be able to give you that answer. But other than that, I don't think we are able to give you an answer really, because we don't pick them early. Yeah.
Thank you.
Right, and I'll go to Professor Bello. So there's a question: when following harmonized NCCN algorithms, how do we choose between the basic, limited, and enhanced resource setting in our daily clinical practice?
Yeah, so we have the NCCN harmonized guidelines for sub-Saharan Africa. It's a different entity from the other ones that are basic core parent guideline. So if you go to the NCCN website, you click on the guidelines, and then you will go down, you will see where they said harmonization and adaptation. Click on that, then you follow, you will see there is the MENA harmonization, that's for North Africa and the Middle East. There is the Japanese harmonization or adaptation, and so on and so forth. When you scroll down, you will now see the African harmonization. That does not have any resource stratification. It is one and the same. So it doesn't have a basic core or parent guideline.
Thank you.
That answers it. Yeah.
Yeah, there's also another question from Alafi, and I hope Dr. Homar would have been here, but I think I can throw it to any of you, especially Dr. Amar and Dr. David. Could environmental factors such as high temperatures, hydration patterns, or dietary habits in hotter regions influence colorectal cancer risk?
Well, Dr. David, not me. So nothing.
Sorry,
I wish
can
I
you just
can.
repeat the question?
The question goes, could environmental factors such as high temperatures, dehydration patterns, or dietary habits in hotter regions influence colorectal cancer risk?
I'm not aware of the temperature, but certainly dietary patterns. And I mean, there's a lot of evidence to support that, going back to the original sort of high fiber Burkitt's hypothesis from Uganda, which showed that the dietary content of a traditional African diet significantly higher than compared to the UK, with very different cancer rates. And then some work, I think, by Steve O'Keefe, showing short chain fatty acid content in different communities based on diet and cancer risk. So I think diet plays a huge role, and I think there's, even in inflammatory bowel disease, there's a potential to really study traditional African diets as a health strategy for non-communicable diseases, whether it's diverticular disease, maybe cancer, maybe IBD. I think there's a great opportunity there, a lot of benefits in that. But I'm not sure about the temperature and climate change, things like that.
And also, I can comment about something. It's about a study we did it in Egypt. It's the diet effect. Of course, it is very important and well established in colorectal cancer, and it's related also to the time of diagnosis. So the diet effect can really affect even younger population in comparison to the older population. So we did this study. Maybe I can just send it to you later on, but it's related that specific diets, and I'm talking about fast food and stuff like that, was actually related to the younger population, which is logical because usually the younger populations, they usually consume more of the fast food and stuff like that. So it's related to, so when we take history of the diet of the patients who have been diagnosed, this observation usually to the younger age group in comparison to the older group. So is cancer changing based on the change of diet? Is actually something that we are really interested in, but it's extremely hard to prove. Extremely hard to prove.
Well, thank you so much. Another question around the trend of colorectal cancer, and it goes: I would like to inquire if the high prevalence of colorectal cancer in the Northern Africa is equally distributed in the northern region countries, or it's only from few of the countries in Northern Africa that have registry from the data collected from the cases. And does this imply that other African regions have similar number of registries from the CRC or the Northern Africa with a higher registry? And what is the implication on the prevalence of the colorectal cancer within the continent?
I think that was answered. That was for Garnier. I think she has answered it. I think the question I think the question for Dr. Amr is this other one, and they said, maybe, did you see it, or I can just go ahead and quickly read it? Can we
I
see
didn't the Q&A or the chat box?
Yeah, it's on the Q&A. So they said great presentation and good program that you started in Egypt. For those who are found to be normal on colonoscopy, when next is the plan repeated? How often is sent out and the screening repeated?
Yes, it's an annual. If you answer the question and you proceed to the FIT and the colonoscopy and you're like clean, you'll have to pass a year before the program allows you to be readmitted in it. In my opinion, we can give him a little bit more. If you're like totally clean, you can actually stay longer. But the program itself, because it's just like an automated system, it just will like hold you for 1 year. You cannot just like do not resubmit the questionnaire again, and you cannot just go into the pathway again. Of course, factors can be different if he has like family history. But if a patient who has really, really low risk, we can actually delay the colonoscopy more than a year, of course.
Yeah, thank you so much. I think we will have to move to yes, and I have a question for you, Dr. Hammer. Thank you. I think I have another question. From the Egyptian perspective, in terms of colorectal cancer screening, what practical steps do you think can be applicable and other African countries can take in when just trying to establish colorectal cancer screening programs?
Well, I don't want to be that we are like, we didn't master it yet. We're far from mastering it. So I wouldn't really give like a huge recommendation. I know that we chose FIT because it's basically simple. We like simple things. We like easy things. In Egypt, like patients don't really like to go to colonoscopy like a routine. We are not in China and Japan where they do like very, very, very reactive colonoscopy in cars that like in mobile clinics. So we are not there yet. So we initiated with FIT test because we think it's basic. We think it's effective. However, we always have limited budgets. So we did this questionnaire, and this questionnaire trying to a little maximize. We can debate the idea of screening and high risk population detection because they are different. We're trying to be in the middle of that. So this questionnaire will like trying to increase our chance of findings because this will potentiate our resources that we have in this thing. So I believe adapting FIT is actually very logical. The multi-target FIT, I'm not sure if it's available or not. It will be a little bit a notch better, I guess. So the pathway that I can advise is trying to use questionnaires, start collecting data based on this questionnaire. You will start finding more information, improve your database. It takes time. Use FIT and then start ordering the pathways and organizing the pathway into specific centers where you can do the colonoscopy. And again, it's not just about diagnosis. You will have to know what you will do when you get the diagnosis. So you will have to track the whole pathway. And this is my advice. Of course, in Egypt, because we have like different situations. So we are considering also genetics and liquid biopsies. in diagnosis, but this is very limited, like private hospitals and very limited patients who have the resources to do that because it's extremely easy and just a blood sample and that's it. Okay, that's it.
Yeah, let me just add here that I think it is important that countries should try whatever they want to do to institutionalize, screening programs. This is very important. The NCCN harmonized guideline. We've also harmonized the colorectal screening, and if they will follow it and adopt it, I think it will go a long way, especially for patients that are at risk, of developing, average risk patients and so on and so forth, not necessarily those that have already polyposis and all that. So it's important that we must encourage our governments one way or the other, whatever they want to do, whether it is FIT, whether it is sigmoidoscopy, whether it is 3-yearly colonoscopy, as the case may be, it's important we have an institutionalized colorectal screening. I think this is very important and this is very key. Thank you.
Wonderful.
Yes,
Thank you.
yes. I really consolidate what Dr. Bella said. And always remember, you will have to find your own equation. Every country should have a perception of what their challenges, their personal challenges is, and don't try to it's not a copy and paste situation. You, of course, you do not have to reinvent the wheel. You can use the NCCN guidelines. We actually adapt that in Egypt. We are totally. This is what the students study in exams in Egypt. So
I know
anyway, you know that this way. So you definitely know that. So we study from that. However, customization. It's not about following. It's about knowing things. So know better about yourself. See what you think. You can a little bit twitch it, and then you can try to optimize later on.
Yeah. We can perfect it going forward, but let's start from somewhere because we are not anywhere. So it's very important.
Exactly.
We have where rallying point, and then from there we can customize, make sure that it's perfected and all that. But
totally agree.
Unfortunately, many African countries have nothing literally as far as screening is concerned. So this is where the problem is.
It's never nothing. They have even
it's nothing really.
A smidge. I hope there is a smidge.
It's really nothing. It bleeds my heart. Most patients. I tell you, I have a colleague, a professional colleague, a doctor, of repute, a senior colleague of mine, who actually traveled with me to Egypt last year. And in the plane, and we started talking about screening and so on. And he said when he comes back, he's going to go and do screening. He is 70. He has never done any colorectal screening. And when he came back, lo and behold, he has an extensive lesion and he has even metastasis to the liver. Yes. And he's on treatment now. So, it's nothing really, but it's okay. Maybe we discuss it in Ansham when we come. Thank you.
Thank you so much for that.
I'm down to moderate the next session. Dr. Assambang, do you want to have a quick comfort break for 5 minutes because we've gone straight through?
Yeah, that'd be great. Yeah, our two speakers are both here, and I'd like
both here and good to go.
Yeah, they're both here and ready to go. So a big thank you to both of them. But and a big thank you to all our speakers who have been on so far. Truly appreciate it. But if people, I know there's a lot of questions in the chat. But if people want to take just a quick pause, our speakers are here. They can just maybe each test to make sure their slides are working as people are pausing. And then Dr. Komolafe will take over and resume. Unfortunately, we won't be able to get to all the questions. We're hoping to meet in the future for an in-person meeting. So I look forward to that opportunity again. So once again, thank you to our speakers. But yes, I think that's perfect. Segun, if maybe the next group can test their slides.
Yeah, we'll have a 5-minute comfort break, and Dr. Ayii and Dr. Chita Ashura can try to take a turn to project your slides. Have you made them both hosts, Mukhtar? Yeah.
Yeah, so he's gone.
Both hosts. Fine.
Yeah.
So that, excellent, working. Are you a prof, or are you a doctor, or are you both? From your slide.
I always say I'm just cheating. I mean,
That's a
yeah,
Nigerian
but
move to put all your
I'm
titles
a
up.
doctor, but I'm just cheating.
All right.
That's
It's a prof. You need introduction.
All right. Okay. So we'll take a 5 minute good, Dr. Ayii. We'll take a quick 5 minute comfort break, and if we just get that ready to go, we'll start in 4 minutes now, 4:30 UK time.
Sounds good.
And as people are taking a break, I'll just share my slides. Those are just for the code. It's going to be on the recording. So people want to test out if the scan works for them as well. Let me see. So I'll just, let's see. Yeah. So that, if this is being recorded, just for people who have stepped away, and for those who are on, they can scan. I think you can try scanning. The videos, they're different sessions, just to clarify, because I think there are questions about this. So this is also available internally to those who are MGH based, and we have a separate internal link, which is why people might have been having some issues. But then the code for attendance and CME, that's open to anyone. So that one is not limited just to MGH. And so there are two different codes that you would need so you can get credit for the sessions. The videos will be posted on YouTube. There's a comment about internal. So for MGH, we have an internal internet access. And then for those in the public, it will be posted on YouTube. So I'm resharing this. We had shared this earlier, but resharing for those who are still on. You can always watch the videos, obviously. So once again, two different codes. You'll notice SOX CAB, and then the second one is JUGYUC. And then the reminder slides for those who are traveling to Zambia or would like to travel to Zambia. We have a workshop coming, hands-on, one with the surgeons, and then the other one with our pathology colleagues. So 2 tracks, limited spots. We have 12 spots for pathologists, and as of now, just 20 spots. And the whole idea, obviously, is to have that close hands-on interaction. So you can scan the QR code as well for more information. All right, and that is it from my end. Segun, whenever it's time, feel free to take over and introduce both our speakers. I will stop sharing and close my video.
Okay, sorry for the noise, just adjusting my computer. So we'll hopefully be starting the next session imminently. I appreciate it's been a long morning or afternoon or evening, so thank you for everyone for their patience. It's been a very, very good meeting. I feel like I've learned a lot again, and I'm always inspired as usual by people doing good work in difficult situations. So thank you for your time. I'm going to introduce our last 2 speakers, if that's okay. Dr. Ayii, who is on, is an academic colorectal surgeon and surgical oncologist with an international career across Nigeria, Europe, Asia, and North America. He's a senior surgical research fellow in colorectal surgery at King's College Hospital in London, and a doctoral fellow in cancer immunology at King's College London. He also serves as a consultant surgeon and professor of surgery and oncology at Afebawala Hospital in University in Nigeria. Dr. Ayii holds fellowships from the Royal College of Surgeons of England and Edinburgh, but not Glasgow, disappointingly. the European Board of Surgery, American College of Surgeons. He has authored over 100 publications and currently serves as president of the Nigerian Society for Colorectal Disorders. He is president and a recipient of the Black Oncologist of the Year 2025 from the Caribbean African Heritage Network of the UK. So he will be our first speaker. Our second speaker is Professor Frederick Chite Ashiwar, a CEO and principal investigator of the International Cancer Institute, a non-profit advancing cancer care, research, and training across sub-Saharan Africa. He's a medical oncologist and hematologist. He leads initiatives focused on early detection, diagnostics, therapeutics, and clinical trials. He has developed multiple oncology training programs and established 17 Empower clinics for breast and cervical cancer screening in Kenya. From 2011 to 2019, he directed the AMPATH Oncology and Hematology Consortium, expanding telemedicine, outreach, and national cancer programs. Dr. Ashiwar serves as ASCO Board of Directors, serves on the Board of Directors and the IASLC Board, and contributes to global lung cancer policy and research. Thank you both, distinguished speakers, and we'll start with a talk on surgical options for management of colorectal cancer, patient selection, when and how. Thank you very much.
Thank you very much. Can you hear me?
Loud and clear.
All right. Again, I'm grateful for the invitation, and thankful again for the opportunity. I've learned a lot from all the very excellent speakers who have talked before me. I do not have any disclosures. Again, I acknowledge the invitation, and I feel honored and privileged to be part of this. So when I got the invitation, my initial thoughts were that there was actually a discussion about selection and biology. So almost 30 years ago, Blake Cady talked about the fact that biology is king and selection is queen. And this has been a mantra in surgical oncology. But the more I thought about it, the more I felt that it actually could expand it for our own African setting. So my own thought about it was that biology is actually the king, selection is the queen, but techniques are the princes, and policies are the princesses, and timing is the key to the kingdom. And I explain why that will be at the end. So we must never forget that biology is the king. And a lot of talk has been done about this by previous speakers, so I'm not going to dwell on that again. But my focus today, my mission is to talk about the queen, about the key, and about the prince. And at the end, I will add the princess and the king to the kingdom to form a surgical framework with examples so that I could tie everything up together. So I'll start with the case presentation. So the 19-year-old female undergraduate referred from came on her own from government hospital following a local industrial action. She came in with abdominal pain and abdominal distension and constipation, signal indicating intestinal obstruction. And of note, she had preceding change in bowel habit and rectal bleeding in the previous 1 year. She had chronic abdominal pain, abdominal distension, background weakness, and she was nulliparous but had irregular menses for the last 2 months. She had an appendectomy just 3 months before presentation at a private hospital under anesthesia. There was no histology, there was no detail about the report, and she had delayed wound healing. And you could see the extensive scar on the image in there. So there are no comorbidities, but she had used lots of herbal remedies and laxatives in the previous 1 year. No family histories significant of cancer, but she was the first of a set of non-identical twins in a monogamous family setup. And she takes traditional African diet. So when we saw her, she was cachectic, or active on chronic ill-looking. She was tachycardic, gross abdominal distension. We could see the scar there. There was ascites. And we actually were able to feel a rectal mass with contact bleeding. She came in with a CT scan that showed ascites, showed dilated bowel wall, and regularly thickened the rectal wall. She had a huge multicystic abdominal mass, surgery of an ovarian lesion, and a bulky uterus. All organs were normal. So we had an impression that she had complete bowel obstruction in a young onset rectal cancer, and with massive ascites, possibly from background metastatic disease or a primary ovarian tumor, and probably an endometrial tumor. And we thought that she may actually have Lynch syndrome with all of this happening together. So of course, we successfully had a laparotomy for an emergency. We had 4 liters of stiff fluid drained, saw dilated bowel. There were bilateral huge ovarian masses. One was 1.2 kilograms, the other was 2.2 kilograms, a bulk uterus, diffuse peritoneal nodules, but no liver or other organ mets to proceed. And those are images of what we found in her. So we drained the fluid. We did a bilateral oophorectomy with gynecologist, gave her a signal loop colostomy, did a rectal biopsy. The gynecologist did an endometrial biopsy, and we did a routine abdominal closure. Procedure went well, and her status was satisfactory. She was discharged on the fourth day after surgery, and the final diagnosis after histology was a high-grade infiltration in mucinous rectal adenocarcinoma. She had bilateral serous cyst adenomas of the ovaries, but the endometrial biopsy was not representative, and the pathologist advised repeat biopsy. So these are slides from the histology and from the gross specimen, both from the ovary and from the mucinous rectal adenocarcinoma. And we counseled the parents and the patient on the diagnosis that this was most likely stage 4 young onset rectal cancer with bilateral primary ovarian cancer. There's a possibility of Lynch syndrome. She will need to have genetic counseling on further analysis, and also screening of the second twin and other family members too. And she will need adjuvant therapy and the need for repeat endometrial biopsy, although there was probably a need for a total abdominal hysterectomy because of the ovarian diagnosis. Unfortunately, both the patient and the parents refused adjuvant therapy and further routine evaluation. We didn't see her after 2 months of surgery. She was in saturated clinical state, but she refused to come for clinical follow-up despite multiple phone calls, and we lost track of her. We don't know actually what her outcome is. So this is a picture of what we see in our setup. So I'm talking about the selection, which is the queen. If you ask me, this is the most important slide of my talk. So whenever I see a patient who comes in for surgery, I ask myself 5 questions. Number 1, what is the feasibility of doing this surgery in a low resource constrained environment? What's the futility? What's the operability, acceptability, and the technicality? And I follow a pyramid approach to it, starting from the base and going up to the apex. So in terms of feasibility, I ask myself, can this health system deliver the treatment safely? Do I have theater backup? Do I have the ICU available? Do I have blood products? Is there support for this? Because if you embark on a journey without the feasibility, it's bound to fail. I ask myself the next question, the futility. Will my surgery improve the patient's quality of life, or will it make it worse? Will it improve survival? And it depends on the metastatic burden, life expectancy, the patient's goals, and the quality of life. It's after that I now talk about the operability. Is the patient fit enough for the procedure in terms of performance status, comorbidities, frailty, nutrition, and fitness? And of course, I ask myself, is it resectable? If it's not resectable, can I divert it? And it all depends on the staging. And then the final question is technicality. Can I actually perform the procedure safely? Do I have the expertise to do this? Do I have the equipment? Do I have the team? Do I have the experience and the resources? So this is my paradigm in selecting patients. And like I said, for me, this is the most important slide of the talk. Selection is queen. Of course, we talked about staging, so I'll not bother about this again. And of course, patient preparation follows this standard approach. Again, because of time, I will not bother much about this. So the next point is timing, which is the key to the kingdom. We've talked a lot about the fact that there's a care timeline for our patients, and I'll talk about it in terms of 2 domains. We know that the patients have to follow a routine of diagnosis, decision, discussion, operation, and therapy and surveillance. But in our setup, there's always delays on every step of it. At the same time, you have to talk about surgical timing too, because we need to prepare the surgery at an appropriate time and not conflict with other forms of oncology therapy. So, like we all know, that if you give a patient chemotherapy, it's not safe to operate within 4 weeks of the chemotherapy. If you're giving a patient anti-VEGF or anti-EGFR molecules, it's probably better to wait until after 6 weeks. If you give immunotherapy, you can wait for 2 to 4 weeks before surgery. And for the radiotherapy, the longer you wait, the better. Most people now talk about months, 3 months at a minimum, although it's variable. Of course, we have always said that there's always the issue of the delay. It's the hallmark of cancer care in Africa. And the timing is often the difference between cure and palliation. Now, I can always say that the surgeon may control the operation, but the healthcare system will control the clock. And so we always tend to find our patients at the late stage when there's very little we can do in terms of cure. The next point is the technique, which is actually the meat of the discussion. So, and the technique is the premise. Now, in this era of therapy, what are our aims? We want to have a good oncological specimen that is margin negative, appropriate lymph node harvests, good TME, CMEs, good functional outcomes, good disease-free survival, and overall survival. That is the aim of our cancer surgery. Anything below that in terms of curative resection is unacceptable. Of course, when we cannot resect the tumor, when we cannot cure the patient, we can have palliative resections. We can also do even diversions. There's a very limited role for debulking, but some people still do that, especially in the rectal and cancer space for symptomatic lesions. Now, in terms of the principle of surgery, I look at it in terms of 6 Ps. What is the position of the lesion? And that's quite important, especially if you are doing laparoscopic or robotic surgery. It's probably better, it's always better to tattoo the colon so they can have direct visualization of where exactly the lesion is. Of course, if you're a rectal cancer, you need to know the appropriate levels in terms of using imaging, the MRI scan. So what platform approach do you want to use? Is it going to be an open approach? Is it going to be robotic, laparoscopic? Is it going to be an endoscopic approach? What's going to be your plane of dissection? What does the patient prefer? What is the period of time you're looking at in terms of timing? Is it an urgent procedure? Is it elective or is it an emergency? And what's the purpose of the procedure? Is it going to be curative, palliative, or prophylactic? So I look at these principles in determining how I approach the procedure. Of course, I've talked about the issue of the distance from the lesions and from the inner rectal cancers. I want to know what is an anterior located lesions, because anterior rectal lesions tend to be more tricky and to operate. Lesions that are in the upper rectum are also tricky to operate. And of course, for lesions involving the lower inner sphincter, the ruler classification helps in determining the surgical approach. And of course, we need to know that it's the left colonic region or a right colonic lesion. And the tricky areas are the flexures, the hepatic flexure and the splenic flexure, because those areas are very difficult to mobilize and also for the anastomosis. I've mentioned ruler classification. I will not dwell on it because it's probably beyond the scope of this discussion. And in terms of the platforms, we talk about an open approach, a laparoscopic approach, the regular stick instrumentation, the robotic approach, which is now the in thing in most Western countries, the transcendental approach, and what people call about the third space endoscopy, where you do endoscopic submucosal dissections or intramuscular dissections, or even TAMs. Now, when you compare all of the open and the laparoscopy and probably robotic approach, in terms of oncologic outcomes, they're probably similar. And so I will not really bother about the platform for use. My own impression is that a well-performed open procedure is much better than a poorly executed minimally invasive surgery. And the surgeon's aim is not the technique, but the outcome. Again, it's not the plane, it's the pilot and the passenger. Whether you're flying a jet or you are flying a commercial airline, you must land safely. So the pilot, who is the surgeon, must fly the plane better, and the passenger, who is a patient, must also be safe. I think it's about the pilot and the passenger, and not really about the plane. Of course, in terms of the plane of dissection for it, Bill was one really pioneered the issue of radical rectal surgery for TMEs and getting good planes and margins for our patients. And there are different planes of dissection that we need to talk about. I've mentioned the third space, which is within the bowel wall itself, intersphincteric dissection for low rectal cancers, the TME or the CME plane, depending if you're talking about the rectum or the colon, probably difficult to achieve. And for extended lesions, you may actually have to do an extended lateral pelvic lymph node dissections for the rectum. And of course, if it's involving other organs too, there's a role for multivisual resection as a form of extension in the pelvis, or regular multivisual resection in the rest of the colon. The patient's preference and characters are also important too. So males are difficult to really operation in the pelvis. Obese patients are also difficult to manage. Patients with a narrow pelvis, they have post-sphincteric function before the procedure is difficult. Of course, previous radiation and radiotherapy and chemotherapy can also influence the outcome and your choice of approach. Of course, you need to always divert a patient who has had radiotherapy for rectal cancer. Comorbidity is also important. Patients who do not want to have a stoma, you have to consider that too. If they have previous laparotomies or disc additions or hostile abdomen, too, you have to figure that in place. Most of the time, it's better to do an open procedure rather than doing a laparoscopic or minimally invasive procedure. Of course, there are different options depending on the location. So I'll just run through those things. So for the upper rectum, we do an anterior resection. For the mid rectum, we do a low anterior resection. For the rural type 1 lesion rectal cancers, we do an ultra low anterior resection with a colonial anastomosis. For patients who have a rural type 2 or 3 lesions, we could do an intersphincteric dissection with abdominal mobilization. And for those who have sphincteric involvement, you have to do a conventional abdominoperineal resection. Of course, for patients who have levator involvement, you have to do an extra levator cylindrical surgery to excise the levator ani. And you may have to even do an ischemic APR. And for patients who have a distal rectal tumor with poor sphincteric function, the Hartmann's procedure probably will be the best option for them because that will give them better quality of life. So, of course, for a male patient with obese with narrow pelvis, probably TA, TME may be the best. Robotic platforms can also actually do help for those pelvic dissections. For early cancers, thoracic surgery is important. We've mentioned the issue of extended resections for patients who have a more advanced disease. Of course, for right colon surgeons to do a right hemicolectomy, left colon surgeons to do a left hemicolectomy. For a transverse colon, it's probably debatable whether you do a transverse colectomy or you do an extended right or an extended left. Of course, for the flexures, you have to do extended resections. And for patients who have multiple tumors, synchronous tumors, you have to do a subtubular colectomy. And of course, there's also the issue of having to divert patients with stomas. And sometimes when they come to obstruction, stomas may actually be the primary modality of therapy. I want to talk about other forms of surgery like surgery and HIPEC is beyond the scope of the discussion here. Of course, when I do the surgeries, I follow these steps: access, and then I assess the lesion, confirm stage and accessibility, and then I take action depending on what I plan to do. And of course, I pose or close the abdomen. And then, of course, the post-op care or the aftermath is also very, very important in managing the patients. Of course, there are lots of instrumentation that we need to manage our patients in Africa that are not always available. Allen syrups are not always there. We don't have the dynamic operating table. Sometimes you actually have to use a regular table to operate on the patients. DVT prophylaxis is not always available intraoperatively. The special reductions we need are not always there too. And even a long tip diatomy cautery is not even there for our patients. Staplers are also not always available. Appropriate energy devices are also not always available. So we all have to make do what we have to manage our patients. Of course, there are certain intraoperative steps we need to take, like bowel lengthening. I'll not bother with the details. And of course, and there's always a chance of nerve injury, especially in the pelvis. And you have to watch about that and see how you can spare the nerve so that the patient does not have sphincteric dysfunction or erectile dysfunction or sexual dysfunction. Of course, whenever I resect the bowel and there's a need for an anastomosis, there are different ways of doing that. You can do it as a stapled anastomosis or hand sewn. You always have to test your anastomosis to rule out a leak, because the leak is the most feared complication after bowel surgery and anastomosis. And of course, some people have even talked about doing a delayed anastomosis on day 3 if there is a concern about leak. But of course, in the rectum, after having done anastomosis, if you are not sure or there are risk factors for leaks, it's always better to do a diverting stoma, which does not prevent a leak but reduces the consequences of the leak. I mentioned about the diversion. Sometimes you actually have to do diversion even before your radiotherapy for patients who have bulky tumors or impending obstruction or internal fistulas. And of course, there's always the debate of whether you want to do an ileostomy or colostomy. In Africa, because of the temperate climate, probably most patients will tolerate a colostomy better because of lower fluid and lateral imbalances compared to an ileostomy. Okay, that's debate too. Of course, most of the time we do a loop stoma to allow for extrapyramidal closure at the end, and we wait weeks. Sometimes we actually even wait up to 3 months, if not more, before reversing the stoma. And of course, we have to confirm that the anastomosis is intact before we reverse the stoma. And always remember that a good stoma is better than a bad function. And so for patients who have bad inner sphincteric tone or function before surgery of the rectum, probably it's better to give them a Hartmann's procedure with a permanent stoma, rather than them coming back with all problems like LARS. Of course, there are many pitfalls that can happen after surgery. Bleeding is probably one of the fair things that can happen intraoperative that we are worried about.
Sure.
And of course,
2-minute warning, Dr. Yeah, that's okay.
Okay. And then of course, post-operative complications like anastomotic leak and LARS are things that we're also worried about too. I'm almost done. So quickly about the policies. And we know that there's the dearth of manpower, materials, machines, protocols, money, and minutes, and that's always affecting and influencing treatment of our patients. We know that most of our patients come with advanced disease, metastasis. Even though it's an image for breast cancer, it still relates to our colorectal cancer patients. We know that there are lots of possibilities that are happening in the world too, in terms of advances with wearables, with AIs, with other kinds of monitoring, which you can also harness as in our continents. And coming back to the framework, I've mentioned again that biology is king, selection is queen, and technique is the prince, and the policies are the princesses, and timing is key. I believe that biology determines the battlefield, that selection determines the strategy, policies will determine the provisions available to treat the patients, timing determines the trajectory of survival, and technique determines the template of execution. And because of time, I will not go to the table that shows how we can use this framework in approaching our patients. In conclusion, I'd like to say that we always try to hope, as always. We help whenever we can. We heal when possible. We try to be harmless for our patients, and we aim for happy patients. And a good surgeon knows how to operate. A better surgeon knows when to operate, but the best surgeon knows when not to operate and when and who not to operate. Thank you so much for listening to me, and I'm happy to take questions.
Dr. Ayii, thank you for a fantastic, elegant presentation, very poetic. We're going to segue onto Professor Chite, if that's possible, and then we will then deal with questions at the end of the talk. Thanks very much.
Thank you so much, and thank you so much, Professor Ayii, for the invitation to attend this meeting and do a small presentation. I'll be talking very briefly about building an international cancer center for patient care, education, research, and how to get started and filling in the gaps. And I'm going to use the model that I've developed here in Kenya, the International Cancer Institute. These are our 5 or 6 or so core areas. And there is clinical care, obviously. We must provide care, education and training, capacity building that I see Dr. Akwi's team do a lot of. There's research and including clinical trials that is very, very pertinent. And we don't really have a lot of clinical trials from Africa, as you know. A lot of partnerships, advocacy, policy, and ensuring that we are strengthening the public healthcare system and not creating parallel programs. And our model generally goes within the same approach. So we call this ICI approach to care, where we have education and we ensure that you not only train the healthcare providers, but you also train the community, because without the community being knowledgeable, then the awareness also in the community becomes a stumbling block. And then we also have community, obviously, screening and early detection. Then optimal diagnostics and improved pathology. Access to therapies is very important, including palliative care. And then data, we also have telemedicine and obviously research. One of the components that is usually missing in a lot of programs that we've seen across Africa and some of our partners that we work with, a lot of emphasis on leadership and especially, agreements in partnership, policy and advocacy, as well as obviously we are having a lot more patients surviving cancer. So survivorship care. I won't go into a lot of details of this, but within International Cancer Institute, we have a Center for Data Training and Research. We have Center for Clinical Care and Community Outreach, where we do diagnostics as well. And then we also have an Office of Community Outreach that is very important to us. And then we've created something like a McDonald's-like space where we've been renting this space for the last 6 years. We call it the Wellness Center, where we do some patient support as well as empowerment activities. This is specifically for those patients who come from very far to our site and don't really have enough funds for hotels, but at the same time, they're not sick enough to be admitted. So capacity building, obviously, to create a multidisciplinary integrated cancer care within these training programs, and ensuring that there is mentorship and supervisory support for quality routinely. So we created several courses, and I know this is something you've already done with the CRC various programs. We have some non-clinical programs that support clinical programs, and we also endeavor to do quite a number of workshops. And we have some highlights of some of the activities. You can see all these courses. There are more than 100 in all. Some of them are 6 to 8 weeks of preceptorships online courses. We also had, colon cancer course, and we have rectal cancer course as well, which was 6 to 8 weeks online. But we don't really have any skills workshops that we've done with this. So we've done more within breast cancer, prostate, and cervical cancer, more than anything on colon cancer, except just treatments. So with ICI capacity building, we engage several places. We have to engage faculty drawn from all over the place, various countries in Africa, but also in Europe and the US and India, and then quite a number of participants across board. One of the areas that we notice is very, very important is the mentorship, going to the various clinics and actually sitting in clinic to be able to see the specific challenges the clinic is facing and how they can actually rise to the occasion. So not all these 17 clinics plus that we've helped establish together with the Ministry of Health of those counties are the same. Some are actually further than others. Some are giving chemo, some are doing, including surgeries and the like. And then we also have the multidisciplinary virtual tumor boards that we do every Mondays and Thursdays for the last 5 years. And these are very important, and especially so to connect those various centers to be able to discuss various patients that they are seeing. The other areas is using some of the digital platforms like digital pathology has really been very helpful, both in training for our trainees, but most importantly, in support for turnaround times for the patients who really need their results very quickly, and also ensuring quality, where we can actually be able to review these slides centrally in a hub and spoke manner for those centers that are subscribed to our center. But this is also important that not only do you do the class dry trainings, but you also do those skills-based trainings, because it's very, very important for the participants to be able to know that what they can do and how they can do it, and actually how we measure quality indices on the ground. And we've done that for cervix, we've done that for breast, and we've done that for prostate as well, both in Kenya, in Rwanda, in Uganda, and in Tanzania. Some of our collaboration partners, including Eswatini, as well as Burundi. This is just part of attending one of the surgical training skills. These are groups of surgeons who do mainly breast work. And then we have some breast oncologists, surgical oncologists that come in and are able to assist. So when you look at trainings, we realize that not only are we doing the clinical preceptorships where you are looking at breast cancer, cervical colon cancer and lung cancer and the rest, but we realize that there are some other components like health communication, project management, M&D, supply chain, commodities, and all that in grant proposal. So we included these as part of our non-clinical programs, because we really need to create a team that is well-rounded, that can be able to not only apply for grants, but also be able to manage them, and at the same time, be able to provide the quality services on the ground. This is just an example of scheduled training programs. These are some of the cadres of staff that we've trained over the period of years. And so digital innovation, the multidisciplinary boards, the telemedicine and tele-mentoring, digital pathology, the virtual courses. The only major one that we have not really fully implemented is the ICI Access to Medicine. We developed this program where we have digital tools to access cancer chemotherapy and ensure chemotherapy adherence and follow-ups in the various satellite sites. However, we've not really fully operationalized this in our setting. Then opportunities for upcoming trainings. I won't belabor on that. The most other important point that we've noticed is community outreach. So we've done, doing community outreach as you build your program is actually a huge plus. Quite often we are saying these patients are presenting late to our centers. But one thing that I noted is that for my breast cancer patient, metastatic breast cancer patients in 2010, when I looked at about the first 100 patients and looked at their navigation, their journey to the clinic, we found out 25% of them had actually been seen more than 14 times before a diagnosis was made, because they are being seen in various clinics in their rural homes, and then they are referred in a very poor navigation within the system. So our referral patterns of the healthcare system was actually to blame more than the patient themselves. They present to the clinics or the various healthcare providers, but they are not really actually attended to as they should. So we developed this community outreach office, and where we are able to go to the communities and work with the counties to be able to do this. And you can see the other lesson that we learned is the fact that when you do a program like this, instead of making it a vertical program like breast only or cervical only or colorectal only, it would be nice for you to integrate these services. So when you do some screening activities within those communities, we do screening activities for hypertension, diabetes, cervical and breast cancer at the same, and prostate for the men at the same time. Hopefully we shall integrate and include colorectal. And now one of the things that we are looking forward to doing is also including mental health as part of these screening programs. Advocacy, we always, even when we're doing breast cancer and cervical cancer, as much as it's women, it's important for us to also address all, including men, because some of them are actually the financiers of the activities that the women in some of these communities are doing. So for instance, if you write your program on what you would like actually their treatment to be, you find that there is a man somewhere with a person deciding on whether they should come to clinic or not. So informing them and ensuring that there's awareness across the community is actually a very important thing. Data will drive progress. And then one of the major missing areas in most of the programs we noticed was linkages to therapy. So people will come to the center, do some screening or opportunistic screenings, and then they don't really have a back end of things where they link these patients or participants to care in case they need. So they'll tell them, you have breast cancer is stage what and what, and then there is no good navigational system. And you notice that you end up losing a lot of patients to follow up. And the same people actually come to your clinic several years later with metastatic disease, asking you why you did not really advise them better. So we usually do some of these things of ensuring that we have a navigator, both a lay navigator as well as a clinical navigator. And then obviously optimal diagnostics, it's important. I don't belabor that. We have several programs that we initiated across East Africa called Blueprint programs. And most importantly, we are looking at various pillars: the education, the clinical care, the community leadership, the IT, and pathology. As we've said, these were the pillars for these programs. And we've been able to engage several partners across the region. And one of the other areas is that as we develop, we have to also be developing some other regional centers of excellence so that not all patients are being sent to one site. That beats the purpose of, access to care. And so some of this, including establishing pathology centers, we assisted in establishment of Meru Teaching and Referral Histopathology Laboratory that is still running to date. This was about 5 years ago. And this is the center now. We ensure that several of those counties out of the 17, about 6 or so, now sent their biopsies to that site. And that really helps some of those sites not only grow, but also helps grow other sites that become regional centers as well. And then not forgetting survivorship care, palliative care, and support groups that becomes so important to the mission of improving quality of care in the region. We also have our care and research clinic, not to belabor a lot, because as we do all these things in the communities and as we assist other centers, when patients are referred to our center, we have to ensure that we are taking care of them and we are using standard of care, or we are putting them on clinical trials. And these are some of the ones who had more than 10,000 or so patients sent in a couple of years. So this is the wellness center. Some of these patients come, they take 3 or 4 days to get to our center. And to turn around, and especially, you remember, most of our sites do not really have everything ready. Like, for instance, they may be coming to do staging workup and they come to get all the CT scans or everything on time. And so instead of sending them back 3 days away, which will lead actually to a lot of loss to follow up, we usually house them in a center that is McDonald's-like. It's very basic, but it's very functional, and it's been around with us for the last 6 years. It's almost always full with about 15 bed capacity, but also some space for their caregivers. In this center, we also train them on some other things, because some of these patients may come to clinic for an hour or two, but then they have the rest of the day off. And so they can learn a few things: tailoring, dressmaking, and then various other things, as well as farming, of course. This integrated pathology has been very useful for our virtual tumor boards, and I think this is something that is so easy to do in most of the centers, where most of the sites can just be taught on how to do very good biopsies and all that, and they can be scanned into this whole slide scanning system, and then they can be sent, and you guys at MDH can be able to assist in review as well as participate in those tumor boards. This has really, really been helpful for quality of care. And obviously, there are various other activities that we do in our setting. Research is very, very important. This one is what I'll finish with. And we have to develop research, but not in the absence of clinical care, of course, because as much as research we really have paucity of data from sub-Saharan Africa, especially in terms of research, not only in colorectal cancer, but all cancers in general. We account for less than 1% of the clinical trials that are done in cancer space worldwide. And so that is not, it's very, very unfortunate. And so ensuring that you can ensure that your a site or two or several other sites that develop clinical trials ready is very, very important. ICI, we are now well over 40 global clinical trials, both in phase 1, 2, and 3. We have a huge group who are, some of them affiliated, but some of them are 100% ICI staff. And then ensuring that we have laboratories that can be able to, when they are coming for their SIVs and all those, so even the pre-selection visits, they can be able to see that your site is ready. Some of these, they don't have to be in every site, but creating some centers of excellence in specific things would actually be a way to go to ensure that they are all collaborating. However, each one of them is picking something that they are very good at. And obviously archiving and several other partnerships are involved. And all these are part of it. We've done more than 4 breast cancer studies, a couple of esophageal, lung cancer, sickle cell, more than 16 now, and other studies. We are looking forward, hopefully in future, to doing some colorectal studies. So last slide is what are some of the barriers? Obviously, financial resources, and especially as you know, globally, some of the grants mechanism and all that has really changed in so many ways, as well as the ability for a lot of researchers to carry their research with the financial constraints. However, working very closely with the government ministries of health, as well as various insurance companies in country, sometimes they can help in deflaying some of these costs. Obviously, infrastructure is something you can build slowly with time, regulatory and ethical challenges. This one is actually very unique to each country, and each country just has to sit with the regulators and say, how can we improve on the regulatory turnaround time so that we are not really locked out of the global recruitment in trials. And then operational barriers, these are so specific to each site. I'm willing to listen more to more sites and what you have on this. Limited capacity. We are always creating capacity and training, and I'm so glad for programs like this because you're also not only creating the knowledge aspect part of it, but you're also creating capacity both for care and research. And obviously, there are other competing health interests like HIV and all that. This will always be with us. However, one of the ways in which we've noticed that works very well is how can we integrate some of the priorities and approaches to ensure that they are covered. I would like to welcome you all to Eldoret, for those who you may be in Kenya so that you can come to our side. But the other thing is, as the chair of Kenya Society of Hematology and Oncology International Cancer Conference this year, I'm welcoming you to Mombasa in November 18th to 21st for our conference there. So these are some of the services we offer. I think I'll stop here and wait for questions. Thank you.
Thanks ever so much for another excellent presentation. I am just scanning the questions and the chat. We have 10, 15 minutes for questions. So if anyone has any questions, just pop them into the question and answers or onto the chat to everyone. There is one, I've got one or two questions, but there's a question from Dr. Babajide Oladayo. I'm assuming it's addressed to Dr. Ayii. It's a surgical technical question. And he reads, excellent talk as usual. I would not expect less. And you described a loop colostomy as it aids extraperitoneal closure. What of an end colostomy for a patient with a low rectal tumor who might require AB resection later? Dr. Ayii, any thoughts on an end versus a loop colostomy for dysfunction in a patient with a large rectal lesion?
Yeah, thank you so much for reading out the question, and thank you to Babajide. Nice hearing from you after a long time. So it's a very interesting and technical question, and I agree that there are nuances that I'll call here. So in the scenario as he has painted is for a patient who has a rectal tumor, who I assume has had a stoma before neoadjuvant therapy. And the question now is, if you're going to give a stoma, should it be a divided stoma or a loop stoma? So usually we give a loop stoma if you have in mind that you're going to reverse it and you want to do the reversal in as easy a manner as possible. But I agree with his point that if it's a low rectal tumor, with the mindset that the patient will end up having an AP resection, then it's probably better to have a divided stoma so that you will be able to just take out the distal limb of the stoma with the rectal specimen and sigmoid column as your resection specimen, and leave the proximal part of the stoma as the end stoma at the second stage of the procedure. So it's actually a technical question, which I agree, but 25 minutes was not enough to cover all the points in surgery. I don't know if I've answered the question to his satisfaction.
Yeah, that's a good answer, and I would agree with that sentiment. I think that if someone's got if you're not going to be rejoining the patient, and it's a low rectal tumor, lower third, then I think technically end colostomies are easier to manage for patients than loop colostomies. They tend to prolapse less, etc., etc.
I think there's a question from Anne Olute just before.
Oh, yes. So you've seen that. So the question from Anne is for a lady who is 49 with a fungating tumor in the ascending, a tumor in the descending, both regarded as hygrodysplastic, and a transverse colon with mild dysplasia, multiple nodes. What would you suggest as best line of treatment? Neoadjuvant chemo, total that's a great MDT question.
That was exactly how I was going to open with that. This is an MDT style of patient where there's a diagnostic dilemma. Your gut feeling says that this is cancer, but you don't have a confirmatory evidence. So I think ultimately to start with, the tissue is the issue. So how loud I put this patient have been, can I get a second pathologist to look at the slides to see that what they called high-grade dysplasia may actually be invasive cancer? And that changes the picture completely. And is it possible to get a second histology biopsy if the patient is willing and is convenient and cost effective? Because the patient now, she's pointed that this is a patient who's less than 50 years. So you are seeing young onset cancer, multiple tumors. There's a chance that we're dealing with something syndromic, Lynch syndrome. There's a possibility that if this is cancer, it may be MMR deficient. And if it's MMR deficient, there's a chance that the patient may actually require immunotherapy. I noticed outside standard of care, but Foxtrot 5 talks about giving immunotherapy as a neoadjuvant therapy for this kind of patients. So, but in a scenario where you cannot have tissue, you cannot start chemotherapy or oncology therapy without the tissue diagnosis. And so you are left without any other option but to go and operate on the patient and do an oncologic subtotal colectomy, take out the lymph nodes, and tell the patient that there's a chance that it will come out as cancer, and a chance that it will come out as benign, but we're not sure. Better to be safe than sorry. So the parent will have to now decide if she wants to go through that risk or not. Being many people, there's a ascending colon tumor, there's a descending colon tumor, and there's a lesion in the transverse colon that is said that to be low-grade dysplasia. So, and then it's also possible that if this is a patient who is MMR deficient, the lymph nodes will just be reactive and a sign of immune response rather than metastasis. So we need tissue, but if we cannot get tissue, then we have to operate. That's my thought.
Hope that answers your question. Tissue is always the issue. Question for Professor Chita, if I may. I really liked some of the work you have done around digital pathology. And what's your thoughts about scaling that kind of work up? My perception from your talk is that is something you've done in some regions in Kenya or Southeast Africa, South and Eastern Africa continent. What's the feasibility of that kind of work being scaled up across broader parts of Africa, or in some sort of collaboration with the NCCN that we discussed or hearing about earlier, for example?
Actually, that's a very good question. And it's actually very, very feasible. One of the things people don't realize is that the rate limiting step, there are actually two. One is the partner should be willing because they need to be participating in uploading the biopsies and all that. But the thing that we realized that was the rate limiting step is not actually the pathologists, it was the histotechnicians. That you have to go to these sites and multiple times be able to train these histotechnicians because the pre-analyticals are so important. Since once you do this whole slide scanning and you send it across the world, if it has artifacts and other things, obviously it will just be as bad as the tissue that was collected. Because we noticed, especially for breast cancer, that some of the times surgeons would do the surgery on a Friday afternoon and just leave this whole breast, on a bench or whatever. And then on Monday, people collect it and they start staining it and doing, cutting it, and that is not good. So for us, we decided to develop a 16-week course for histotechnicians, and after doing the online course, we actually went to those sites and trained them in wet laboratory procedures, and then shared with them SOPs for this. So this is highly scalable. We are only working with 4 surgeons, 4 pathologists who are local pathologists who are reviewing this digital pathology platform, but you could expand it to include pathologists from anywhere around the world. So not only can we expand the platform, but we can also expand the utilization of it and be able to develop some videos that can be used in your MDTs when you're discussing the specific patients. So it's highly doable.
That'll be interesting. It'll be interesting, Akwi, to sync up some of that work with Dr. Rotimi, who's one of our NGO pathologists. He does a lot of work in different parts of Africa along those lines. Any more questions? I'm just double checking there's no, one more question's popped up. Thank you very much. That's an answer. Okay, great. No more questions, Akwi. Yes, sir.
And Dr. Segun, the other thing that we noted is that sometimes some turnaround time for pathology takes so long because sometimes a pathology is waiting for another one who was on leave or whatever to come and review so that they can have a consensus.
Yeah.
That actually is obliterated by the fact that you just put it online and you can invite any specialist pathologist. Like, for instance, when you're looking at breast cancer or, colon cancer, you can actually have colorectal pathologists from any center who you can say, hey, this is the case, this is the story. Can you able to help and review this? So it actually helps both sides because also the pathologists who are not specific specialists in some of those areas really learn a few things.
Can I ask you a controversial question if you've raised that issue then? What about the issue that I've heard about, I won't say where or who, of AI reporting pathology slides?
So I'll tell you, even if AI reports, AI is not registered to practice in Kenya. So, so you can't sue AI. So there must be, even when we are looking, actually, that's a very good point. And before we even started talking about AI, we started looking at the issues about if a pathologist from India reports, and that report, you take it and treat your patients, and it's a wrong report for any reason. I'm not saying there is a wrong report, but just because who is to blame? Is it Cheetah? Is it the digital pathology platform?
Yeah.
So what we said is that we must have in country the pathologist who is the overall pathologist who signs off on those reports, because most of the time they are sending, they also have their own thoughts about the case. So when now another pathologist reviews and sends their report, becomes more of a recommendation to them, and the final report is actually written by these four who are registered in Kenya to practice, and they can be sued in case anything goes wrong. So AI will treat it in
I
the
have,
same
I mean, I'm being facetious, but I have seen reports and reports in Scotland. I've seen reports that state that will seem to caveat the report by saying that there may have been some AI involvement in the reporting. I'm never quite sure the extent of the AI involvement, yeah, I'm wary. I think some of that stuff is inevitable actually for
Yes.
radiology and pathology. Inevitable.
Yes. And I
Because
think just like now when we are doing review of peer-reviewed articles for these journals, international journals, we always say, please let us know if AI has participated in any way in this so that we see the extent to which AI has done. However, for things where it relates to patient care, we actually say that things like AI should be supportive of those pathologies, but not replace them.
not replace. Absolutely, exactly. Important caveat. Yes, Akwe, sorry.
Yeah, and I have actually have multiple questions. You've started this problem, so I'm gonna continue along that problem of discussion. So I have multiple for Dr. Chithi and then one for Dr. Dere. So just kind of working backwards, you actually made a very important point about the licensing component with the use of AI. I actually don't think I'd given that much thought. We attended this global health clinical ethics course, not course, but program that discussed the use of AI. And there was, a lot of support of having AI participate in providing the diagnosis for pathology, because some of the challenges in colorectal cancer care is the delay in diagnosis due to the workforce, the lack of pathologists. And so I don't think I realized, which is a good point, I don't think I gave it much thought that the report needs, quote unquote, you need a medical license, I guess, so to speak, to provide a report. And there might be some legalities associated with having a report by AI, because it goes to the question of who's responsible. That's what I'm getting from what you're saying. Is that correct?
Very true. So when
Okay,
you are taking care of the patient, we assume the pathologist assumes the entire responsibility of that pathology
got
report.
it. Okay.
So even when we invite other pathologists, like we can have an MGH pathologist who is a neuropathologist to
Yeah.
help our general pathologist on anything, we can't have the report from your neuropathologist be accepted for the management of the patient in Kenya. We'll actually
Mm,
want our own pathologist review and write his report with those recommendations in mind so that he can be held accountable for whatever he does. So even with AI, we would actually expect that. And by the way, just a quick one,
mm,
we even evaluated use of PDL1, looking at AI to be giving us results. And even breast cancer, we wrestled with the same problem
yeah.
because we said, if it's taking so long, why don't we, since it's a whole slide scanning,
Mm-hmm.
because actually AI can tell you, we think this is cancer. But
Mm,
the question is now whom do I sue if I'm treated
right.
for cancer for and then at the end of it there was really no cancer and actually human beings review it. So we think it's a supportive tool but not a replacement.
Yeah, and then so the other two questions, and part of the background is, I've worked in different African countries. It was kind of new to me where we hand specimens to the patient, and then the patient takes the specimen to find a lab. Because and this is I did some research on gastric and colorectal cancer, and that was a new thing. You give the patient or their family, you know, I know we're talking colorectal cancer, but like, the breast that you just resect, so then they take it to a lab, a private lab and things of that sort. So I guess the question, sort of two parts. Number one, you use the term integrated digital, pathology. If you can just explain what that means. Then the second part, which might be beyond the conversation today, if you can expand on funding is basically what I need to ask you. And then just to be blunt, where are you getting the money to host these amazing programs? Like I was texting my buddies on the side, the moderator, I'm like, I need a McDonald's house. So how are you getting funding? How are you getting funding to support your programs? And then that's the same question I have for Dr. Day in terms of like funding for surgery within the continent, right? So some of the challenges across the continent is we want to get this done, but we're not putting the funding to get it done. So how are we getting around that funding component to be able to prioritize the care of colorectal cancer patients or just cancer in general? So those are really long questions. I know we're almost out of time, but if you could start,
So
Chitty, and then
I'll start with the first one just quickly. I'll probably just take a minute. So if you want to improve quality of care, and this is what I've noticed for breast cancer, in Kenya, people used to do the same. And I said in my program that should never happen. And slowly by slowly, we've involved the government in various policy making and saying that you should never hand the patient their biopsies to walk around with them and then bring them at will. We don't really think that is good. Not only do you not follow protocol, obviously, like where they are taking it, how they are storing it, pre-analyticals as important as post-analyticals. And obviously, when they take it to the center they take it to, you don't have the ability to know the quality of care there. And some pathologists can just report whatever they are reporting. I mean, if they are in need for money. So one of the things to ensure that if you are working together, we work together, like for breast cancer clinic, we would work together with the surgeons, we would actually be in the same, because the issue of neoadjuvant therapies was also not really well taken in 2010. Now everybody knows. Locally advanced, obviously, want neo. But for pathologists also being part of the multidisciplinary teams, we noticed that really helped a lot. And that's how we actually identify one of the biggest problems was technicians. The histotechnicians were not really following protocol or SOPs and all that in terms of preparation of the specimen. So handing the patient, I think it's a no-no, especially if you want to improve quality. That's my thought. And for the funding, these collaborative partnerships are very important. Like right now, we are collaborating with various countries in Europe and some in Africa, including South Africa, for esophageal cancer and gastric cancer work, and we are being supported by European Union. So each of these becomes, and that's why I really like the way you say fill in the gaps as part of the thing. So you spread out all these pieces that are missing, and you look around and say, who can help me with this? Like for instance, we do palliative care, but we are not the best in palliative care. So we have to actually partner with Kenyan Hospice and Palliative Care Association for various palliative care components, because that is their 100% work. And if you go into that space, you find you're stretching your little dollars while you could be concentrating on something that is much more effective for the interdisciplinary care.
Okay.
So we get grants, that's for sure. We work with pharma very, very closely. Some of the aspects are covered by various county governments. So every program we integrated for these 17 counties, we ensured that they had skin in the game. So it was not an International Cancer Institute affair. It was their county affair with support from ICR.
Got it. Dr. Dede?
Yeah, so I'll just quickly respond to both questions. I think the issue of the pathology specimen handling is also very important too. So as a surgeon, what I've noticed in the two sectors in Nigeria I worked in, private and public, is that the culture is different. So in the private sector, that is in Nigeria, the hospital takes responsibility for the specimen and gets it to the pathology lab, whether the lab is in-house or is outsourced. However, some patients will claim that the hospital is adding some extra charges. I'm talking about the private hospital for that service. And they will prefer to negotiate that fee on their own. And so they will say they will take the specimen on their own. So that happens because sometimes when you insist that you want to take the specimen on their behalf, they will say, no, you're trying to rip them off and they want to handle that aspect too. So it's at their own detriment. It's not right, but it's a cultural thing. The flip side is that in the government or the public sector, you expect that the department should handle the specimen. However, for many reasons, some logistic saying that we don't have porters, we don't have the mechanism, they would hand over the specimen to the relatives to take the laboratory and say that they are the ones who are responsible for anything that happens to it. So in short, you have divested the responsibility and put it on the patient so that if the specimen gets missing, which happens sometimes, you say the patient's fault. So it's not the ideal, and I agree that it's a no-no. I agree that it's not the ideal, but it's a cultural thing that at least in the area of practice in Nigeria, is prevalent. Hopefully things will change as people understand the importance of handling specimen. That's one side. In terms of funding for surgery, I need to be very honest. I think we've mentioned it many times today. Financial toxicity is a major problem. It's a clear and present danger. For example, a patient who needs to have rectal cancer surgery, rectal cancer treatment, not just surgery, chemotherapy, radiotherapy, surgery, the follow-up, they will spend in Naira terms, Nigerian currency, they probably spend close to 5 million Naira. And the minimum wage in Nigeria is 70,000 Naira at present. So comparing millions of Naira to 70,000 Naira. So that is going to be bankrupt. We're not going to survive that. So you end up not going for treatment or getting part of the treatment or having to depend on philanthropy, having to sell property. So I have cancer patients who tell me that they would rather send their children to school, get food on the plate, rather than pay for chemotherapy. Because you have to choose between care and normal daily life. And our health insurance system is so bad that less than 5 to 15% of Nigerian population, talk about Nigeria now, has some form of insurance. So the majority do not have insurance, and so they cannot access the care. So it's a major, major problem that has to be sorted. I know that our government has been trying to do things about it, but it's still not enough. So I need to be honest. We just have to, sometimes we cut corners, which is not the ideal. We try to do things to make sure that the patient gets the care, but it's not always enough. So financial toxicity is a clear and present danger.
Thank you. I have one last question, Segun. Just give me that one last question, and then I know someone had raised their hand, but whoever it is, if you can type your question in, and I can blame Dr. Ademola for having me ask this question. And I want all the panelists to actually answer this question. So the something you mentioned, it's our culture, right? And I feel like sometimes there are things we're doing and we're blaming it on our culture. You know, this is our culture. We're doing this because of our culture. So I guess the question is, and this might be a heavy question beyond the goals of our talk today, how do we get beyond our culture in terms of trying to advance colorectal cancer care? How do we get beyond, we don't have reagents. I'm not sure what our culture has to do with not having reagents in the lab. How do we get to the point where, and we've got the quote unquote younger generation, Dr. Kizza-Brown and Angelo Autiak are my replacements, is what I'm saying. At some point I have to lay to rest, so to speak, and we need to train our replacements. And so for our successors who are coming on, we can put the blame on them. So how do we quote unquote edit aspects of our culture to be able to promote adequate patient care, whether it's the whole concept of the pathology lab, like, maybe Dr. Chiti shares what you're doing in Kenya. Both Dr. Dede and Prof. Bello can share what the culture can do or can be done in Nigeria for colorectal cancer care. It's a very heavy question, I know, but like I said, we can blame Dr. Ademola for bringing the culture as a cause.
Yeah, well, can I quickly go so that I don't get blamed for extending? Sorry about it. But the thing, Prof. Bello, nice seeing you again, sir.
They got you, man.
Yeah,
they got you.
Yeah, but the thing there is that when I say culture, I think it's in two dimensions. There's a medical culture and there's an inherent socio-cultural component. The medical culture will require education, will require a mind shift. And you need the critical mass of individuals who are ready to change the narrative. We're already doing that by having this webinar. And all the stellar speakers who have spoken very well, very clearly, and with such succinct manner. So I think we just need to generate that critical mass and then transfuse and transfer that mindset to the upcoming generation so that they don't adopt the things that we saw ahead of us. In terms of the general prevalence, social and economic culture, I think I can't answer beyond that. Well, I'm talking about more of the medical culture and what has been baseline. I rest my case now so that I won't be blamed for extending.
So, Doc, I'll say two things. One, and I've noticed this. There's a time I was running a program in Southern Africa, and when I went to this hospital, they said, and it's a major hospital for the country, and they said, we don't really have pathology. All their biopsies are being sent to private hospitals. And then I went to their lab and I talked to the pathologist, and we found all this wonderful equipment that has hardly been used. So I said, it's not that you don't really have equipment. They actually had newer equipment than mine in my own lab, and I always think I have some of the best. So I sent a team of pathologists and histotechnicians, and we were there on the ground for 3 weeks. And we were able to train them and read all their biopsies with them in their pathology lab. So some of it, and I think it's some of it is mindset. And some of it, they already have some of these things they are not using. And sometimes the equipment is actually just stored. But most importantly, one of the major things I wanted to point out is that us guys, as healthcare professionals, we sit in our meetings and talk like this, and we have all these good qualities and what we want, and then we wonder why it's not translating to care. Part of it is that we need to be in those policy meetings. We need to attend those advocacy meetings. I realized that sometimes you attend and you really want to pull your hair out because of some of the things you hear in those meetings. And you're like ERPR, HER2, and Ki-67. These are important things for any breast cancer patient. And they're like, some of these are not important. We need the drug. So it's important for us to take some of our knowledge to some of these policy meetings. And I realize it's not a waste of time attending those meetings, even though they may be very boring and very repetitive.
Can I? Well, I have a different perspective from most of the things. I mean, I don't think it is just culture. For me, it is health system. It is our health system that is totally disconnected with the reality on the ground. And that's what I mean by health system is that, I'll give you an example. When I was, trying to develop the study for the colorectal cancer using, nivolumab. And then we had to, get sure that we are able to do MSI testing at the National Hospital in Abuja. We did all the necessary things, go to NAFDAC, get this, get that. And then we were, running helter-skelter to get reagents and trained all our pathologists to be able to do it. By the time we got reagents and were ready to start testing, they now realize that the machine that we have has not been calibrated to do MSI tests at that point. So you see, this is total disconnect. Now we had to start, literally everybody just told me, I'm sorry, you are the PI, we don't know what to do. This thing cannot work. So I had to start looking for who is the technician that can actually tweak this machine to be able to, because getting another machine will take another 1 year. And we already have nivolumab donated by BMS, right? And then we can't tell them, come and take your drugs. And it took us almost 2 years to get through the bureaucratic bottlenecks and, regulatory agents to allow us to get donated nivolumab, which is not like we are doing a clinical trial because it's approved everywhere on metastatic colorectal and all that. So if not for the grace of God, I mean, that's what we say here, God does miracles. I had to go and start looking for the technician that knows about the Ventana machines that were donated by Roche and all that. And I sat him down and showed him how important this is for it to work. And within 48 hours, he was able to tweak it and make it happen. And we were able to do MSI. But nobody was ready to do anything. Everybody just folded their arms and said, we can't do it. So it's a system. I think we need a system that will change the mindset of everyone that is working in the system. Our mindset is such that we are just after how much we're going to make, and if it doesn't work, too bad. And that is why what Ademola is saying, in government hospitals, nobody give a heck. Take the samples. In fact, it's not only pathology. If you go to my clinic when I'm not asked, in fact, I'm not mandated to know the type of drugs that the patient is bringing in. What I need to do is just write a prescription, hand over to the patient, and he goes and sources the drug, whether it is substandard or whatever, and it is administered. And we try as much as possible to change that narrative. When I was head of department almost 20 years ago, I tried to change this and insisted that every vendor must pass through a kind of probation or sort of, to make sure that his drugs are standard. We know the sources, and so it didn't just happen. It's like I'm trying to stop them from making money, or I'm trying to support the patient. So system has to change completely. It's a health system that we must make it work. Otherwise, these things will keep happening. It's not only pathology, it's not only radiology. I tell you, the things I see when I'm running this study is simply unbelievable.
Yes, that's a very good point to finish on. I think we need a coalescence of people who are very good intentioned and hopefully, and I think people who keep trying in difficult circumstance to work and avoid a culture of learned helplessness, and then we keep going forward, and hopefully Africa and Africans will eventually get the leaders that we deserve, who care more for the people and the population than their own pockets, and then we might start to see some proper resourcing, which leads to proper change. I think we should conclude the discussions there, Akwi, and I'll turn over to you for any kind of concluding statements or business.
Yeah, no, once again, I really, really want to thank each and every single one of you. I want to thank you for your time, your dedication. And usually, when I ask people, for those who present at international, national meetings, it's a lot of work. People look at their schedules, moving things around, and I am just so grateful our speakers were able to work with us. They were able to last minute move things around to accommodate another speaker.
You are fast.
Yeah, and and you provided a very rich discussion. The moderators were just like, there's a lot of questions. We're not able to get through all these questions, and which we did not. And we're just like, you know what, we need to all meet in person and have more than like a half a day, type of discussion. And hopefully one day, and so I'll have to speak with Dr. Chitti on the side, like, all right, tell us about this money stream so we can tap into that and we can all meet, whether it's in Mombasa or Zanzibar or Livingston. It doesn't matter. We'll just meet
Zanzibar
somewhere.
is good.
But I am really grateful, and to the listeners, to the audience, I think one of the key takeaways is just remembering that it truly is preventable, colorectal cancer, that is, and early detection is key, treatment is key. The multidisciplinary approach of patient care is critical, knowing who's taking care of you. And it's not a competition. We're not competing against this person or that person. The ultimate goal is a great outcome for the patient, and also respecting a patient's decision. I think, as Dr. Komolafe mentioned, not every patient wants treatment, and that is an option, right? No medical, surgical, whatever treatment is actually an option for the patient. So we respect their wishes as well. But these conversations are very, very enriching, and I am very, very grateful. Hopefully, some of you will join us in Zambia in about a week or so. It's been an interesting journey. We're focused on tissue as the issue, so we've got pathology and surgery as our key focus for our trip this year. I will put up the slides again. This has been recorded. If technology works, this will be posted on YouTube. It didn't work for the live stream, but let's hope we can upload this onto YouTube for everyone to see. And so on that note, once again, just very, very grateful to each and every single one of you, and to Dr. Kizza-Brown and Dr. Autiak, who were doing a lot of the background work, getting the flyers and all of that stuff together. Super, super grateful to you guys. So everyone have a fantastic day. So good morning, good afternoon, good evening, and good night to some of you. I'll stay online just for a little bit, just so I can keep the code up if anyone needs it. But thank you so much, and blessings to all. Take care. Talk to you later.
Thank you.
All right.
Bye, everyone.
Nice to see you. Long time.
Nice to see you too. It's been a while. Let's connect offline sometime.
Indeed.
Thank you.
You've
Cheers.
been hiding,
No.
And
I've
I'm
been crazy.
seeing,
Prof, let's meet and have a Zoom at some point. And come to Kenya, by the way. I'll invite you. November.
Please, I've been coming. It's Eldoret. You need to call me.
Yeah,
I've been coming to
when
Kenya.
when you come to the
Now,
Mombasa.
thank you so much. What's happening in Zambia?
We're having the colorectal cancer workshop. I just put the flyer up. So we're all traveling. Yeah, we're going to, we usually come to, we were in Abuja and in Kano and Lagos. This year we're going to Lusaka and Ndola in Zambia. So
you didn't invite me. I would have loved to come.
you know what? I have you on my list, and we are totally bringing you one of these days for sure. So yeah, no, this is the information, but we're going to
It'd be
Zambia next
nice.
week.
TK, you must go. Zambia is my second home, so.
Well, Prof, if you say so, just some logistics, Prof. I would love to.
Yeah, well.
Yeah, I think let's see the dates. Then Dr. Aki,
Yeah.
I'll confirm. It would be
Yeah,
nice to
let's see
meet.
the date too, yeah.
All right.
And we haven't really, as ICI, we haven't done so much in colorectal, so it would be nice to learn a lot and see what we can do together.
You know what? Now that you've put it
And-
out into the universe, Dr. Chithi, how dare you plant the seed? And you've started some trouble. So our
No,
2027
Prof is putting me in a lot of trouble now. Anyways, I
apparently.
would love to.
So it looks
I
like
He has
we
been
might go
doing
to
this for the
Kenya.
last 20 years, man. So he's
Yeah.
good at it. No problem.
And honestly, Dr. Aki, I think
Yeah.
this is, one brick at a time. We do
Mhm.
breast, we do cervix, we are in colorectal. I mean, slowly by slowly, and we unite those groups and integrate.
Absolutely.
And we share what we know. I think we'll go far. So
absolutely. All right. Thank
okay,
you,
thank you
everyone.
guys. I'm
Thank
off.
you.
Thank you.
We're going to Kenya in
Take care,
2027.
team. Yeah, bye, everyone. Okay, bye.
Welcome
Thank
to
you.
Kenya.
Thank you. All right, to all those who are
Okay,
still
Angelo.
on,
Bye. Thank
this
you.
is recorded.
Thank you so much for
Jennifer,
coming.
well done. Dr. Kizza, you've done well. Amazing work. Well done.
Thanks
Hope
so
to
much
see you
for
in Nigeria
joining.
very soon, yeah?
Absolutely. Thank
Yeah,
you for
you must
joining.
come for our hepatopancreatibiliary cancer consultation.
Yes, definitely.
Oh, okay. You're bringing her, right?
Yes, she's going to Zambia. And then we're adding her on the list. It might end up being I'll talk to her on the side. I'll update you. She just came from
So when
Zambia.
is Zambia, you said? When is Zambia?
It's next week. We head out next week on the 19th. The program starts on the 23rd. Yeah.
23rd. You'll be surprised as you see me there,
You know what?
Can do that.
Welcome. We're gonna be
No,
surprised we'll see each other there.
I don't need a visa, I don't need a visa. I think I even have an air ticket.
Oh, well, welcome.
So,
yeah.
And I have 1,001 people that will keep me there. So,
oh my goodness. Yes. Please
yeah, I have accommodations, like I can accommodate people, So.
Oh, you can? Okay, wonderful.
Yeah. Well, let's see how it goes.
Wonderful.
Next week.
All right.
Short time. I would have arranged it really. Yeah.
No, we'll make it. We'll work on it for next time too.
Yeah.
All right. I will stop this.
Yeah. Bye, everyone.
Ciao, ciao. Let's see. All right.
I guess the recording is still on.
Stop. Okay, let me stop the recording now. I think I need to stop share. Stop recording. Thank you guys. Let me pause.